We are live now?
Live now, good to go.
Okay, sir. So, Jagdish sir, it's all yours.
Okay. So, good evening, everybody. And it's pleasure to welcome you all for this third GI meeting. The background of this meeting goes like this, that at HCG Cancer Center, Ahmedabad, we started, I would say, sporadically MDT for our GI cancers. And as I said, sporadically, that we used to interact with our colleagues on case-to-case basis and not in real MDT ways. But we were convinced that this is the way we want to move on. And that's how gradually we started building our team. And honestly, I would admit that for last 3 years, Viraj has joined us as a medical oncologist who is heading our GI medical oncology section, and he is practicing only GI medical oncology. So that has really catapulted the things at our GI unit. And really, we now have a genuine multidisciplinary team approach to almost all of our GI cancers that we are treating at our institute. So besides Viraj in medical oncology, we have Dr. Samir in our radiation oncology, who is looking after our patients of GI cancers. And we have team at radiology and pathology who are also accomplishing this task. So that is the background, that there is a definite momentum now at our institute in dealing with this malignancy in a proper way. And that's how Viraj coined that we should start our GI oncology conference, and then first, second, and this has been the third meeting that we are holding on. And of course, we have in our organizing team, besides Viraj and me, Dr. Ashish Kaushal, Dr. Devendra, and Dr. Samir Batham, who are also part of this organizing team. So COVID changed the way we wanted to do the meeting, and we started talking with our colleagues, and we took opinion of our other senior colleagues, and then we decided that we can do the meeting in a virtual way. And then started talking to people to join us as moderators and panelists. And we are glad to say today that we have a great moderator who are going to discuss 5 various subsites of GI cancers and a great galaxy of the panelists in this. I hope we meet to the expectations of doing a good discussion and able to bring out multiple perspectives. That's what I would always believe, that, you know, we are not trying to find out a single answer to a problem. Probably we would like to discuss the options available in various situations, real life situations where we need to have the answers. And as all of us know now, that there could be more than one answer which is correct. So that's what we would aim at doing. And I once again welcome you all, and thanks all the faculties for this meeting. And I think it's all yours, Viraj. Thank you.
Right, sir. Thank you, sir, very much. So I welcome you all from all of us. So today's meeting, like sir said, we are going to have 2 lecture sessions, after which we are going to have a plethora of surgical discussion. So without wasting any time, I will be talking on HCC immunotherapy role. And then subsequently, I'll have Dr. Ashish Kaushal talk on ramucirumab in GI cancers. So the topic is checkmate in HCC. And for the purpose of this next 10 minutes, I want you all to have this case in background so that we can correlate with the discussion that I'm doing. an elderly male, the garden variety of HCC case that we see day in, day out, 70-year-old HCV positive, AFP in thousands, liver functions slightly altered, but albumin and iron are normal, Child-Pugh score 6, CT scan showing liver lesions as well as extrahepatic disease, performance status strangely very good, and typically these patients are seen by a gastroenterologist, and they are started on sorafenib. It has been standard of care since last 10-15 years. And as the patient has progressed on 3 months, and this is the patient I want you to keep in mind for this session. So we know in HCC we have always surgery as a backbone, surgery or liver transplant. Then we have a local regional therapies like TACE, TARE, and even now radiation coming into SBRT. And we had sorafenib as a targeted therapy for last 15 years. But now we have 3 more targeted therapies approved by FDA, namely regorafenib, lenvatinib, and cabozantinib. And then, of course, we have a very exciting field on immunotherapy in HCC. Liver cancers are all to be immune or hot tumors, and there was always interest in exploring immunotherapy in these patients. Based on that, this was a study, nivolumab in its advanced HCC, and this was a publication in Lancet 3 years ago. And this was a phase 1-2 study where in phase 1, you always check the dose, about 50 patients. And then when you see the efficacy, you go and test on a larger population. So about 250 patients were tested with immunotherapy in advanced HCC. Mind you, they were all HCV infected, HBV infected, and third were non-infected. The classic inclusion criteria, mind you, there were Child-Pugh score 7 also included in this, which are typically excluded from medical oncology trials, but there is some data on Child 7 as well. And you can see the baseline characteristics. About 3/4 of patients had an extrahepatic disease, and everybody progressed on sorafenib. And what I wanted to show here is it was a global trial. There were Asians and there were Europeans, so everybody was included. Now this is an important slide. What it shows is that with immunotherapy, single agent, no other chemo agent, the response rates were ranging between 15 to 20%. That means every 1 out of 5 patients will have a tumor shrinkage more than 25% in your imaging at 2 months, which is very nice considering sorafenib response is just 2 to 4%. And you can, obviously, we don't expect complete responses in these patients, so they were all partial responses. The beauty about this drug, so one may always argue just 20% response, but it's the responses, if you are responding, then you are likely to go for long duration. So what we call is these responses are durable. Like in chemo, when you give chemo, there is a response, but then you immediately progress. But with immunotherapy, if you respond, a big if, then that's the patient which can go on for even years. And these are just the waterfall plots showing whether you are HBV, HCV, or you are uninfected. It doesn't matter. With immunotherapy, you will respond about 1/4 of patients. And this is the spider plot showing the same thing. A wonderful thing about immunotherapy is in second line, just imagine that patient who progressed on sorafenib. Can we tell that at 1 year, there is a 60% chance that you will be alive? Now, we all know that this is not what we see in our country, but with immunotherapy, I think so we are seeing patients going on for years, where the survival was just for few months, just a couple of years ago. So that is an exciting thing. And this is the same thing what I was telling, that if you respond, the patients can go on up to 3 years or even 4 years. The median survival at 27 months for patients who respond. That is amazing. What is another thing important is we know that lack of AFP secretion is a bad prognosis, we all know. But AFP levels again do not correlate with the responses with immunotherapy. So whether you have low, whether you have high, irrespective, immunotherapy will work same. And similarly, If you have hepatitis B, hepatitis C, doesn't matter, they work all the same. Little word of caution, if you give immunotherapy in hepatitis B, about 10% of your patients may see a flare in the DNA viral load. And I would encourage all of these patients to be seen in MDT with a gastroenterologist always to see this hepatitis B treatment. Second question is, PD-L1 is very overly explored in immunotherapy studies, but in HCC, PD-L1 positive or negative does not make any difference. Immunotherapy will work just the same. Safety-wise, we all know immunotherapy safety. It's fairly tolerated. Of course, you're going to see some skin reaction and some liver dysfunction, but by and large, they are tolerated fairly well. So in summary, nivolumab is approved by FDA in HCC once you progressed on a TKI, and the median OS is more than 1.5 years, and response rate ranges from about 20%. So with that, let me thank you all, and this was a talk on immunotherapy. We are not going to take questions on these medical oncology talks. We will take any questions which you type in the chat box during the panel discussion. So now let me invite Dr. Ashish Kaushal. He is the head and director of medical oncology division at HCG Cancer Center, and he's going to talk on ramucirumab in GI cancers. Dr. Ashish Kaushal.
Thank you, Raj. Can I share my screen?
Yes, please.
So on behalf of organizing team, I welcome you all on Friday evening for third mid-year GI oncology meet. And why we're discussing about the gastric cancer, because the gastric cancer is one of the common cancer with the annual incidence of around 75,000 to 1 lakh cases per annum in India. And if you see the outcome of localized gastric cancer has been double in last 2 decades with the improvement of surgical modality. But at the same time, there is a little bit change in the treatment of metastatic cancer before 2 years. And there is an unmet need of plant treatment sequencing in a metastatic or advanced gastric cancer. So whenever we see this advanced gastric cancer patient after the diagnosis, I think the most important thing where we need to see the performance status of the patient. If the patient is in advanced terminal case, I think the best supportive care should be considered. But those patients where the performance is good, I think the patient should be offered a combination treatment. And if the patient is being HER2 positive, I think anti-HER2 therapy with combination chemotherapy should be preferred. If you see for those patients of HER2 negative, the doublet should be preferred over the triplet, and the triplet should be reserved for those patients where the patient is a very young and fit, can tolerate the theater regimen. If you see the outcome of various treatment options compared with the best supportive care, because the best supportive care is give only 2 to 4 months of median overall survival. So now I have various agent in after the first line of the treatment, and out of that, the AIO trial where the irinotecan is compared with the best supportive care, and the median OS is increased from 2.4 months to 4 months with the irinotecan, favors the irinotecan. There are the study of POGAR study where the docetaxel is compared with the best supportive care, and where docetaxel is been superior over 3 months compared to the best supportive care. And there is a combination of docetaxel and irinotecan which shows a median OS of 5.3 months versus 3.4 months with best supportive care, though it's a more toxic regimen. So now we have recently 2 landmark study. One is REGARD and second one is RAINBOW with the ramucirumab. And the REGARD study where the patient has been treated with the first line of the treatment, and the progress has been randomized on the best supportive care versus a single agent ramucirumab. And the ramucirumab single agent in the REGARD study, they showed a median OS of around 5.4 months compared to the 3.4 months, and they favors the ramucirumab alone over the best supportive care. Now we have a rainbow study, and which is also a phase 3 randomized study where the paclitaxel with ramucirumab has been compared with the placebo and paclitaxel. And with this study outcome shows a median OS of 9.6 months versus 7.4 months, favors the combination of ramucirumab and paclitaxel superiority. So with this background, I'm going to present my topic, which was given to me, the crystal ball of the gastric cancer.
If I can interrupt, I think your slides are not moving. So
I'm move now. Yeah, I have not changed. So now this is my title.
All right.
So this is the topic was given to me, the crystal wall of the gastric cancer, the role of the ramucirumab. And I'm going to share the real world evidence on the Sarenza and metastatic gastric cancer. So this is my disclosure. Now it's okay, Viraj?
Yes, sir.
Yeah, now we are seeing it. Yeah. Okay.
So if you look for the data from the real world data from the Asian countries, and this was the original article which was published in the Korean Cancer Study Group, where the efficacy and tolerability of ramucirumab monotherapy or in combination with paclitaxel in advanced gastric cancer as a part of the expanded access program. And in this study, the 265 patients in the ramucirumab expanded access program and 228 sites has been enrolled from June 2015 to December 2015, with a median follow-up of 9.2 months for combination group and 9.6 months for the monotherapy. In the combination arm, the patients are significantly younger and more HER2 positive. We see the outcome of this real-world data. The patient was treated with the ASSESS program. The median PFS with the single-agent ramucirumab is 1.8 months, compared with the combination of ramucirumab paclitaxel is around 3.8 months. And the median OS is 6.4 with the single agent versus the combination of ramucirumab paclitaxel is 8.6 months, which show a clear superiority of the combination with the median PFS rate is 66.9 versus 28.5%. So the combination of ramucirumab and paclitaxel is superior. If you see the overall response rate, the disease control rate in this group of the patient is approximately 66% versus 38% in the single agent ramucirumab, and the overall response rate is around 17% versus 5.4% favors the combination. So similar kind of the ASSESS program was also, the real study data is also available from the European studies, and where the 167 patient and ramucirumab from 25 Italian hospital, they've been enrolled from October 2014 to Feb 2016, with a median follow-up of 11 months. The median age of the patient was 61 years, and around the patient was HER2 positive, and 90% of the patients are treated with a combination, while the 10% of the patient treated with the single agent ramucirumab. We see the patient demography is around 61% patient, 61 is the median age, and around 2/3 of the patients are the male. The most common location of the tumor is the gastric, where around 70% patients the tumor is located at the stomach, and around 25% in the gastroesophageal junction, and 5.4% of the distal esophagus. In around 55% of the patient, they were not underwent surgery because they are unresectable on presentation. This patient of the good performance has been considered, and 90% patients receive a combination of ramucirumab paclitaxel versus 10% patients receive the ramucirumab alone. So coming to the outcome of this patient who was enrolled in a European study, the overall response is around 20%, but the disease control rate is around 60%. If we see the median PFS, it favors the combination of ramucirumab paclitaxel of 4.5 months versus 2.7 with the single agent ramucirumab. We look for the median overall survival with the combination is 8.3 months, favors the combination of ramucirumab with paclitaxel compared to the 4.8 months with single agent ramucirumab. If we compare this data of East and West with the randomized study, in the rainbow study, the median PFS was 4.4 months with the median OS of 9.6 months. And rainbow non-Asian countries, the median OS was 8.5 months. And with this Korean and randomized study, the median OS was 8.6 and 8.3 months. So it's pretty similar outcome, which was there in the randomized rainbow and regard study. I think the similar data has been from the real world data from the East and West. So what we learned from the randomized control study of ramucirumab, that ramucirumab is the first biological agent to achieve the statistical significant survival advantage as a second-line treatment for gastric adenocarcinoma and upper esophageal junction in combination with paclitaxel as well as the monotherapy. The safety profile is and tolerability makes the ramucirumab possible to treat the advanced gastric cancer patient while maintaining their quality of life. And the data from the real one, it taught us that the treatment pattern and the serum effectiveness from the real world studies are consistent with those from the randomized clinical trial that was regards and RAINBOW. And this real world practice allowed us to consider the combination of ramucirumab with paclitaxel is a new standard of care in the second line treatment. So these are the data where the ramucirumab shows advantage in combination as well as the single agent, where the patient cannot fit for the chemotherapy. Now, we all agree that the pan-Asian is adopted the ESMO clinical practice guidelines in the management of advanced gastric cancer. And if you see, whenever the patients are there in our OPD, I think the first of all thing, if the patient is advanced gastric cancer, we need to first look whether the patient's performance status is fit for the chemotherapy or not. Those patients where there is a poor performance 3 or 4, probably they can offer with a supportive treatment. But if the patient is a good performance, we need to think for offering the chemotherapy. And I think the first thing we need to do is the HER2 testing. If the patient is HER2 positive, I think anti-HER2 therapy with combination should be considered. If the patient is HER2 negative, I think the treatment sequencing is the most important thing which should be considered. We need to offer a platinum with 5FU based doublets and triplets only for the patient who can be a very young and fit to tolerate this triplet regimen. And if the patient is in progress after the first line treatment, whether it is with or without trastuzumab, and that the second line, again, we need to look for the patient performance. If the performance is good, we can offer the patient with the second line treatment. And if the performance is not good, I think the best supportive care should be considered. In the performance of PS0 and 1, the combination of paclitaxel ramucirumab with available data of the RAINBOW should be considered. I think that would be the best regimen. And there are other data of using those patients of MSI high, immunotherapy can be considered. If the patient of performance up to, I think ramucirumab monotherapy versus single agent irinotecan and taxane can be considered. And if the MSI is high, I think immunotherapy is preferred modality of the treatment. And if the patient is a poor performance, I think the symptom control or best supportive care should be considered. So with this, I think this is the brief introduction of the ramucirumab and advanced and metastatic gastric cancer. And this is the treatment approach we need to do in our practice. Thank you. Thanks a lot. If there is,
before we start panel, I think so we have some questions from the audience. There's Abhishek from Hyderabad. He is asking what's the role of atezo-bev in first line HCC. So I think so since HCC was my talk, I'll reply. Atezo-bev hands down is the first line therapy choice now all over the world. Unfortunately, Roche has not come up with a patient assistance program in India. And I think so once they come up with patient assistance in India, I think so atezo-bev will be first choice and TKIs will be pushed to the subsequent lines. And the second question that Abhishek asks is, what's the role of nivolumab post lenvatinib? Of course, the data is bleak. It's a single institutional study. But one would assume that post VEGF inhibition IO works. So if it works after sorafenib, it should work after lenvatinib as well. So that is my take on it. Jagdish sir, I think so we have a panel of colon cancer now, and Dr. Saklani is going to join us. I think so he has still not joined us. So he is joining. We have called him. Since we are early by 5 minutes,
you can take more questions, you know, if you have.
Yes, I'm taking that. So nothing on answer.
You have any question in the chat group?
So no, but let me ask you, since since my talk was on HCC, what is your take on ramucirumab in HCC, sir?
So ramucirumab, there are other two indications in GI oncology where it has been there. One is the SCC, if the patient has been progressed on the first line, particularly the AP is more than 400. I think that is the only subset it has been there as approval. So I think if the patient is a candidate for this category, if the patient is progressive post sorafenib with the AP is more than 400, I think that category, this is an option. Though there are other options of regorafenib and cabazantinib, other options are there. I think this is only approved for this indication. And the second thing in a colorectal cancer, I think that is we are going to address in our panel, where this patient who's been initially treated with oxaliplatin and they progress. I think that is the scenario where the ramucirumab with FOLFIRI would be another option, I think, which can be given if the patient is not AMSI high or if the patient is not a candidate for other VEGF blockers. So I think this is an option, but I think as of now, with the available literature, the bevacizumab is our preferred modality with FOLFIRI if the patient is a candidate for VEGF blocker compared to the ramucirumab.
Right, sir. So I think so we are done for the questions right now.
What did Dr. Saklani say?
Yeah, he's joining. So I think so some technical issue with him.
Uh-huh.
He's already on the system.
Oh, okay.
Dr. Viraj, Dr. Shubhadra.
Hello, madam. Good evening.
Good evening. Usually, whatever we have read, the tumors which are very rich in lymphoid population or immune infiltrating cells, there is a good correlation between response to immunotherapy. So you are talking of immunotherapy in HCC. So when we see HCC, usually the inflammatory cell population is not that much. So now we would get more and more cancers who would challenge this concept, right?
Right. So that's why the combo of atezo-bev. So it is known that when you use a VEGF inhibition, the so-called cold tumors or the T regulatory cells are inhibited, and that is why the immunotherapy can act and they can flourish. So that's why all the combo treatments are worked in HCC. So I agree, single agent immunotherapy may be pushed back over the next few years.
Right. Thank you.
So we have all the panelists, but I think so Dr. Saklani is facing some issue, technical issue, joining us.
Normally Saklani is very techie savvy, you know, he never has a problem. He's a master in computers and webinars. Surprising, maybe the whole Mumbai must be shut down, I think, if he has
Agree.
Jagdish bhai, namaskar.
Namaskar, Rao Saib. How are you?
Viraj, good evening.
And
Sir, आ रहे हैं sir? आपका wait हो रहा है.
good to see you, sir.
I should be saying that, sir.
And,
Avnish,
yeah, we are waiting.
coolest consultant I've ever seen in my life. Somsekar has a different opinion. He's very, very tech savvy, but slow, steady, looks lazy, but very, very effective.
and maximum concentration on quality of life.
Everything. Quality of surgery, quality of life.
So, this is the reason that we have this kind of a meeting where we can get all galaxies, and you guys have agreed to oblige us, and that's a fortune that we have today.
See, because there is time, it's becoming time for vote of thanks, sir. Jagdish Bhai. It's a great privilege, to be very honest. But I don't know. I hope people won't be tired of the real long session.
Yeah.
And it's going to be intense also. So that is the only issue. We have never tested by doing it for so long. 3-4 panels and then 2 lectures.
Yeah.
Medical oncology, we are very used to this.
It is a full day congress, like,
Yeah, correct. It's almost like a
surgical stand
conference. Yes, full conference.
But good thing is no talks, and they're all panels, so that keeps it lively.
Avanish has come in. Yeah.
So Jagdish Saklani sir has joined. So
Avnish, welcome. As a penalty, you have to get party for all of us whenever COVID pandemic stops.
Oh my God, where are you sitting, man?
I'm in front of Vidhan Soda, Bangalore.
Oh my God, gone into politics already.
Dr. Saklani, welcome, Dr. Saklani. I think Dr. Saklani doesn't need an introduction. Professor at Tata Memorial Hospital, heading the colorectal department with a lot of thrust onto minimally invasive surgery, laparoscopic surgery, and robotic surgeries, and HIPEC. So 360-degree of the colorectal surgery that he is coordinating at Tata Memorial Hospital. So may I request you, sir, to start the first panel on the colon cancer.
Thank you, sir. Thanks, Viraj, and thank you, Dr. Kothari.
So just wanted to let all the panelists know we have about 200 people watching us right now. And this is the time for next 3 hours. I want the surgical marathon to begin. So let's have a good show.
Great. Thanks, Viraj, and thanks, Dr. Kothari. So we have such eminent people here. I think my panel discussion is going to be on colon cancer. I think we've already introduced the faculty. Let me go to the thing. I think colorectal cancer in India, as we know, is still not in the older population. Median age will be 46. It's poorly differentiated and signature cancer are not common. Locally advanced cancers are common. I think this time we looked at survival for colon cancer, and it looks acceptable, except in poorly differentiated and signature tumors. And even if they have recurrences, if they're done in a proper CME fashion, most of the recurrence seem to be peritoneal rather than loco-regional. I think the first case I'll discuss is the role of CME. There's a 58-year-old gentleman with a lump in the epigastric region. A colonoscopy shows a lesion in the transverse colon. Is CEA 32.49. CT scan shows a lesion in the transverse colon, some pericolic nodes. There are no nodes along the SMB or SMA. So it looks like clinically T3N2M0. So I think coming on to this, I'll come on to the surgeon for Dr. Kothari. It's obviously would go for surgery. So would you have any preference for surgery for this one? Would you like to do laparoscopic, open, robotic?
Yeah, so, the standard extended right hemicolectomy is the surgery which I would plan. And at our place, we try and do more and more this kind of cases also in a minimally invasive fashion. So my option is definitely minimally invasive surgery with, I would say, that extended lymphadenectomy, because you have demonstrated that there are pericolic nodes in this area.
Sure, sir. I think that looks okay. I think we've been doing this same surgery, right hemicolectomy, for a very long time. And some people, Dr. Kothari, would say that you need to clear the nodes along the SMA or SMB I think the idea of complete mesocholic excision seems to be there. But do you think just taking the nodes along the SMB adds a great deal to survival? Or have you seen a lot of loco-regional recurrences when you just did a standard right hemicolectomy?
So honestly, Avnish, it is little bit tailored surgery in every case, in the sense that we look at the CT scan carefully, and we want to make sure that we have done complete lymphadenectomy. Now, getting into the complete CM in every case, I think that's where the decision lies. And if it's not really a very bad mesocolic nodes, and in those cases, I may not go for the real radical D3 dissection, but D2 is what I think we have started aiming in every case. D2 is minimum that we would do, and if possible, we would do the extensive lymphadenectomy is what my answer would be.
Great. I think Dr. Kothari, just I'll come to one more question. So now you have access to everything, and all your patients are also quite affluent. So suppose if you were to give them a choice between laparoscopy, robotic, or open, what do you think actually will benefit the patient, and how do you think? We'll come back to Asit and Nikhil as well, but what do you feel, sir?
So honestly, I have just 4 years of experience of minimally invasive surgery for colorectal cancer, but the way patients have started recovering after this kind of surgery, that is number one. And we are very comfortable now doing this surgery oncologically. So our preference has more and more tilted to minimally invasive surgery, even for challenging cases that we are doing. So I would say that, if cost is not the constraint, then we would end up doing at least 80% of our colorectal resections doing in a minimally invasive way. The choice between the two, laparoscopy. So I don't do laparoscopy. So for me, it's only robotic, but I have excellent team who does laparoscopically also with the same skills. And that is also a definite option for these patients.
Right. I think MI has a definite advantage in terms of smaller incision and less pain. So let me come to Dr. Nikhil Agarwal from Delhi. Nikhil, what would your approach be?
Is Nikhil there? I think he left by accident, I believe.
Okay, is Asit there?
No, I'm there. Yeah, I'm here.
Okay, hi Nikhil.
Yeah, please. Hi.
So Nikhil, so this is the right disease of the right colon, and looks like a localized disease. So the plan is to go for a right hemicolectomy. So we are just taking a preference of surgeons. Whether would you like to do it open, laparoscopy, robotic? What is your preference?
So laparoscopic is something which we routinely do, and this is our preference.
Right. And when you do laparoscopy or something, do you do extracorporeal anastomosis or do you do intracorporeal anastomosis?
So mostly I would prefer to do an intracorporeal anastomosis, but sometimes we end up doing extracorporeal because doing intracorporeal anastomosis is slightly more expensive, right? So if cost issues are not there, then I would do an intracorporeal anastomosis.
Okay, that's good. Dr. Asit, what do you feel? Is he here?
Yeah, I'm here. Yeah, very much. So, Dr. Saklani, I think I would. Hi, how are you? So, my preference is exactly the way Nikhil has described. So, in my unit, we do most of the colorectal work laparoscopically, and that's our go-to technique. And if cost is not an issue, most of the anastomosis are done intracorporeally. And also the part that you asked initially about the extent of lymphadenectomy. Yeah. So we routinely perform D2 lymphadenectomy in these cases. D3 is not what we actually aim at, but especially for this tumor, that is a mid-transverse colon tumor, I think we should also emphasize on the point that we have to remove the level 6 nodes here. So we need to clear the right gastroepiploic nodes. So that's an important technical point that we have to consider in these patients. And that makes this procedure a little more challenging and more demanding than a routine right hemicolon.
Right, right. May I agree with you? Hohenberger's original operation did say for hepatic flexure tumors you need to take gastro-epiploic node, but I'm not sure many people would agree. Dr. Kothari, would you do that for hepatic flexure thing, whether taking the nodes of the gastro-epiploic or?
So not as a routine procedure, except that I said that, if you really find on your imaging that this is the node that you need to clear. Otherwise, honestly, not. But I think Asit is making the right point that we should consider taking this out.
That's right. I think that should be good. I think Asit, just coming to this, okay, I think if you have do you have an enhanced recovery program in your hospital where patients are mobilized and pre-op things are giving? So do you think if you have an enhanced recovery program, then is there any difference between the MIS approach and open approach, or just as a thought, just as a sort of thing? Because sometimes
no, we don't have, we are not enrolled for an enhanced recovery program, but this is something which is very high on our wish to do list, and we would love to start doing an enhanced recovery program for all our MIS cases. We know some of the centers are routinely doing it. I believe even you guys are following that, if I'm not wrong. But at present, we have no structured enhanced recovery program. But yes, I do believe it will definitely add on to the overall recovery, and it does shorten the length of the hospital stay. Absolutely, it does.
So Nikhil, I'll come back to you again. So I know the Max had a lot of workload of COVID and the number of beds were restricted. So actually this was the right time to start enhanced recovery. So we started doing it here, and because we didn't have any beds, we had to send them on day 1 and day 2. So what is your experience? Have you ever tried out the 24-hour discharge or 48-hour discharge or enhanced recovery?
No.
I know it's difficult in corporate practice, but
yeah, but like we generally, like as Asit told you, we don't have a structured enhanced recovery program. Despite that, like we tend to follow the enhanced recovery program. All the components of that program we generally follow. So we'll not put in Riles tube. We'll take it out just after completion of case. We'll put drain selectively, and we'll start orally the very next day. But generally, generally our patients are a little conservative. And second thing is that a very important component of an enhanced recovery and discharge program is that community support. So we don't have that, right? So the end result is that despite when we feel that, this patient can go on for POD3 or POD4, we end up keeping most of our patients till POD5 or POD4. So that's a challenge which I think we'll face.
Yeah, I think because of this COVID, I think all of us will have to start enhanced recovery program. So that's a great insight. Anyway, he underwent a lap extended hemicolectomy. There were 24 lymph nodes and 2 disease. So let me come to the medical oncologist, Dr. Mudashir. Are you there?
Yeah, sir. I am here, sir.
Hi, Mudashir. So now it is N2, T3, N2 disease. I know there's a lot of thing, whether 3 months of chemotherapy or 6 months of chemotherapy. So what would you advocate? Because I know there's a lot of controversy amongst the medical oncologists, but
yeah, sir. So this is probably a dynamic issue right now. Lots of studies are going on, and some of the results have been out. It is still a mixed bag. Like MSI, to do MSI to see whether MSI high or MSI low, to give whether only 5FU or to use the combination of oxaliplatin. High risk features. This patient, there is the only high risk feature is probably the N2 disease. Margins are free, no obstruction. I think we in this patient who is stage 3 and with N2 disease and T3 disease, completely resected, margin free, no other high risk factors. The benefit of adding 3 more months after the initial 3 months would be very little. Probably 2% in the latest,
that's right.
area. So whether we would like to go for 6 months or not, is a big question.
I know. My medical oncologist would not agree with that, but anyway, that's the evidence. Mansi, what do you think? What would you do?
Like Dr. Mudashir said, this is stage 3 disease and high risk features. I generally tend to give 6 months FOLFOX if there is N2 or C4 or above. N2 or above and C4. So
And
I
what
would go for 6 months of FOLFOX because the absolute benefit is 2.1%, like Dr. Mudassir said, for the high risk group. For the low risk groups, yes, I would discuss with the patient, debate about 3 months KPOX versus 6 months FOLFOX. But for this patient, I would definitely go for 6 months.
So would you go for FOLFOX or KPOX? Because there seems to be more advantage for KPOX, I think, in the idea thing. So
the advantage for KPOX is for in the 3 month group because we are also reducing the oxaliplatin frequency and so it's in the 3 month group. For 6 months, I do tend to go for FOLFOX. Now in the current COVID scenario, again, it's KPOX over FOLFOX for 6 months also.
I think all of you are right, actually. So we'll come back to that and we'll have a look at that. So I think laparoscopy can open a comparable oncological outcome. There is study from cost, color, and classic, and there is hardly any controversy. Good short-term benefits or long-term outcomes are similar. For D3 resection, we take the notes along with SME. I think this was the initial study from Mohanberg, which said cancer-specific survival improved by about 7% and the local recurrence decreased. Obviously, there was a 2 different time period that they compared. The JCOG has compared laparoscopic versus open CME and they found it to be safe. They didn't find any vascular injuries. So if you're experienced, that can be done. This was the IDEA trial, a consortium of 6 trials looking at the benefit of adjuvant chemotherapy. And it looks like for low risk cancers, initially they said 3 months was non-inferior to that and KPOX was better. For T4N2, they recommended that probably 6 months would be better. But the recent thing in ASCO with 5-year follow-up, that's actually like what Mudassir said, there's not much difference and degree of benefit is of additional 3 months is only 1 to 2%. So I think you'll have to look at your own results and see how things go. So I think let's go to the second case. Again, we'll come back to the surgeons. So this is a young chap, 32-year-old gentleman, which has got some familial history of cancer, altered bowel habit. He's got a big lump in the right flank, looks like a ascending colon going to the hepatic flexure T3N1. I think we have already discussed he's going to require a right hemicolectomy. So Dr. Kothari, should I come back to you? So now this is a young gentleman, not confirmed colony, but he's got some family history. So it may be a Lynch syndrome or HNPCC. So when you go on surgery for this month, so would you like to do right hemicolectomy itself or an extended right or subtotal colectomy for Lynch? What would you like to do?
Yeah, so I think we are still evolving our surgical strategies for these kind of situations, and a couple of more informations which I need. What is the status of polyps in his rest of the colon? That is number 1.
Sure.
And number 2 is, as you have shown here, he's a pretty young man. So, I mean, boy. So, if there are definite obvious polyps, I would tend to do a radical surgery of subtotal colectomy. I have bias of preserving rectum for sure, and increasing bias in preserving rectum, at least to give them a good quality of life. At the same time, the debate, it is so important. Actually, just recently, I operated upon a father who is a doctor and the son is a pediatrician, and same situation, and they were absolutely adamant that they do not want to have the complete colectomy done. So, this kind of counseling is also very, very important, and we have to tailor-made the treatment on these patients. I think that's what my answer is.
I think great. I think then awareness is the most important thing. If you're young colorectal cancer, I think what you said, counseling patients on what can be done is there. Nikhil, what would you do?
So, see, the standard of surgery in Lynch syndrome was subtotal colectomy.
He's not a documented Lynch. He's only a young thing, which could be Lynch.
Correct.
It's one family history. So he doesn't have history to one thing. Yeah.
Yeah, one thing is that we can evaluate him for Lynch, right? But having said that, the consensus now has moved towards organ preservation. And we also follow the same approach. We would rather do a right hemicolectomy in these patients and watch them like a hawk for any other tumor in the colon.
Okay, Asit, what would you do?
Yeah, so my approach would be a little different here. So in such scenarios, we would involve our geneticist for sure in these patients. We would like to establish the diagnosis of Lynch first in these patients. That will be done by establishing a proper family history by the age at which his father got the disease and what disease he exactly had. Then you have to look at the histology, whether there are any HNPCC related signs in the histology, whether there is a lymphocytic infiltrate or it shows Crohn's-like feature or it is a high MSI disease. If it shows that, then we would like to prove it by getting a germline mutation testing done in these patients. And this whole workup is supervised by a geneticist. Once you prove that this boy has a Lynch, then obviously, like Nikhil said, even if you prove it, there is a tendency towards preservation of the organ. So we still go for a right hemicol with a very high follow-up at 6-monthly follow-up and do a colonoscopy at yearly interval. These patients are not just at the high possibility of developing a recurrence in the residual colon, that is about 25%. They also have a higher risk of developing recurrence in the residual rectum, that is about 8%. And then all extra intestinal diseases like periampullary carcinomas or renal cell carcinoma, ureteric cancers. So it's very important that we establish this diagnosis and then these patients are followed up diligently for all other malignancies as well.
Great, Asit, you did a great evaluation. You got a thing and you got all this genetic testing done, but by the time this patient has gone to a neighboring hospital, just joking, man. But the problem is
he won't. That problem is not with TMH. That problem is definitely there with us. But then at TMH, I believe patients don't leave you guys.
I know. No, but problem most of these times it takes a long time for us. So normally we make a decision and operate, and then we come back to it. So I think most probably either subtotal or right hemicrectomy, we are both not wrong. Just as soon as the patient knows that he has to come for surveillance. So that we have done, he underwent a lap right hemicolectomy because I think we didn't have significant stage was T2M0. He was MSI high, was referred to a cancer genetic clinic. And our policy is to normally do a lower GI endoscopy at 1 year until they come back at MSI high. And you already said there are also other factors to look for in HNPCC. We won't discuss that here. The pros and cons of segmental colectomy, we know if you do a segmental colectomy, there's a 25% chance they will have a tumor in other part of the colon. They can fuse the endometrium and other things as well. But on the other whole, they can have functional problems of diarrhea, and also we have already discussed all those things. But actually, whether you operate on them, will it improve survival? So there's a study from Omar Fayez where and the other group which showed actually there's no difference in cancer-specific survival. So there are 4 times likely to develop metachronous cancers, but survival is the same. But this is where you have good surveillance policies and patients don't default. So in our setup, depending on how the patient is and he agrees, probably you could do it at the same time. Okay, so that's the one thing we talked about. So suppose if this patient was about 60 and it was a Lynch syndrome or something detected, and he says, what surveillance strategy would you have for his children? So Dr. Kothari, what would you recommend? So he says, okay, I've got a genetic history. When should my children have surveillance scopies?
So we generally recommend it at starting at the age of 25, and we obviously, as it was told by the previous panelists, that we would always engage the geneticist, and they will map out and find out the youngest family member who has suffered from this colorectal cancer, and that will also guide us in starting age. You know, if somebody has suffered at the age of 20, then probably we will recommend at the age of 15, at least 5 years earlier than the youngest guy. So I think that's what the answer is, and how frequently we do it, it depending upon what you have picked up on this colonoscopy. If you have picked up something which is really bothering you, then next colonoscopy is after 6 months, or else it is after 1 year.
Sure. I mean, I think the European Society says If you have different type of mutation, you can have different screening things every 2 years or so. But I think all of us realize we need a geneticist in a big center to make sure we follow them up. That is the best way. You cannot have screening for the population, but you screen high risk population and you can save lives. And a good high colonoscopy is essential. Coming back to, I think the next one is the multivisible resection in colon cancer. And I'll come back to the medical oncologist after this case. So 32-year-old gentleman, again, vague lump in the right flank. CE is 0.67. It's a low GI endoscopy. There's a growth near the hepatic flexure. It also involves the duodenum as well. So you can see that there's a large bulky mass hepatic flexure infiltrating the duodenum. Touching the IVC, but that seems to be free. Major vessels are free. Anterior aorta is okay. So let me come to Nikhil. So what do you want to do for this one?
Yeah, so it's a colon cancer which has gone into duodenum, and looking at the CT images, it looks like it would require a Whipple. Now, my approach would be depending on the possibility of a R0 resection, right? So if I think that this imaging, say portal vein, IVCs, even SMA, and all these things, if I can get a clear-cut R0 resection,
everything is free. Everything is free. So
yeah. So then I would resect, right? And like even if it requires a Whipple or multivisceral resection along with it, I'll just go ahead and do it. But if I have a doubt on imaging that, I might not get a clear margin at any place, then I would prefer to give them a neoadjuvant downstage and then do the resection.
Okay, Ashit, what would you do? Would you want to give the neoadjuvant chemotherapy for this one? No.
Yeah, so I'll base my decision on the fact whether how the patient's general condition is, and secondly whether the disease is symptomatic or asymptomatic. For if he's bleeding and his hemoglobin is falling rapidly, then I would have no option but to go in. But if his general condition is not so great, and the disease is not very symptomatic, and if it gives me an opportunity to treat him systemically first, followed by colovipples, that would be my
let's find out from the medical
Dr. Saklani, sorry. We have Dr. Bharat Prajapati also. He's a surgeon.
Sorry.
He's also on the panel.
Okay, Bharat, what would you do? Actually, sorry, Bharat, I will not have I did not send it to you.
Hello, sir. No problem.
Hi, Bharat. Good to see you.
Yes, sir. Sir, if a patient is having aggressive nodal disease, then there are chances of systemic failure. There are high chances of systemic failure. So, in this case scenario, only we would go for the neoadjuvant chemotherapy. Else, if nodal disease is not aggressive, then we'll upfront go for colovipples.
Great. But for this one, in most of these colon cancer having Whipple, the duct is not dilated. The pancreas is very soft. So the complications of standard Whipples are quite high. Pancreatic fistula rates are high. So he may not have actually adjuvant chemotherapy. So maybe you are not wrong. Dr. Kothari, what do you think?
So, Dr. Saklani, the way we would deal with this situation is a definite indication of neoadjuvant. If I have, doubtful involvement of the pancreas by the hepatic flexure colon, I would certainly give, because by doing this, my R0 resection rate would improve. If there is a definite infiltration, probably other criteria will also justify, and I would probably straight away go ahead for the surgery. The reason for my bias for surgery is that these patients may not be able to tolerate my chemotherapy well, and only chance if he has is a surgery is the only chance for the cure if he is not going to be tolerating. So it's going to be really a case-based selection, and I am open with either of these two depending upon what we are dealing with.
That's right. I think we have to realize about treatment-related failure, whichever arm you put in. It's a great one. Let's find out from medical oncologist. Mansi, what would you do? Would you like to give chemotherapy, or do you want the surgeons to go ahead with surgery? Or Mansi, are you there? Or Dr. Mudashir?
Yes, I'm here.
Okay, go on.
So yes, so it would depend on how confident our surgeon is in assuring an R0. So if an R0 is possible, we would go for upfront surgery for sure.
Great. Mudashir, are you happy with this?
I am happy with this. So if this patient has a lot of disease which is growing out. I don't know how this patient was having obstructive features, at the same time or not. So obviously you will decide as a surgeon, if the surgeon decides that, surgery is to be done, I think that is the best course. But if there is any, question about surgery or margins or, things, then we may, give neoadjuvant therapy.
Okay, great. So I think...
Viraj, can I comment, sir?
Yep.
Yeah, of course. Go on.
Right. So after the Foxtrot study, in fact, any patient of the flexure, if we have any doubt, we go for neoadjuvant at our institute, and we do not perform heroic surgeries upfront.
Right. Okay. I mean, there are no right and wrong things, but that we agree. We do half and half. So
there are evidence now supporting preoperative therapy in colon as well now.
Okay.
So that means you listen to the surgeon, isn't it? The surgeon should say that there is a question.
My surgeon is right above you.
Depends who's the stronger one. Anyway, for this chap, he looked frail. His staging laparoscopy was non-metastatic. Actually, he's the same chap. He had HNPCC. He had a sigmoid colon done about 4 years back. He dropped out of surveillance program and he came with a second primary. So now you got both the scenario, missed HNPCC and is come with this now. So obviously you can't play around with him. You have to look at him. So what we do a staging laparoscopy to make sure he's not metastatic. We admit him for optimization, nutritional rehab, and then he underwent a colorectal procedure. We could sort of preserve the left colic, and we were able to save it. We do a pancreatic gastrostomy because of this. The chances of complications are less with soft pancreas, but that is just me. He has a small subclinical leak, but he's doing well. The multivisible resection, I think we should be going ahead. 5-year survival pretty good, 52.8%. We looked at propensity case map from our institution, and with multivisible resection of standard colon, there's not much difference. There's another multivisible resection, large lesion of splenic flexure, signet ring tumor, young chap. So there's the lesion in the splenic flexure, which seems to be touching the spleen and the tail of pancreas. So it will require. Bharat, should I come to you? What do you want to do?
Yes,
So the lesion in the splenic flexure is the tail of the pancreas, spleen, and abdominal wall.
Yes, sir. If it is infiltrating the tail pancreas, definitely we need to go for the left segmental colectomy with distal pancreatosplenectomy.
That's great. That's great. Would you want to do? I think most of us would do it open. Do you think, suppose now you got the robotic system and with MIS, do you think you can try MIS for this one?
Yeah, yes, sir. Definitely, I would like to go for the laparoscopic approach. Today only we have completed one laparoscopic distal pancreatectomy, preserving spleen. So we would like to go for laparoscopic approach.
That's good. But earlier on, you would think there's not much evidence for T4 cancer, which is there. Most of the cost classic was a standard thing. But with increased techniques and technology, I think you can do it as well. Let me take opinion from Asit. Would you be okay? Do you want to do open or MIS? I mean, both of them are okay. There's no right or wrong. There's no law.
Yes. Yeah. So the thing is, obviously, the approach would be to attempt laparoscopic resection in this. So we don't do robotic at our center. All of our colonic surgeries are done laparoscopically. So we would definitely attempt a laparoscopic resection in this. I would keep a low threshold of conversion. I won't say converting to open, there is any shame in that. It's just a due course of time. If you feel you're not progressing well enough, I'm happy to convert it. But I feel with the kind of expertise that most of us are having nowadays, and stalwarts like you showing the leading the way, I think more and more comfort level is there to attempt such aggressive resections laparoscopically.
Great. Dr. Kothari, sometimes what do you feel?
So I think same way, if you have a team, this kind of surgeries would require a proper team as well. And if it's a small lesion and I'm comfortable, I would definitely try. But if it is a bulky disease and it's going to take away a lot of time and struggle, as Asit said, that low threshold for conversion. That's what my approach would be. Yeah.
Great. I think we can do that. So I think he underwent a lab hemicolectomy with splenectomy, and that was okay. T4N2, he was discharged and he's on adjuvant chemotherapy. So I think the Japanese have always been on front, and they have got a long-term follow-up of this as well for limited group of patients, but 5-year cancer-specific survival and overall survival of okay. I think as you gain experience, you can do it, but not everyone needs to do it. So let's look for role of neoadjuvant chemotherapy. I think already go on, sir.
So, I think on this neoadjuvant only, I just wanted to make a little difference in terms of how I'm handling the right-sided colon versus left-sided colon for the neoadjuvant treatment, advanced cases as well. As all of us know that left-sided colon, there are risk of getting obstruction. And if I have started my patients on neoadjuvant treatment, and if this gentleman gets into an obstruction, this is a real life scenario where, I have a neutropenia and platelets are low. And on those situations, if I'm asked to do a resection or a stoma, the chances of morbidity and mortality risk is really, really very high. So in the interest of, for the young colleagues, it's very, very important to decide and make sure that your left-sided colon, if you want to give neoadjuvant, it's not obstructed or not a very, very bulky disease.
That's right. I think the experience is the most important thing, and you have to do the most to save the patients. I agree with you totally, sir. So this one is a difficult one because it is not very resectable. There's a mass in the right iliac fossa. CE is 29. So the mass is infiltrating the psoas. It is also infiltrating the right ureter and causing hydronephrosis. So T4BN1. So Nikhil, what do you think?
Yeah, I think this is a case which would require neoadjuvant, right? I mean, the possibility of an R0 resection would be not very high here, resecting the part of psoas, and it's a bulky disease. So we can give neoadjuvant. We can also do upfront also if the patient is very fit, right? So there isn't much data to compare neoadjuvant versus direct upfront surgery approach, but maybe neoadjuvant would be a sensible approach here.
Sure. Bharat, what would you think? Chemo or surgery?
Sir, seeing at the scan, we can get away with the deep margin with the psoas muscle stripping, and anyway we need to sacrifice the ureter and ureteric or interposition graft for the ureter. So we can go with upfront surgery also.
Oh, that's great. I mean, I've never seen a bowel being interposed for the ureter, but I'm looking forward to this case. We have not operated. I don't know. Has anyone done any case where they resected the mid ureter and put an ileal interposition?
Cross ureterostomy can be done also.
Right. And most people don't want to do. Okay, good. That's good. That's interesting. So we are thinking about surgery for maybe 4 cycles of chemotherapy. I think that Foxtrot over there, it showed that people tolerated chemotherapy quite well. Post-operative complications weren't very high. Foxtrot, for all these locally advanced cancer, they gave 6 cycles of oxaliplatin, Folfox, and this. But the primary endpoint was 2-year DFS, and there was no difference between giving neoadjuvant chemo versus there. But all the other factors favored chemotherapy. That tumor regression came down, nodal staging was less. There was no difference in complication rate. And R1 resections were also significantly less if you give neoadjuvant chemotherapy. But the primary endpoint of the study was 2-year relapse-free survival, and that wasn't significant. So at present, Diane Morton is quite for it, but so far it is still not the standard of care. But you can look at it both ways. So all of us are right or wrong, but we have to see. We have to see how many patients, and the thing, not many people progressed. Okay, let's come into the medical oncologist. I think surgeons can have a bit of rest now. So I think 57-year-old gentleman has abdominal pain and melena, HB 7.9. He got a CT scan. He's come with a lot of hope, and this is showing bilobal liver metastasis, CA right colon T4N1. Mansi, how will you approach this patient? The surgeon has suddenly lost interest, and he said, "Oh my God, this probably needs to go to Mansi." What would you advise this patient?
So, can I just see? I mean, the other metastatic workup besides liver, are there any other?
No, it's only liver limited, bilobal liver limited metastatic disease, and with some melena and anemia.
The performance status of the patient, may I know?
Performance status is fit. He's fit for surgery. He's walking around. He doesn't know he's with bilobal.
No, of course, I would not. I'm not asking the PS for surgery here.
No, he can tolerate chemo very well. He is a very affording patient as well.
Okay. No, so because bilobal surgery, I would have pushed him for probably chemotherapy and try to give him aggressive chemotherapy as a conversion chemotherapy so that we can at least bring down the number of mets and reduce the burden. The performance status and the LFT would guide me whether I would give a triplet-based chemo, FOLFOX-CD, or would I give FOLFOX. So I would definitely counsel them for an attempt for downstaging the disease with FOLFOX-CD if he tolerates.
Sure. Would you like to do the normal panel for the RAS, RAF, or MSI?
So we would get the information and keep it handy. But if I'm planning to convert the patient to a surgery, for a surgical resection,
sure,
I would hold it for now. I would rather give a triplet-based chemo instead of chemo with targeted. But yes, there are a lot of people who would even give targeted with FOLFOX, and they may not be wrong.
That's right, Mansi. You're absolutely right. Mudassir, Dr. Mudassir, what would you do?
Yeah, I agree. Actually, in this case, we have to keep in mind that, we'd start with chemotherapy, and then if the patient, gets converted, then well and good. Part of the liver may be managed with your surgery, and part of it may be with some local techniques. And the chemotherapy, will depend upon the sidedness, whether, maybe the RAS-RAF, RAS-RAF, as well as the MSI, status. But mostly, as Dr. Mansi said, that the addition of targeted therapy in this is probably questionable. Even bevacizumab, it may increase the morbidity. I don't know, sir, what is the experience at your center? But we should give the chemotherapy after a maximum of about 4 to 6 weeks, or 6 to 8 weeks, or 12 weeks maximum.
Sure,
and during that time, we will have to skip probably last 2 cycles of, or at least last 1 cycle of bevacizumab, and how many cycles he will ultimately take. Then regarding the the EGFR antibody, the problem with that is that there's a controversial data in the neoadjuvant setting.
Sure. Suppose instead of this looks for you, this looks unresectable, and suppose if you consider this potentially resectable, then what? I know these are the symptomatic by the ESMO guidelines. You would give this only chemotherapy. But suppose if you think you wanted to convert this patient, so it's a right colon cancer, bilobal liver mets, RAS wild type, what would you give based on the sidedness and this? No BRAF mutant, only RAS wild type.
Yeah, I would like to know about the liver status as well. Parenchyma of the liver. Is there any chronic disease or not? If the patient is if the liver is otherwise fit. If the liver is otherwise fit, then we would like to go for either FOLFOX or FOLFOX-CD. I would not add any targeted therapy in this setting.
Okay, but even if you were considering a potentially resectable, would you add biological? Or?
Targeted therapy may be added. I would add maximum of bevacizumab, probably within for a few cycles. Bevacizumab may be added. But
okay, Mansi, if it was a left-sided tumor and you think it's potentially resectable, what would you do? I know.
In left-sided tumor, and if it was wild type, there is a controversy where after cetuximab or panitumumab, there would be better responses, but then have been using folfoxiri, but I've seen a lot of good responses, and the tolerance is also not as bad as we were, thinking theoretically how it would be. Practically, a lot of patients are tolerating folfoxiri much better.
Okay.
So I would still go for folfoxiri. I would still not add targeted, even if it was left side.
This is Dr. Dipanjan. Can I just have a point?
Yeah, of course, sir. Please.
Yeah, so I think I heard Mudassir and Dr. Mansi also. I really don't understand. I think this the liver, at least in this cut section, seems to be okay. There is no cirrhotic feature, and as far as TRIBE 2 data is concerned, we can consider folfoxiri with bevacizumab. There is no particular contraindication against that. Of course, triplet chemotherapy per se is also good, and people always say whether it's the chemo or the targeted therapy. And secondly, I think there is a study called ATOM study, which has shown that in left-sided cancer, the cetuximab can have a good depth of response, and the resectability increases. So in left-sided cancer, if you are wanting to conversion, I think cetuximab for the right patient is an option. And this case, I think a triplet with biologic is not contraindicated. Actually, it can be not.
Okay. I think that's a good one. We can go on for 1 hour for this, but I think as long as you know, I think at TMH only 6% of the patient with bilobar liver mets receive biological. It will be more in obviously in the corporate sector, but the thing seems to be changing. So okay. But anyway, he was symptomatic and anemic, and so he underwent surgery, capox and assessment, like what Mansi already said. For a symptomatic patient, and resection is not an option. You just have to control the disease and prolong survival. But normally, for all, if you're going to think of biological, you would always get for molecular testing. That is standard. Conversion therapy is there. They said if you give only standard chemotherapy, conversion rate may be 15%. It depends on the surgeon. So let me come back to Nikhil. Nikhil, I'm not sure. I don't do liver resections. I don't know if Nikhil and Asid do it.
Yeah, we are very happy to do liver resections. That's what we do all the time.
Good. So what do you think for potentially resectable one? If you give only chemotherapy or biological, what is the conversion rate in your institute? What would you think?
Yeah, so generally, we would prefer to add biologicals in the beginning, right? And we make sure that we take off biological a little early. So like say if we are planning for 4 cycles, we'll give biological for 3 cycles, and last cycle will not give biologicals, right? And we find a little more conversion rates with biologicals. But then like this kind of liver, right? This is an unresectable liver. So we will not target downstaging or conversion therapy in this. This is a totally non-resectable patient, but we have to be very, very sure with imaging that we will be able to, resect these patients. So even multiple lesions is not a contraindication. We can RFA some lesions, we can resect some of them, we can downstage, we can do a lot of strategies are there to, preserve the liver and do all sort of things. But then a preoperative imaging is very important, and yes, biologicals I would like to prefer to add a biological.
Nikhil, how often do you evaluate this patient with bilobar liver mets? So do you evaluate them?
I just missed your question. Yeah.
So how often do you evaluate the patient? So if you're going to keep them on chemotherapy, would you see them after 6 cycles, every 2 months, or sometimes people forget and they just give chemotherapy and they come back after 6 months, and then it is too late for you to operate sometimes?
Yeah, so generally after 4 cycles.
About 4 cycles. So I think every 2 months mostly you should see the liver. If you give more chemotherapy, there are complications for surgeons. This is another one, sigmoid tumor.
We have the last 3 minutes to end this.
Sure. Definitely. Okay, we'll see. So this is a bilobar liver met, but it looks sort of a resectable sort of thing. Limited liver lesions, primary lesion in the sigmoid colon. So what would you do? Would you want to give them, let me ask Nikhil, would you want to give them chemotherapy? I'll go back again.
So most of our liver lesions, we will first give them. So we use the liver first approach. So we'll first give them chemotherapy, reassess, and we will prefer to do the liver first, and then again some cycles of chemo, and then the colon or rectum.
Okay, so I think we can do that. We gave them chemotherapy, coiled the lesion, 4 cycles capox, and the lesions look resectable, and then underwent a left hepatectomy with sigmoid colectomy resection. We have already talked about side-edness, rough impact. So suppose if the lesion was resectable and had, so would you give any biological, Dr. Mudassir? So suppose this looked like resectable liver met. So would you just give chemotherapy or would you add some biological as well?
We can add, there is good data available that we can give chemotherapy plus biological, whether to use bevacizumab or cetuximab. For the cetuximab, the data is, yes, there is some very good data because of the depth of response, because of the the degree of response. So that is there. So for cetuximab, but chemotherapy with a triple agent can also be tried, or triple agent with bevacizumab, as Dr. Dipanjan Panda just said, that can also be tried. So there are various combinations, probably, seeing the patient as well as, whatever maximum we can give to the patient should be tried to get the maximum possible effect.
Sure. So Mansi, if you have an isolated...
Sorry, can I just...
Yeah, go on.
If I'm not wrong, Dr. Saklani, you said a patient who is resectable upfront, use of biological in those patients, if I'm not wrong.
Yeah.
Right. I don't think use of biologicals would be a great idea in these patients.
I know. I mean, that's why I put out the new EPOC trial. So normally you would think if
I don't know. I mean, we can ask.
Okay, I think if it's resectable liver met, probably just go ahead with surgery. You may want to give chemo, but no biological, because outcomes for new not good with the new EPOC. So, okay, I think we are probably running out of time, or let us see. What do you think, Viraj? Are we done?
Yeah, I think so. We are done, sir. A couple of questions which have come for colon panel. We still have 3 minutes, so I want either you or panelists to take these questions.
No, I think the panel can take it, and I'll just log out of my screen and then we'll see.
Right.
Okay.
So the one question is again on the foxtrot. So in this COVID era, if you have patient coming in and they are reluctant, even the operable patient, P3 in those hospitalizations, if they are reluctant for operation, how comfortable are you to going ahead with neoadjuvant chemotherapy based on foxtrot studies, knowing that it is not non-inferior? Like, it is non-inferior. So, Dr. Asid and Dr. Nikhil, what would you do in your practice? If patient says Delhi has a lot of COVID, we don't want operation now, can we go on chemo right now and you operate us on later date?
Yeah, so I would say if patient is specifically asking for it, then yes, this is one option which can be explored. And now with the foxtrot there, we are much more happy to explore that option. But in my personal experience, I must tell you that during this COVID and we being in the deep of the blue sea, being in Delhi and practicing in Max, which was the hot seat of COVID, we have still managed to, our SOPs was such that we still have managed to operate all these patients. We have done more than 350 surgeries during these last 3.5 months. And somehow we have had infrastructure in place. We managed to keep our OTs and our ICUs completely segregated of COVID. So we did not change our practice a bit. We offered them surgeries just like we would have done in non-COVID times. We were fortunate that way, but yes, your question is very valid. If a patient has a apprehension that he doesn't want surgery in COVID era, I'll be more than happy to offer her or him chemotherapy and maybe surgery at a later date.
Right. So Dr. Nikhil, do you agree, or do you have any other things, or do you also accept?
No, so we adopt the same policy. We are from the same center, so we have the same policy, same outcome, and I don't have much to add there.
Right. The second question is on metastatic disease. It's again upfront surgery versus peri-op chemo, the standard questions that we always get. A solitary liver met synchronous disease, what is the panel's opinion of upfront surgery versus peri-operative therapy? So one could answer it in a molecular or a sidedness. So Dr. Nikhil, what would you do? Synchronous solitary liver met.
So synchronous solitary, then it all depends on how big the lesion is. So if it's a small solitary metastasis, which can be tackled laparoscopically at the same time as colon resection, then I would like to resect in the first go, right? But if it requires a major liver resection where we have to do it in 2 settings, so liver separate and and a colon separate. So, I mean, there is data there also, like we generally do not do liver resection with rectal cancer, and we do not generally combine a major liver resection with a colectomy, right? So if this is one of those patients, then I would prefer to give these patients neoadjuvant and go for the liver first approach, which means chemotherapy, liver, chemotherapy, and then colon.
So, Dr. Saklani, if I may ask, do you use FUM score in your practice before deciding this is high risk oligomet or this is low risk oligomet, and then decide surgery versus peri-op?
I think for me, everything is low risk because I sent it to my colleague, Dr. Mahesh Goyal. Just joking. Okay. So I think they're quite sensible. I think most people would want to take it upfront without chemotherapy. I think we have to look at facilities of a place. You may be a good surgeon, but if the intensive care is struggling a bit and they end up with more of liver complications, especially.
Let's say this patient is CE of 1000, but solitary liver met.
Then the decision would be taken with us. Then we would definitely consult our medical oncologist and probably give for chemotherapy. Dr. Dipanjan, I'm sorry, I didn't realize you were here. You were not there on my list and I don't have a screen. Please accept my apologies.
So Dr. Dipanjan, if I can ask you, CA 1000 solitary liver met, would you go for chemo or have surgeon take it out?
I will discuss this with my surgeon. So I never take these decisions alone. If the CA is very high, most probably it's an aggressive biology. So the pitfall of doing an upfront surgery is that after doing a major surgery, you might end up seeing 3 or 4 mets popping up somewhere else, causing an embarrassment to everybody. So
right. So I think so it's important.
The only thing that I can talk about neoadjuvant in this is that it may reveal the tumor biology. That can be the only advantage. Otherwise, you all know very well, as I know, that this can be resected and maybe in the same sitting. I mean, all the senior surgeons, I know more of them personally also, they are more than capable to do that surgery. But the tumor biology can be better revealed with chemotherapy. That's the only advantage.
All right. I would just add a point here. There are 2 more advantages which I at least see. One, giving them neoadjuvant will make sure that most of these patients will receive chemotherapy on time, because what happens that if you do a major liver resection along with colon resection or rectal resection, the complication rate per se goes up and their chemotherapy and systemic treatment so far will get delayed. Second thing is that organ preservation. So most of the time when we give them neoadjuvant, the liver resection which we will do will be smaller. And that is very important because many of them will throw up metastasis sometimes or many times in the remnant liver. And then if we have that margin of safety there when we re-resect and re-RSA and do all sort of things. So that's why my approach is always been to aggressively treat them first with systemic treatment.
Right. So that's all about it. Dr. Kothari sir, let's take to the next session now.
Yeah. So thank you, Dr. Saklani and all the panelists. I think we could address a lot of burning questions, I would believe, and people have got some answers, some cues, and some of them might have got confused. Nonetheless, we will move on to the next panel. And it's Dr. Somsekhar. It's a great privilege to have Dr. Som, and he would moderate the panel on HIPEC in gastric cancer. So, Dr. Som, you know, in your last meeting, you had asked me to speak on to the trials on the gastric cancer. So I thought it's in the interest that let's have some further review on what is happening in the gastric cancer as on today. So it's all yours, Dr. Som.
If I can request Dr. Bharat to stay for this panel. Dr. Bharat?
Yes, sir.
Okay. Why don't you stay for this panel as well?
Yes, yes.
That's fine. That's fantastic. So thank you, Jagdish bhai. Fantastic piece on GI. And I know that I was supposed to make you do this in Hyderabad in Subbu's Indian Society of Peritoneal Surface Malignancy, but it came back to me. But we'll not leave you. You have to still do the talk next time.
Yeah.
So it's a pressure. Actually, I'm very happy because people are fed up in HIPEC with colorectal and ovarian. But the new thing that's suddenly emerging is gastric cancer. Last year in ASCO, both in ASCO Chicago and then the ASCO GI, maximum study presented were on actually HIPEC in stomach, which nobody thought, because people thought the gastric cancer is so bad, it's always like, may not be have, but suddenly evidence was built up very high. So it's the right time to discuss this particular area. I have a fantastic panel, with me. You are there leading, everybody knows you, I don't have to, introduce. Then my close friend and colleague, Ravindra is there, with the head of GI Oncology in Rajiv Gandhi Cancer Center, Delhi. Then Dr. Manish from TMH Mumbai is there. Dr. Ashwin from Global Cancer Hub Indore. Dr. Neenad and Dr. Nitin will join us. They are stuck in emergency, but they told they're going to join. And Dr. Shishir from HCG Baroda. And Shubhda, your in-house good oncopathologist, is there with us. So it's pleasure to have all of them. And then Bharat is also continuing. That's fantastic. This is the panel. I have fantastic panel to go. I just have, why do we need to have this particular panel? Because gastric cancer, even though it's one of the 5th most common cancer, most important is about 14 to 43% of peritoneal carcinomatosis synchronously is known. If you look at all the trials I analyzed, the number is 35% of all the synchronous metastasis happens in gastric cancer. And 9% is the sole site of gastric cancer with peritoneal metastasis. It's very important to understand. So peritoneal recurrence in a curative stomach, whoever you have done curative surgery done, almost 10 to 46% of them are going to develop peritoneal recurrences, that are the primary site in addition to the liver. And in spite of D2, 12 to 40% have, which means peritoneal disease, either you have it at presentation or it's going to come. And this is something which is very important. Traditional conventional treatment of palliative systemic chemo gives a median survival of 3 to 7. 5-year survival is almost 0%. So even with the best of the best chemo, 8 to 12 months is what we see. And this is one of the reasons, even though there is S1 docetaxel, which increases the response, but still the survival is poor. So we will look at the case 1, how we go about it. This is these are the real scenarios which my colleague Dr. Rohit from Manipal Cancer Center, my colleague, helped me build up this. A young fit guy, 40 years, evaluated for vomiting and dyspepsia, and had an upper GI endoscopy. You know that most of the time, the moment they have, they just go and get a scopy. He had an ulceroproliferative enteropylori, not a proximal, but a distal, mild outlet obstruction, liquid. He can take only for solid occasional vomiting, but semi-solid, liquid food he can take. It was biopsied. It is a moderately differentiated adenocarcinoma, and a contrast enhanced CT of abdomen, pelvis, chest suggested that there are perigastric station 1, 2, 3, and 4, but no non-regional lymph nodes, which was staged on a good imaging as a T3, N plus, and M0. So this patient, since it was distal, was taken up for surgery, and then a staging laparoscopy was done. And you can see this is the picture you found on a staging laparoscopy. Mild fluid, you have in Morrison pouch, straw color, 2-3 ml, and left subdiaphragmatic area. And you can closely see that rest part looks good, but left diaphragm, which quite often we see in gastric, small few nodules are found. And the surgeon sent it for frozen section, and it reported as metastatic adenocarcinoma, which means otherwise a fit, healthy young male, worked up, thought to be locoregional non-metastatic disease, on a staging laparoscopy before going in. Remember, it is not a signet or linitis or poorly differentiated. This is the picture. We know that we all end up with this in gastric cancer quite often, sometimes even in pancreatic. So I wanted to know, before I go in, one-line answer from everybody without any explanation. With this picture, with your experience, when you see this, what is that comes to your mind? Okay, the intention of treatment in this patient from now is palliative or curative. One-line answer, will come back yes or no, starting from Jagdish Bhai. So what is the option? You think it's palliative, or is there any option of curative?
Young patient curative is what I keep in mind.
You keep it in mind. Okay. So Shivendra, what do you think?
I will like take as curative, but we don't know the PCI score. What was the PCI on the laparoscopy?
Yeah. I showed it. It was confined only to 3 quadrant. The PCA was
Then I'll take it. Then I'll take it as a curative only.
Good, good. And Manish?
Yes, sir. Curative. Curative.
And Ashwin? Shishir? Shishir is there? Okay, Bharat, what do you think?
Sir, as it is low PCA with no mesenteric involvement, we'll go for the curative intent.
Superb. I have given an aggressive panel who has a knife which is a magic wand, you know. Beautiful. I wish if there is a medical oncologist, you would have brought all of us to ground tele, it could have palliative. But it's nice. We'll go ahead with this. I'm not asking this question to pathologists because, you know, surgeons take the blame for whatever happens and they get the tissue. So now I will ask, what is the sequence of treatment? There is no one absolute right or wrong in, you know, medicine. A wise man knows that there are more ways you can actually skin the cat, they say, okay? So I would want you to know there are 5 options I have given. Systemic palliative chemo. With the first answer all of you have given, I am very much convinced that you believe that there is an option and scope of, you know, curative. Time will tell how where we ended up. So option 1, probably with this panel, with the answer you gave, may not be an option. Now that you have already prepared and the PCA is low 9, you would straight away open, do a proper D2 gastrectomy and think I'll give chemo. Or you think, yes, I know it is resectable, but it is metastatic. So I would abort the procedure, give perioperative neoadjuvant chemo, then I come back with surgery alone, or I put a IP port, normotomic, or I will give chemo and go ahead with definitive cytoreductive surgery HIPEC. Obviously, option 5 doesn't exist because option 1 itself my panel is not considering. So can I have a lift of hand from everybody, starting from Shishir, Ashwin, Manish, Ravindra, and then Jagdish? Which option are you going to operate? Because there are more than one ways. Nobody is right or wrong. Which option? Then we'll come back for evidence. Okay, Bharat? Yes, Bharat?
Sir, NSAD followed by again diagnostic laparoscopy in the same setting with a surgery diagnostic laparoscopy showing it the same amount of disease, no surprises.
No, we'll not go for discussion. You would give for neoadjuvant chemo. Then whenever you operate, things have changed in your favor. What is that you do? Only cytoreductive surgery, or you consider IP port-based chemo or IPEC or no?
Did you go gastrectomy with cytoreduction?
Okay, no HIPEC.
Plus or minus HIPEC. As we have no experience till now.
No problem. We'll come. So philosophically, you would say surgery definitely yes, but you will not operate even though it is resectable now. Okay, Jagdish bhai, what option you take? 2, 3, 4.
Option 4.
Option 4. Shivendra, what do you think? What would you do in your institution? Because you have a good experience.
Option 4. We follow the option 4 only.
Okay, you follow option 4. Okay, Shishir, Manish.
Option 4, sir.
We'll come back to this. Why not do this? So what is it? Is it just that you want to believe it is metastatic stage 4 you want to do, or you think there is an evidence for that? Is there any evidence pro and con against surgery, HIPEC, and then adjuvant versus neoadjuvant, downsizing and coming back? Do you think, is there any evidence, or it is just like because it is a stage 4 metastatic you want to do that? Anybody can take it.
So, you know, it is not randomized trials results do we have at this stage, but in literature, we have definite evidence that surgery, I mean, neoadjuvant chemotherapy and surgery plus HIPEC has shown definitely better results in less than 15 PCI patients. So I mean,
will you not be afraid that you spend the moment you send to medical oncologist, they're not going to come back for 3-4 months. There is some group of patients who might progress and choose an opportunity of a optimal cytoreduction possible at this moment. Does anybody have that concern in the mind?
No, definitely not. Because if my patient is not chemosensitive, the whole philosophy of managing this kind of advanced gastric cancer is that it is a chemosensitivity, which is going to help me as a surgeon. As a surgeon, you know, it's going to be a gastrectomy and plus and minus whatever CRS and all those things I'm doing, which is not a heroism here. I'm banking on lot on the chemotherapy and the treatment that if I'm doing with HIPEC is a backup, which is a significant backup for me. And that's where, if there is a fit patients, I want to consider for this kind of an aggressive approach.
No, that's a very interesting thing, because those of all, GI oncosurgery whom we do, This was exactly opposite in colorectal. In colorectal, peritoneal metastasis alone was thought to be chemo-resistant, and the Netherlands and Amsterdam group was always no neoadjuvant, no adjuvant, cytoreductive surgery with HIPEC, and they told the benefit of peritoneal alone is less. So there they thought that cytoreduction alone will do. But I agree with you. So you believe in the concept that unless you can't control locoregional systemic control with chemosensitivity, local treatment may not have an impact. Is that fine? Does everybody agree with that, or any different thought?
We agree.
Bharat?
Agree, sir.
Agree. Everybody, so you think so? Pros and cons for all these things. Anybody does IP therapy only, normothermic and not HIPEC? Any of you in the panel do intraperitoneal therapy, non-HIPEC? Because you can have a early you can put a port and do early post-operative chemo, or you can put a port based, or you can do NICS also, and you can do HIPEC. So of the 5 forms of intraperitoneal, anybody does anything other than HIPEC? Heat with IP? Any institution following? Shivendra, you have large experience. Do you give non-hyperthermic intraperitoneal chemo and gastric?
We have not used for stomach, but our gynae team has been using. But most of the time, oncologists are not very confident in using intraperitoneal chemotherapy. And that is why most of the time ports are not used properly.
Because if you see the new emerging data that is coming from Korea, Japan, and
Japan,
Russia,
definitely there is a data.
Yeah, they give. So if you look
What
back,
is your experience, Som? Do you do IP?
Yeah, we are now following the NICS, which is coming after a very encouraging result that came from Korea, Japan, and also Russia. But majority of the patients in gastric actually still are in HIPEC. But I'm very enthusiastic in doing this off late. See, the reason that came to this is there are 2 large cohorts from 2 different parts, Netherlands and France, which showed any amount of treatment which is not with cytoreduction, with or without HIPEC, had a 5-month survival. This is the natural course of peritoneal metastasis. But how many of you know there is a phase 3 randomized control trial, HIPEC, no HIPEC in gastric cancer? You know, we always think that colorectal has 3 are randomized, ovary has 2 randomized control with HIPEC. Very interesting. This Annals of Surgical Onco from Ziango et al. Final result of phase 3 RCT, prospective. Very interesting to go back. You know, if you look back, they found CRS group alone had 6.5 months, HIPEC group has 11 months, and p-value was significant. In CRS group, 0% were alive at 5 years, but about 6% alive at 5 years, and double the number at 3 years. You know, very interesting that there is an RCT in stomach which is underevaluated, and Dr. Rohit, my colleague who helped me find this, told me, sir, the number is less. So probably the evidence came down, and those who achieved, but you know what is interesting? If you achieve CC0, HIPEC didn't have survival benefit in this group. But the moment you have R1 or CC2, HIPEC added survival. So if you are not able to achieve optimal, this is very interesting to know there is a randomized control trial, phase 3, which showed HIPEC helped when you are not able to achieve C0 but not CC2, remember CC1. And the counterpart of trial also from GIMSA trial. This is also a very good, well-conducted GIMSA trial, which showed HIPEC arm had 11 months survival, median survival compared to 4 months with chemo alone. This is the evidence I was telling, which all of you told I'm going to do neoadjuvant. This is a very good evidence where the groups were decided into surgery with HIPEC, where resectable like this case. Even though it is resectable, abort the procedure, neoadjuvant chemo, then you do HIPEC, or neoadjuvant chemo with surgery alone, no chemo, HIPEC. This is the 4-arm which was there in the trial. And this particular trial actually beautifully see how the Kaplan-Meier are separating. They showed neoadjuvant chemo followed by cytoreduction with HIPEC had got the best survival to the tune of 33 months. So I would agree that the panel, even though may not have thrown an eye on this, this is something what they told. This is something very important. What we use in ovary cancer, port-based chemo without heat or NIPS didn't improve survival. This is a trial which is there. So this actually, answers all the 5 options I gave you, which it is a meta-analysis of 2,520 patients with 30-year experience of HIPEC in gastric cancer only, where 620 patients underwent HIPEC for peritoneal carcinomatosis, and it showed that the survival benefit was there in the group where neoadjuvant chemo and HIPEC was given. It's a very large number. Okay, now we know that just because we have a hammer, everything is not nail. I know all the people in this panel, I had a survey, they are all experienced HIPEC surgeons, good peritoneal surface group, experience, lot of cases they have done. Do you think any case can walk in? What is the message we give? I want to know, how do you select? Does ascites present yes, no malignant matters to you? Is there a PCA score cutoff? Do you do a peritoneal cytology lavage and look at it? And NSCT neoadjuvant response, what as Jagdish Bhai told, is mandatory. CC0 only is required, and institute experience. This is a very important slide in my panel. I want everybody to give a crisp answer, all the point, your experience. Then we'll come back to look at the evidence for each. I have a trial for each. So we'll start from Shivinder. Can you answer one line under all the headings?
Yeah, for malignant ascites, minimal malignant ascites we take, doesn't take as a contraindication. PCI we take the cutoff of 10 to 12. And peritoneal lavage cytology we routinely do. If it is positive, then we give neoadjuvant followed by CRS and hyper. And the response to NSCT should be there, then only we'll take up. If there is progression, then we don't take up. And only for CC0 and CC1 we proceed with hyper.
Super.
And
so
we have done around, for gastric cancer, we have done around 32 cases for gastric cancer.
But you have a combined experience of like more than 300 in your institution, HIPEC. So that's a very good long learning curve you're passed off. So that itself changes. Cross experience in colorectal and pseudomyxoma helps you to also get it. That's excellent. And Jagdish Bhai, can you enlist what is your philosophy?
So, you know, I think what Shivender has said, for me, what is most important is, again, as Bharat mentioned before, that my first laparoscopy and second laparoscopy at the time of doing a resection of these patients, if I find a progression between the first laparoscopy and second laparoscopy, I don't do HIPEC. I don't consider HIPEC is going to
that is option number 4. No response to NSCT in terms of progression or stable, right?
So I will not do HIPEC.
Is ascites contraindication for you?
So marginal, minimal ascites not. PCI is definitely an important parameter for me. So 15 is the number which I will see. I mean, even other parameters, my bias is less than 10. Because gastric, it is what my cutoff is different for gastric and different for colon, and for ovaries, they are different cutoff.
Fantastic. Manish, what is your answer? Crisp answer, so we can summarize that. What is in your center in TMH?
Yeah, so malignant ascites per se, if it is minimal, as everybody has said, that's not a contraindication.
If other things are favorable, that alone is not absolute contraindication.
Alone is not.
Good. And what PCI cutoff you take in the institution?
So we take we have learned over the 40 cases, and when we have looked at the data, we found that about 8 is a cutoff where under 8 is better. So, but that doesn't mean that
mandatory response for you. If there is no response, you would not.
In the response, I would just see lack of progression rather than a response. Even if there is a stable disease, that's okay. Progression is also okay as long as the PCI value still stays below 10 or 12. That's okay. Even if 2 has become 8 PCI, I would still go in if there is other areas of response.
Fantastic. Almost pretty much your opinion and thing is there. Just that PCI you would like to have written though. Okay, Ashwin, Shishir, and if Nitin has joined, anything different or in this?
Hello.
Anything is written, Nitin, welcome. So I just wanted to know if there is a malignant ascites, what PCI cutoff you take, you would subject a gastric cancer for CRS hyper.
Sir, for stomach as such, I don't have much of a experience for stomach HIPEC, but generally I would believe it would be lesser than what I would do for colon and other etiologies. Principally, I feel it should be lesser the better. That is what I feel. 6 or 8.
For the benefit of audience and student, in colon we have an evidence 15 to 17 and above PCI, even though resectable, CC0 achievable, HIPEC has no benefit. So 15 and 17 high is high cutoff. So here you are at 9 or 10, 11 you think, or less than 15. That is the philosophy.
Hello.
Yeah, please go ahead, Nitin.
Yeah, sir. For this, although evidence says that we can go up to 12. But principally, I would not do it for more than 6 for any of my patients, at least for a few starting cases. Once I see that it's doing okay, then maybe yes, in future I might start doing it for even higher one. But at the start, at least 6 would be my cutoff for the starting.
Is Ashwin there? Ashwin from Indore? Okay. See, this is extremely important if you listen from all the experts. So this is a case selection is most important in gastric, unlike others. So it is extremely important to understand this particular. This particular question is to Dr. Shubhada, our pathologist. Now that everybody told they want to use neoadjuvant chemo, in your institution, do you and your pathologist grade by PRGS score? For the people who are not practicing HIPEC or other, I will tell you, once you give neoadjuvant chemo for a peritoneal surface malignancy, be it colon, be it ovary or whatever, we have a peritoneal regression grading score, which is score 1, 2, 3 and 4. Based on this, the outcome prognosis further treatment is there. We have a lot of paper from our center, many other things which we have done. This question is to Dr. Shubhada. How difficult is it to put PRGS score? And how do you
yeah, see, after NSCT, if the previous diagnosis is diffuse cohesive type, it can be pretty difficult to give a peritoneal regression score. And if there is a very good response to the chemotherapy, like there is a lot of necrosis, fibrosis, then also sometimes it is very difficult to pick up those cancer cells in a poorly differentiated, otherwise tubular carcinoma also. But otherwise, answer to your first question is yes. All cancers who receive neoadjuvant chemotherapy with peritoneal metastasis, for example, we do more of an ovarian. So one has a specific 3-tier grading system for ovarian, and this SOLAS that you are talking about, it's a 4-tier system, essentially just like Ryan system, which we have in colon. So whenever we receive sample, we have yet to get samples for gastric HIPEC. But when we receive samples, we would definitely do the grading.
See, this is very important. People who practice HIPEC in all peritoneal surface malignancy or PIPAC, pressurized intraperitoneal, sit and sync with your pathologist and do it. I just wanted to know, Nitin and then, Shivendra, Manish, is this a absolute component of your pathology report, PRGS scoring?
In almost all, we request our pathologist to give.
So this is something important. It will be interesting to know what is the 5-year survival or DFS OS based on this score, which is extremely important. That's something which is very, very useful. So I will put one slide. Preoperative malignant ascites is a very poor prognostic marker. And these are the group who didn't derive a good benefit in HIPEC. I understand this is not an absolute. If that is the only thing, like small straw colored ascitic fluid, not a tense ascites, but these people don't do well even with HIPEC. PCI, high PCI doesn't, but the optimal PCI for gastric is 6. Remember, for colon, it is between 9 to 14, but for gastric, less than 6, but up to 9 is fine. 9 to 14 institutional variations, which means, optimal less than 6 means small amount of disease in the supracholic compartment around the omentum and around the peritoneal deflection of diaphragm. So low volume disease is something which benefits. And then if you look back the PCI at various level, all of them actually showed that optimal, less than 9, 6 to 9 is the best for you. CC0 has got the best result. If you can achieve, you must achieve. Surgeon and institution, the learning curve in HIPEC is 70 to 180. Institute which have less than 3-year experience, less than this number, had very high morbidity and less outcome. So this is very important to understand. Surgeon, institution and the learning curve also plays an important. Now I want to know, now that we decided neoadjuvant chemo, staging laparoscopy, sensitivity to neoadjuvant chemo, less of ascites or no ascites, mandatory response to chemo, low PCI. We have already decided in a good performance to do. Now, shall I have with a hand of count all the center? What drug in gastric cancer would you use? We'll come back. If you can answer all of them, one starting with Jagdish Bhai, which drug in gastric you prefer, what technique you use, 30 minutes, 60, 90, and last question will not come now, I'll come back to that. So first 3.
Mitomycin, and we always do open, and I think 60 minutes. We have very limited experience in gastric, so okay. I think 60.
Manish, what is your protocol in institution?
So we use cisplatin and mitomycin. Cisplatin 50 milligrams per meter square and mitomycin 15 milligrams per meter square, with an open technique and 60 minutes of duration of the HIPEC at 42, 43 degrees centigrade.
Okay, Shishir is a surgical oncologist from HCG Baroda. Shishir, what is the drug you use and what technique you use and duration? Or does it matter, or all you think are okay? Shishir? I saw him briefly on the screen. Okay. Ashwin is there. Ashwin, Nitin.
Hello.
Yeah, Nitin.
Sir, I would prefer cisplatin 50 milligram per meter square, and I practice open technique. So with that technique, 60 minutes.
Okay, why cisplatin? Why not mitomycin or oxaliplatin?
Hello.
Yes, go ahead.
Sir, as such, I told you I have limited experience with this, and cisplatin, and as per the trials, has shown good results in stomach. Mitomycin, I'm not sure how good or bad it will do. So cisplatin is what I feel should be the one which one should use.
Shivendra, what is your protocol? Shivendra? Okay, I think probably he lost the connection. Okay, anastomosis, you do before starting the HIPEC, all the anastomosic, esophagojejuno or gastrojejuno, all the restoration you do before starting HIPEC, hyperthermia or after? Jagdish bhai, in your institution, generally in HIPEC, where do you do?
All HIPEC, we continue to do it only after HIPEC.
Okay, do you technically find difficulty, edema, and then restoring would be very tough, a stapler or Antsion?
Yeah, so yes, there is some edema on colonic anastomosis and all, but I think we have to accept it, and we continue to do the stapler anastomosis in most of the situations, and my tolerance for the diverting stoma would be less here. So
you restore after baking a HIPEC. So
yes.
Any other Shishir, Nitin, Shivendra, what is your protocol? You do anastomosis before starting HIPEC or after completing? Nitin?
Sir, after.
After, okay. Shivendra? I think I can't see. Ashwin?
You are muted. Shivendra, you are muted.
Dr. Shishir, you need to remove your headphones. Dr. Shishir, remove your headphones. Disconnect your headphones.
Yeah, Shivendra, what is your protocol in your institution?
Our protocol is doing anastomosis after HIPEC.
Okay.
And
is there any experience behind that, or just you thought that's right?
Yes, as a protocol that we have been following.
Did you try the other way and then you didn't feel happy or anything, or just from day one you started?
Never tried the other way. Just apprehensive about that.
I have a different experience here. We always do the anastomosis before doing the HIPEC in all cases. Just as Dr.
Because it's very easy, tissue is fine and everything can be
tissues are fine, edema, but we make sure that we check the anastomosis again after the HIPEC fluid is drained out, just in case if there is any loosening or any other additional sutures to be taken. But okay, we always do it before rather than after.
Ishit, what is your philosophy?
So, sorry, Manish. Manish, you shared that you want to check after completing the HIPEC for any leakage, and I think there is a specific reason that you do this. Have you experienced this?
No. We have never experienced that.
Show the evidence for that.
After HIPEC, there was a problem.
That's nice to know that there is variance of opinion. That's exactly the beauty of the panel. Okay, Shishir, what would you do? You do anastomosis before or after the HIPEC?
Sir, I do anastomosis before doing the HIPEC.
Beautiful. House is divided by 50-50. So half do before, half do I.
Som is doing before. Is that right? Your opinion?
I will show you the largest experience, which I'll show you. What is the drug? Look back. These are all the various things which came. Oxaliplatin now in HIPEC is almost dumped after negative trials. Maximum used drug in stomach in all the world trial literature is oxaliplatin MMC. You can see that oxaliplatin had the highest leak rate, breakthrough bleeding and complication. And this is one of the paper from our institution which was published in EJSO. Dr. Ramya and Rohit Ashwin did this beautiful analysis, toxicity profile of various chemo used in about 350 patients. And when we analyzed and published this, the maximum complication was in oxaliplatin. So we abandoned. We almost used oxaliplatin in 100 patients. Now we totally switched over to mitomycin. And when they compared mitomycin versus oxaliplatin, oxaliplatin has same outcome, but the toxicity was lowest in mitomycin. Now more maximum trial in gastric car recruited with mitomycin. Efficacy of oxaliplatin MMC was highest. MMC is least toxic to do. Now anastomosis before. I understand all the people who are done. If you do before fresh tissue, beautifully you can put second layer, but the disadvantage is you are afraid if edema will break the anastomosis, mismatch of the lumen. Pros and cons are there. Because of this, we undertook this study among large number, 214 patients, prospective study at our institution, which was presented in the ASCO GI and now getting published in Annals of Oncology. Stomach, bowel, large bowel, stoma perforation, when we looked at all, between done before or after, 104, 110 on both sides, absolutely no difference in any form. So if all of us know there is no difference in anastomotic integrity leak complication, we all agree doing upfront is technically easy. So we are 100% switched over to that. When everybody is open to read this paper, it is available. It's a very good study. One of the only study ever conducted in a prospective way. Now we'll look at this particular case. 45 young fit ECOG 0 lady, early satiety anemia, upper GSCOP now showed in the body, ulcer proliferative. CT scan showed there is a thickening of the stomach, loss of fat plane, bulky, regional 1, 2, 3, 4, 5 nodes, not beyond station 7. I want to know what imaging you prefer. US for T-stage, PET scan, MRI or texture analysis, or CECT is enough. What is the investigation choice in your institution? Shishir, what would you do? What is your standard workup for these patients?
I would like to know the histology of this patient.
Yeah, the histology is moderately differentiated adenocarcinoma. Grade 2. Why does it change if it is poorly differentiated, PET, well differentiated, MRI, moderately differentiated, CT?
Then, sir, regarding the signet ring.
So signet seal, what is that you do different then? Tell me, okay.
If it is a signet ring, I would not do a routine PET scan, but in such cases,
so otherwise, you do PET scan in these patients? Okay, but you know that the resolution of CT is inferior to common. Shivendra, what is the standard workup in your institution?
In our standard workup is CT chest and abdomen. But if there is such a bulky nodes are there, then we always do a PET scan also, other than signet ring cell patients.
Okay, Jagdish, man?
Yeah, so same way, if I have got a good CCT done and gives me adequate information, I am okay with the imaging, but I have a definite bias that laparoscopy, diagnostic laparoscopy is very important.
Invasive, non-invasive here. Okay, so the working horse for you is a good quality contrast enhanced CT scan.
Yeah.
Okay, Nitin, anything different, Nitin?
No, sir, I would do the same.
I think Ashwin and Ninad is not there, right? Okay. Now, if you look back all this, anybody does a texture analysis? Do you have that software and do you follow that?
No.
No. This is a very interesting thing. This is a tricky question, because you got bias with the node. If you want to assess the node and systemic, I understand you concentrate on a CECT or a texture or PET. But if you want to know the peritoneal, we wanted to know that, this is something which is a meta-analysis of what imaging is right in gastric. CT scan, PET scan, then you can see MRI, and it showed that while all three modalities were good, MRI had the best sensitivity in identifying the peritoneal metastasis, inferior to staging laparoscopy, I agree. So if peritoneal disease is your thirst, MRI. If node, primary and systemic is there, I understand your thirst would be. This PET is not a routine, and this meta-analysis concluded contrast, like MRI, diffusion weighted MRI is the standard of care, superior to either PET or CT alone as a standard of workup. And
so you are right, and that is the reason while we are subjecting the patient for the HIPEC, many times we will combine CT scan plus MRI because it gives us better idea of BCI.
Fantastic. Peritoneal surface malignancy, working horse is to combine MRI with CT. Very well said. That's a very important thing. These two are the closest, inferior to staging laparoscopy, but these two are something which is very, very good for you to do. So now that we agreed CECT is the working horse and MRI as a backup, I want to know how many of you do option 2 and 3, routine staging laparoscopy, compulsory as institute protocol, and peritoneal. Shivendra clearly told they follow peritoneal lavage cytology. If it is positive, he may add neoadjuvant chemo and consider hyperkinetic. So I would want to just know, is it a routine to do staging laparoscopy, peritoneal lavage in all your institutions? Shishir?
Yes, sir, I do in all cases.
Fantastic. So, okay. So, because you remember there are hundreds and hundreds of students who are there, we have to give a good message. So, staging laparoscopy, you would do in stomach. So, does anybody differ in this? Is there any group of patient, Shivendra, you would not do staging laparoscopy? It's not a rule. Some case I would straight away open and do it.
Most of the cases, rarely ever we will do.
Anybody has a different opinion, Nitin?
No, sir.
Nobody. So the message
I
is
just want to say one thing about not difference in opinion per se, but although MRI is good as compared to CT scan for diagnosing peritoneal disease, but it is still inferior to staging laparoscopy. So doing it as a protocol is not very cost effective, because ultimately you are going to add a staging laparoscopy to assess the PCI and peritoneal disease. So CT scan and staging
the
lab.
issue is all the panelists unanimously agreed. If it is a peritoneal carcinomatosis, we are going to give neoadjuvant chemo. If you have done an MRI and you have peritoneal disease and you can stage it, so then probably you can avoid taking them to OT and putting the two scope. But
So that is
as a trial, many people
that is one thing which I actually have a question for everybody. That would you avoid a staging laparoscopy if MRI is showing? Because MRI may still be understaging the peritoneal disease as compared to a staging laparoscopy. So does it avoid a staging lap in your practice?
Okay, I will come back to this. You know, there are two ways of looking at it. In a de novo case, otherwise thought to be resectable, you want to do a surgery, you do MRI, you pick up peritoneal disease, go to neoadjuvant, then definitely surgery, you do laparoscopy. Or MRI is normal, then definitely you planned it, already posted for surgery, you do laparoscopy. So both are different issues. I'll come back to this particular laparoscopy. I want to know, what is the minimum molecular pathology you would subject a CS stomach with peritoneal, this one? Shubhuda?
Nowadays, HER2 new everybody does routinely, so as MMR.
And it is only 5% of them are positive, and TOGA trial says 5% of them.
These gastric cancers are divided into 4 types by TCGA, and EBV associated, and second MSI high. They show PDL1 expression. So actual panel should include ideally PDL1, MSI, HER2 new, EBER for EBV and P53 apparently.
Okay, because all panelists unanimously agreed neoadjuvant chemo, then HIPEC, then it gives an idea for us what should be the standard, even though most of them might start with FLOT regime. And these are the laparoscopic finding. You know, there's a good paper from Sugar Baker. It is what you can't see and you ignore is what kills the patient, not what you remove and what you see. And this is something which is very important, that in gastric at least, please go ahead and do a staging laparoscopy. It avoids open and close procedure. Peritoneal lavage. Only Shivendra, other than Shivendra, anybody routinely does a peritoneal lavage cytology, PLC? Any other institution does in gastric?
So we have started doing it in all cases of gastric, yes.
Okay, why would we do that? If it is positive, would you manage them in different way? If it is negative, you would manage. Can you tell for benefit of students who are logged in?
So at least I know upfront that whether it was positive or negative, I have staged the patient. The whole idea of doing
a prognostic, you're not going to change your therapy based on that?
So you know, the therapy is not based only on my positive cytology. It is based on other factors as well.
Shivendra, do you agree with that? Is there anything different you do? I do cytology positive, bad prognosis, or I do cytology positive, even though there is no peritoneal mass, I give neoadjuvant chemo, then I do HIPEC. Is that the philosophy? Management changes for you?
Yeah, only changes if peritoneal cytology is positive and there is no peritoneal mass, then also we'll go ahead with neoadjuvant chemo and don't proceed with surgery at that point of time.
Okay. So anybody has any different view in this? Shishir, Manish, anybody would? Manish, do you do routine peritoneal cytology?
Yes, sir. I think it is a very important thing to do, especially in absence of metastatic disease, peritoneal metastasis, because we can do HIPEC for all these patients, and probably these are the ones who will benefit the most with a CRS HIPEC in a gastric cancer.
I'll come back to those two trials. You know, I really wish and loved what you told would have been practical, but evidence, you know, that medicine says something. I'll come back to that. I agree with you. Prophylactic HIPEC in high risk group is more useful than full-blown peritoneal is what we believe, but I'll come back to that. Remember, for people, peritoneal lavage is not just you put some saline, wash and take it off. That is not. 2% of them are positive. They are independent prognostic marker. When you look back, completely treated with cytology, without cytology, median survival changes from 38 months to 19 months. That's why rightly all the experts in my panel beautifully told, please do this. Remember, even if you resect, give chemo, do HIPEC, there is a clear demarcation of Kaplan-Meier curve, cytology, positive versus negative. 27 OD, enormous number of publications are there. This is something which I want to tell the people, you know, PLC, DPL, DL. PLC is peritoneal lavage cytology, different than diagnostic peritoneal lavage and diagnostic laparoscopy and lavage and IFCC. For the want of time, I cannot tell. I ran a big panel in the last, ISO meet, but please read about it in Journal of Surgical Onco 2013, PLC, DPL, DL. Most of the time what we do is DL because we do laparoscopy, take a washing and come back. There is a technique to do 100 ml to 200 ml from the saline is introduced. The return should be at least 50 per 500 ml output. If you put 1 liter, then you know you must take at least 100 ml back, and addition of heparin not required. Wait for 15 minutes, then you take, then a cell block is made and yield is 40%. And the yield in T3 lesion, all T4 is 86% positive, 100% positive if multiple nodes are metastasis, higher the grade 71% positive. So Shubhada, would you agree with this? Any tips for surgeon who sends this cytology to you? If you want to increase efficiency, what would you give a message for us?
Usually what we do is for all cytologies, we make a cell block because making a cell block, usually these patients are post NSCT. So on cell block, one can do IHC also. I don't particularly
Is there any special way for us? We just send it in a bottle or some buffer or
no, it's nothing? Okay. No, I accept it. It depends on when you are going to do the surgery, but still it is like if it is going to be after hours, then it's better to be to keep in the refrigerator than one can put formalin also if the transport to the lab is going to be delayed because
so we are immediately send everything you remove. Don't think that I take 200 and send one small bottle. If you delay, refrigerate it. Formalin is okay. You say what stain normally you use in this?
No, we do usually routine HNE, and on the slides that we make from the smears, we do Leishman and PAP. I don't believe in doing any special stains because mucin can be deceptive because sometimes muciphages, which are histiocytes with mucin, if they are positive, one can give a false positive diagnosis just depending on that mucin stain. So if one is in doubt, it's better and safe to do a simple cytokeratin because post-NSCT diffuse signet ring cell type can be a particularly problem area.
Okay. See, now a lot of fantastic points my panelists told. Number one, they told staging laparoscopy, please make it a part. CT with MR is good. And the neoadjuvant chemo they would prefer, and they don't think it is a palliative setup curative with peritoneal disease. And then judicious selection of PCI good performance status, and then peritoneal lavage, and this everybody does, which is a fantastic this one. Now the same patient now went up for surgery. When you put a scope, you found serosal invasion, and then peritoneal cytology is negative. Now this is a high risk, no peritoneal disease. Cytology is also negative. Does anybody in the panel,
Viraj, sir, can we conclude, sir? We are running out of time.
Fine, I'll conclude that. So, do you believe in prophylactic? I just have a couple of slides. Do you believe in prophylactic HIPEC in advanced disease? High T state, high node, even though there is no peritoneal metastasis, would you actually believe anybody does a prophylactic HIPEC for gastric cancer, advanced but not peritoneal carcinomatosis?
So we don't do prophylactic in high risk cases, but I do believe probably there is some role based on the
The
data.
answer is no, your philosophy. Jagdish bhai, you do yes or no? Otherwise, Viraj is on my head. Yes or no? As of now, you have to unmute, Jagdish bhai.
Yeah, no, we don't.
No, okay. Shivendra?
We don't also do. We don't do.
So nobody believes in this particular. Anybody practices this NIPS? Anybody? Just yes, if anybody does it, NIPS? No?
No.
Okay, fantastic. So what I'm going to do is I'm going to conclude about this. There's something important to know. GastriPEC, which looked at HIPEC, which used MMC, closed down because of lack of accrual. because they could only recruit about 100 patients. Gastric chip, which is the one randomized prospective RCT in locally advanced disease, but no, high risk group is going on. And in conclusion, this is something very important. Good HIPEC is not substitute to good surgery. General trend, don't be pessimistic. There are subgroup of patients who will benefit with lateral surgery HIPEC. And there are a lot of parameters. Patient selection is key. Low PCI less than 9 important. Usually non-signet may benefit better. And then ideal institution with a PCI low, resectable with neoadjuvant chemo, judiciously adding staging laparoscopy. Mitomycin is number 1, oxaliplatin high complication. Open, semi-open, 60 minutes and 90 minutes doesn't matter. All of them have shown benefit. But what is most important is it's a teamwork. Your medical onco, surgical, pathologist, having all of them. If it is palliative, going to PIPAC and systemic chemo, curative, we are doing this. Is the team here to do? This is the team which helped us do 330 HIPEC. So remember, all through passes through stage. Ridiculed, violently opposed, accepted. My panelists are already in the third phase. So this is the lesson we learned. And it has been fantastic panel. I thank Jagdish Bhai, Viraj for allowing me to do this, and beautiful, very well experienced panel here. We are very happy to take question offline because we are late or if there is a time. Thank you.
Thank you, Shom.
Thank you. We have around 350 audience, so I think so we have we ought to take questions. We'll just take 2 questions, and these are important. Even I want to ask them. Do you take signet ring cell versus intestinal histology before doing HIPEC into consideration? And the second one is, if patient has MSI high, would you still go and do HIPEC, or would you leave this patient for immunotherapy? These 2 questions, and then we go.
I will give an answer, but Shivender, I will give to the expert. So Shivender, crisp answer for both.
Our signet is, for prognostication, it is important, but it will not be contraindication for HIPEC.
Okay, absolute, not absolute contraindication. Yes. MSI.
MSI also will. MSI also is not a contraindication. MSI high. We still go ahead plan for a.
I know it's not contraindication.
No, we as a surgeon have answer for everything. All these are only contraindication medical. But there is a paper from Netherlands which looked at signet cell histology in spite of achieving CC0 with HIPEC didn't benefit. So in my institution, I tend to eliminate signet cell. However, young patient signet, not high volume, T1, T2, N1, not much. I would not decline case-to-case basis. As a general rule, signet, I am not very comfortable doing HIPEC. As of now, MSI status for me, it is not changing for HIPEC as long as there is peritoneal metastasis less than 9. Anybody differs in this? Any panelists, anybody want to add any other view? Okay, what is the next question before we wind up, Viraj?
Yeah, Dr. So, what about HER2/neu? If the patient is HER2/neu positive, do you consider for?
Yeah, see, if it is HER2/neu, we would definitely add neoadjuvant trastuzumab along with chemo before I do HIPEC. So, and then I would follow it up with adjuvant. But HER2/neu negative or positive, I'm not going to see HER2/neu positive, aggressive, but I have an intervention, then aggressive chemo is not going to help well. Then I'm going to do aggressive local treatment. HER2/neu negative, better prognostic, then I'm going to still operate and do HIPEC.
But do you have data on that?
No, absolutely not. Absolutely not. No data.
Okay, great.
See, currently only 5 things are proved in HIPEC in gastric. Above 9 PCI 10, it's not going to usually benefit, number 1. Number 2, staging laparoscopy, CT, MR you do, neoadjuvant chemo and then surgery. Mitomycin is a better drug with low complication. Anastomose is done before, after, doesn't matter. Neoadjuvant and adjuvant chemo is an integral part.
Okay, great. So that was an excellent session. Dr. Kothari, are you here with us?
Yes.
Right, sir. So let's move on to the next session, sir.
Sure. So thank you so much. And we now move on to the third session, and we have Dr. Sailesh Srikhande. Hi, Sailesh. Welcome you.
Hi, Jagdish.
So Sailesh, of course, doesn't need any introduction. Professor of Surgery and Head of GI and HPB services with one of the largest experience in the world treating the pancreatic cancers. So it's esteemed privilege to have Sailesh with us, and it's over to you, Sailesh.
Thank you. First of all, thanks so much for this kind invitation. There is a fantastic panel, and I'm glad that you've already put up the names of our panel. I have been informed about that. What I'm going to do is to straight away start sharing my screen. Can you see my screen?
Yes.
Great. So I've decided that we have 40 minutes, so we'll try to focus not on the whole of pancreas cancer, but try to touch upon some aspects of what is borderline resectable and what's locally advanced, two areas where multidisciplinary care is the key. First of all, thank you, and pardon me if I've missed out on anyone's name, but this is the list that I have got from Purohit as well as from Viraj. Am I missing out anyone, Viraj? So thanks a lot, Shivendra and Indranil and Dr. Bhuvan Chug and Dipanjan, Dhaval and Karthik. Am I missing anyone apart from the boss, Jagdish himself?
Sir.
And you two are, you know, there anyway. You will cover all of us in any event. So thank you for being there. So now I just want to straight away start by asking a medical oncologist, and anyone should take that question. When it comes to a patient of pancreas cancer, what's the preferred modality that you would use?
So this is Dr. Bhuvan, if I'm audible to you. I think this is primarily a surgeon's question, but the answer would be a dynamic CT pancreas in which you have a good look at the vessels as well as the pancreatic parenchyma.
Right. So I think you are right. In between, I might interrupt all of you just to cover as much as I can in 40 minutes. Please don't misunderstand me. And you are absolutely right that this question is aimed at a surgeon, but I wanted my medical oncology colleagues to answer me because we finally sit together and work. So the request would be,
this is Dr. Dipan. I think the answer is contrast and CT scan of the abdomen of pancreatic protocol.
So a dynamic CT pancreas is that's it. Dynamic CT pancreas is
great. So triphasic CT scan the very first time you do, and perhaps also a CT thorax at the same time. That will help you to get a good amount of staging. You have easy access to accessible and cheap PET scan. You can do a PET, especially if you're not looking at resectable disease, but at borderline resectable or locally advanced, you can stage it with a PET. But if you don't have a PET, at a practical level, we are doing a contrast enhanced CT scan and a CT thorax as well. Now the question for the surgeon, when would you use an endosonography in a suspected case of BRPC or LAPC?
Endosono may be, see, when we know that this has already been a borderline resectable or a locally advanced disease.
Correct.
So we do have a histopathology with us. But very importantly, endosono is a very useful adjunct in the sense that this is the area where in pancreatic, the head of the pancreas periampullary lesions, role of EUS comes into the picture, which gives us is another level of information from apart from the cross-sectional imaging.
Yeah, but you said that we already have a histopath diagnosis. You have a radiologic diagnosis of BRPC and LAPC. But how do you get a histopath diagnosis in a BRPC versus an LAPC as a surgeon?
Side-viewing endoscopy, if it is fairly good for available lesions at that side-viewing endoscopy is fine. If it is not, then we may have to go for an endosono-guided biopsy.
So why not?
That is my first preference.
Would you like to do an endosono-guided FNA or would you like to do an endosono-guided biopsy?
Biopsy. Always, I would prefer to have a biopsy. As far as possible, biopsy is preferable.
Is there a big difference in cost when it comes to biopsy? I'm told that pancreatic cancer is hard. There is peritumor desmoplasia. The needles can break and they are far more expensive to do a biopsy. Is that a problem in your practice, Shivendra?
Definitely. FNA biopsy needles are costly. So we most of the time do an FNSA. If only it is inconclusive, then only do a biopsy.
So now, how many times, great. How many times will you keep trying? First attempt inconclusive, second attempt.
Most of the time, actually, in our center, there is an on-site pathologist. He will tell if there is a cells are there or not. If cytology slides are insufficient, then at the same time a biopsy will be done.
Great. Last question.
So, Sailesh, we are talking about borderline or locally advanced. So at our center, we have excellent radiologist, and he is generally comfortable doing ultrasound guided biopsy. No need for US in at least 90% of our patients to obtain a tissue just by doing sonography guidance.
So Jagdish, next question. BRPC can still be very much resectable disease with good chemotherapy and or radiotherapy. So would you worry about the risk of tumor seeding when you do a transcutaneous biopsy? That's my next question. In locally advanced, I know 9 times out of 10, you will never resect. But what do you do with BRPC? You know, 70% or 80% can be resected. Then what do you do?
I mean, honestly, Sailesh, we are not worried about the tumor seedling at this stage, and we still go ahead and do only sonography guided biopsy.
Okay, would Shivendra agree? Would Karthik agree? Or you have a different viewpoint?
No, I don't think that we should be recommending ultrasound or CT guided biopsy for borderline because of the risk of seeding. I think it is.
So I've raised the controversial point, but for constraints of time, we will go ahead.
Yeah.
But if you ask me as a moderator, I think I would attempt an EUS guided FNA biopsy in a BRPC. In a LAPC, I would not do an EUS. In an LAPC, I would do a transcutaneous ultrasound guided FNA or a biopsy as need be.
Sorry to interrupt. We also have Dr. Indranil Malik, Dr. Datta as a radiation oncologist in our.
Yes, I'm coming. I've already, Dr. Datta's name I seem to have, no, I've got it here, of course.
Dr. Datta is also here.
So they will come on board very soon. Next question, how important are tumor markers for the entire panel at the start of treatment when a patient comes to you first? Is it important, non-specific, non-sensitive? Why do we focus so much on tumor markers?
It is so important, you know, especially when my intention of giving neoadjuvant treatment to this patient, and this is one single most important marker for the response to the treatment, because as all of us know that radiological evaluation is not going to be critical in deciding whether my patient has responded well or not, even after 3 to 6 months of the imaging. So CA99 response and definite response, my patient is responding and I have increasing hopes of taking
so
this
you
patient.
Would like to have a baseline CA99. Let me ask my medical oncology colleagues and also Dr. Indranil, is there a cutoff level at the presentation which makes you worried in terms of the burden of the disease or the response to neoadjuvant treatment? This question is not for surgeons, but any med-onc and any of my radiation oncology colleagues can take this question.
Frankly, no, sir. Whatever be the burden of the disease, if it is elevated, it gives you a good marker to follow up. But is there absolute cutoff which I'll not treat? No. Or I'll be scared to treat? No.
But do you have a prognostication in your own practice? You might continue treating all of them, but how do you deal with your patient when you are dealing with 500, with 1,000, with 10,000, with 20,000? Just the same? I mean, treatment will be the same, but does it help you to counsel your patients differently? I see Indranil's.
No,
yeah, hi, Dr. Sailesh. I think one got cut off. Yeah.
A level of C as well as the.
There is a break in the voice just now. Is everyone able to hear?
Yes. Yeah, please.
I think Dr. Deepanjan is talking, but he's on mute. I can't hear him.
Yes, what I was telling,
I was saying, so yes, the tumor burden, it defines the tumor burden and as well as the, no.
All right, fine. Deepanjan, you had something to say?
Yes, I believe if it is, I think more than 350 or so, there is a poor prognostic marker.
Right.
But that does not differentiate in the treatment. The treatment will go, but overall prognostication, yes.
Fine. Now, beyond the imaging, beyond the PET scan, etc., Is there a role for staging laparoscopy in borderline resectable or locally advanced disease prior to starting radiotherapy? This is a specific question, not for medical oncology or surgical oncology, but for giving radiotherapy. I would love to hear from Dr. Datta or Dr. Malik. I also see Reena Engineer, my colleague, somewhere on this group, but people can opine.
Hi, Dr. Sailesh. We usually in our clinical practice do not do any staging laparoscopy before. It would occasionally come into discussion if you had a really high CA19-9 level, for example, but not. I can't remember any patient where we.
Sorry to interrupt you, but for the sake of the audience, when you say when you have a high CA19-9, what do you mean? One. Two, you want to give radiotherapy for a disease which is systemic. And I believe that radiotherapy has an increasing role coming up even in pancreas cancer. But how will you know without a staging lab that you are truly treating a local problem in your practice? So what would be your cutoff?
So occasionally, we have patients who have a CA19-9 level of say more than 1,000 or more than 2,000.
Okay.
So below 1,000, I wouldn't think about.
You wouldn't do it. Okay.
Yeah.
Fine. Okay. And PET scan is available for you, so I guess you are fine with it. If the PET scan is fairly accurate, you are okay with treating.
I don't believe we do a lot of PET scans for looking at peritoneal disease, for example. If that is one of your concerns, I mean, I think that the PET scan has slightly lower sensitivity in pancreatic cancer, so I wouldn't trust it to make a decision on whether in a borderline resectable setting.
Fine. Does Dr. Datta have an opinion from Kochi?
We do the same. Usually in our clinical practice, we don't treat too many pancreas with radiation. Most of the patients go for systemic therapy for most of the patients before considering for surgery.
Okay.
So it is like a different kind of practice where, as you actually, I think if you're towards only you are talking towards that many of the patients in pancreatic cancers may not take radiation also. They get chemotherapies and followed by they consider for, which actually happens in our place, that unless it is truly borderline pancreatic cancer, they don't get radiation, but they get chemotherapy.
So I want to ask you that my topic is focused only on borderline resectable and locally advanced. So what percentage of patients in your practice are getting radiotherapy integrated in your practice? Say for BRPC, just give me a figure, and for LAPC, just give me a figure.
In borderline, maybe 50% of the borderline. Say in a pancreatic cancer where the CA19-9 is more than 1,000. Then most of our patients get systemic therapy only, not a focal therapy with radiation.
Okay, fine. Would the medical oncologist, Dr. Bhavan, would you like to speak, or Viraj, would you like to speak? BRPC, CA19-9, how do you involve the chemotherapy aspect and integrate the radiotherapy aspect? When do you do it? When do you not do it?
So please, so my practice is we generally, if the patient is fit and has started with a FOLFIRINOX-based regimen as a neoadjuvant therapy, I generally do a reassessment scan at the end of 4 to 5 cycles, and look if the patient has become operable or not. If there is some chance the patient has not become operable, I generally tend to discuss with the surgeons as well as the radiation oncologist.
Fine.
If they feel that there is a...
I got your answer. Whom do you decide that the patient should get FOLFIRINOX and whom should be getting gemcitabine and nab-paclitaxel? How do you decide that?
You see the patient and you know whether you give FOLFIRINOX.
No, but I don't know. We have
anybody who's less than 65. Okay, so anybody who's in Indian scenario, anybody who's less than 65 has a performance status 0 to 1, minimal comorbidities, you push for FOLFIRINOX. Anybody who's around 60, between 60 and 70 is diabetic or hypertensive, a bit fragile, usually a female, we end up choosing a gemcitabine nab.
Just a practical question. In terms of patients requiring hospitalizations and other problems, is it labor intensive to give modified FOLFIRINOX versus gemcitabine and Abraxane?
I personally think when it comes to pancreas, I am ready to, they will probably have to visit hospital 4 to 5, probably 6 times and get admitted for two nights each time. So labor intensive is not an issue.
Right.
Shailesh, can I come in?
Please come in quickly.
Yeah, so FOLFIRINOX nowadays we give through the 5FU, we give through Baxter pump, so it's a 6 hours hospital stay. And number 2, the response as a neoadjuvant, FOLFIRINOX definitely has a better response than gem-nab-paclitaxel. Gem-nab-paclitaxel you have to come 3 times in a month, whereas FOLFIRINOX you can actually do 2 times, and the response is better. Most of our surgeons do not like to give pre-op radiation to that tumor bed, so they prefer to give FOLFIRINOX, and the response is better. And
one thing, I think last week there is a randomized trial which has come in America which says that there is no superiority of FOLFIRINOX versus nab-paclitaxel.
And that was an ASCO study. That was an ASCO.
Since you made me ready for this moderation,
I am aware of the study. I am aware of the study.
Yeah, I'm joking. Tell me.
I am aware, but the thing is that overall, I was basically putting on the aspect of which is easier to give.
Fine.
So nowadays, with omission of bolus 5FU and decreasing the irinotecan from 180 milligram per meter square to 135, 150, modified FOLFIRINOX is a tolerable drug. And in our personal experience with Baxter pump, we have actually has a less hospital stay and less hospital visit with modified.
I got your point. I will move on. So I think the message that is coming out with an experienced medical oncologist like Dr. Deepanjan is that yes, modified FOLFIRINOX, which started off in 2011 as palliative chemotherapy in good performance status, has now reached the realm of treatment as a neoadjuvant approach, which surgeons are happy with, especially in borderline resectable disease. The surgeons, one quick question for a quick answer, only because I want to cover more points. When they give 4 cycles of FOLFIRINOX, when do you want your new reassessment CT scan, and when is it safe for you to operate in a patient whom you want to operate after 4 cycles of FOLFIRINOX? Dr. Dhaval?
Around 4 to 6 weeks, somewhere between 4 to 8 weeks, but usually we wait for 6 weeks.
So you mean after the last day of the 4th cycle of chemotherapy, when would you do the CT scan? The next day morning, or in 10 days, or 7 days, or 15 days, or 1 month?
After 6 weeks. After 6 weeks.
Would the other surgeons agree, Dr. Jagdeep?
I think we do usually a CT scan after 2 weeks of the last chemotherapy.
Okay.
And if there's a response is good, and if we think that we can proceed with surgery, then we wait another 2 weeks and go ahead with surgery.
Right. Why do you wait another 2 weeks after your CT scan has shown a good response? Why don't you operate on the 15th day after completion of FOLFIRINOX last dose?
Usually, we feel that the patient is generally much more fitter and fit for surgery after 3 weeks. So
Right.
usually 3 to 4 weeks is the usual time that we plan.
So I want a medical oncologist.
Shailesh, one point, which I am trying to bring it again, that it's not going to be the CT scan assessment which is going to tell you whether your borderline resectable has become resectable or not. This quickly, in just 2 months, you may find radiological picture could be the same. So these decisions are generally taken upfront at the time of starting neoadjuvant chemotherapy, whether this patient is ultimately resectable or not. We are just trying to see the progression of the disease. If there is a progression of the disease, that is the information which we are trying to get.
You're right, but it still assumes extreme importance. And I'll tell you why it assumes importance. What percentage of patients which you have chosen are deemed operable before starting chemotherapy? What percentage of them drop out from a chance of surgery after 4 cycles when you evaluate them with a follow-up CT scan in your practice? Then I'll tell you what is the data out there, but what is the percentage of patients who cannot be operated now after 4 cycles of chemo?
So just considering 4 cycles of chemo, actually speaking, if you ask me this, we don't operate at for just 2 months. We try and give either 2 more cycles or even more than that. And sometime we have considered even adding the radiation also into this. So,
Right.
so it depends, you know, what
Yeah.
kind of a disease upfront you
So
have.
I think what I want again the audience to understand is that within the spectrum of borderline resectable pancreas cancer, you have the good spectrum, which is actually operable even on day 1, and a high chance of getting R1 resection, though the surgeon it's R0. So we sterilize them and also systematically give them chemotherapy, systemically give them chemotherapy, and they'll be operable. But there is the other half of borderline resectable, which is tending towards locally advanced. So I understand somewhere where Jagdish is coming from, but I want everyone to understand that there is a whole spectrum of BRPC, which I'm sure as we move along is going to get further reclassified into new groups. But again, for practical level, we need to look at 3 things, and that is the ABC of borderline resectable pancreatic cancer. One is the anatomy and the radiology. Second is where the CA19-9, which we spoke so much about, and the response, whether it's the same, whether it comes down or whether it's increased. And third is the C is the patient's condition. So if the performance status is same or improved, you are closer to surgery. If the CA19-9 is same or less, you're closer to surgery. If the radiology is same or less, you're closer to surgery. But if it goes the opposite, please look at the ABC of BRPC. Moving on, one line answer, Karthik. BRPC, you do upfront or first chemo and surgery or chemo, radio and surgery? One line answer.
Chemo followed by surgery.
So B. Okay, Jagdish?
Combination of anything, you know, never upfront.
Never upfront.
So either
Okay.
chemo and surgery or C.
Yeah. Shivender?
Yeah, chemo followed by surgery most of the time.
Dr. Malik?
So what we do usually is chemo followed by radiotherapy followed by surgery.
Okay.
So we.
So how do your surgeons respond to the thought process of radiotherapy before surgery? Do they have any concerns?
See, before radiation, we have to exclude metastasis. So I think a laparoscopy would be reasonable to consider.
I think we are deviating. The main question just now is that the answer given by our expert panelist, who is a radiation oncologist, is saying that all their patients of BRPC, which are borderline resectable, get chemo and radio. So I'm sure it's a multidisciplinary decision. And I want to understand how their medoncs and surgeons take it together. I'm taking it for granted that there is no metastatic disease. It's only BRPC.
So our surgeons actually have no problem with operating after radiotherapy, because they know, and the literature shows that post radiotherapy there usually is no additional operative complications, and therefore they actually welcome it. We have a
and is it making better oncologic sense as compared to option B?
I believe so. I believe that when you're worried about vessels, it really makes a lot of sense to have radiotherapy before the surgery, because the radiotherapy.
What form of radiotherapy do you do?
We initially, for a very long time, we would give 50.4 grain 20 fractions, but now we are moving over to SBRTs, which is why we are doing chemo first, and then SBRT, and then surgery.
So is Reena Engineer, my colleague, there to make a quick comment?
Yes. Yeah, Shailesh, I agree with Indraneel. We have been at Tata now at least more than 3 years. We are practicing 4 to 6 cycles of chemotherapy, followed by SBRT, followed by surgery for the BRPCs, most of the BRPCs. And we don't have the final results, but yes, the R0 resection rate is to the tune of 96%, where radiotherapy has been given. I can vouch for the SBRT patient.
I think I agree with what Reena says, but I do make a differentiation. I don't make a general category of BRPCs.
Yes.
Because there is the other side where Reena should be more specific, since she's from an expert sector talking across the country.
The early BRPCs versus
early BRPCs. Yes. I respect the thought process goes to chemo and surgery without radiotherapy. The
Yes.
more advanced BRPCs, I'm on the side of radiation oncologist and Reena, who is my friend, of course. But now I have to meet her on a symposium. She doesn't meet me in the same hospital, you know. She's a busy.
Shailesh, can I just say something?
Dr. Shailesh, I would like to know your experience of operating on a radiated patient.
We will come to that step by step. We have time
So,
constraints.
Shailesh, just 2 points I would like to make. One is many of the surgeons are not very comfortable.
Who is speaking?
This is Dipanjan.
Tell me, Dipanjan.
There are 2 points. One, many of the surgeons at this our center are not very confident on operating on post-RT, and secondly, post-RT, they're giving chemotherapy, the dose are always compromised. So if we can avoid radiation and do an R0 surgery, that is preferable. But if a post-chemotherapy, you still find it is unresectable, I'm fine with radiation. But the final decision lies with the surgeon.
Sure. So I think all these things show us how we as a multidisciplinary clinic in our own hospitals deal with every patient. And this is what I want to bring out in this panel for this group. Now let's look at the evidence. Meta-analysis, 2 of them. This is 2016. There is another one in 2018 in the BJS. But essentially, it shows you something which is very important. And what it shows is that you clearly get a better R0 resection rate. If it is gemcitabine based, it's a little bit less as compared to FOLFIRINOX. So it confirms. But mind you, please choose your patients well. Please choose your medical oncologist well. And please choose your hospital facilities well, because FOLFIRINOX does cause a fair bit of grade 3 and grade 4 toxicity, which can't be ignored. So we need to keep it in mind. Now, just before we go to something else, what is the role of adjuvant chemotherapy in any resected pancreas cancer? Resectable disease, borderline resectable, locally advanced. This is just an example of a patient whom we have resected. YPT3N0, lymphovascular invasion present, PNI present, 2 surfaces positive with good surgery, no nodes involved. Now, the surgeon, any role for additional lymphadenectomy in hindsight should have been done?
Routine.
I would say that there is no defined role of extended lymphadenectomy.
Fine. Okay.
But I believe that all surgeons would be removing lymph nodes to the right of the hepatic artery. But I usually now, for last year or so, always do a celiac axis node dissection as a routine practice.
Jagdish, a quick comment about lymphadenectomy in pancreatic cancer?
So there is no role of extended lymphadenectomy. And answering your question on to this role of adjuvant chemotherapy, I think I would like to know the tumor regression analysis here.
I don't have a tumor regression analysis, but this is the report I have, and I have sent this patient to you. Will you give him chemo or not give him chemo? Or will you give him radio or not give him radio?
So
this is the report I have, or kuch kiya hi nahi hai maine.
But what about neoadjuvant?
Yeah, it's given. It's post-treatment. Neoadjuvant chemo has been
received RT, and I
how
doubt
much?
would have never received RT.
Okay, so my radiation oncologist is confident that the medical oncologist failed because the margins are positive.
No, so the role of chemotherapy and radiotherapy is different in this scenario, and I'm sure with confidence I can say that a margin would come negative if radiotherapy would have.
Reena is right that this patient was given neoadjuvant chemo and not radio. That's fine.
And I would also like to see the pre-op picture for this patient.
Reena, we have less time, but your point is well taken and conveyed. Now about adjuvant. Okay, the radio is not given, chemo is given, surgery is done. Now, competent, complete R0 is done, but this is the path report. Now, I want people to tell me, Dipanjan, only adjuvant
chemo radiation. I would like to know, first of all, what adjuvant chemo has been given.
FOLFIRINOX was given before, 4 cycles.
So if the baseline image has, and compare with the post-op image, it has shown a significant regression, I would like to continue with FOLFIRINOX, but in that case, since the margin is positive, I would like to add radiation for the local control. Okay. But if there is not significant response with FOLFIRINOX, I would like to change to gemcitabine-based chemotherapy and along with radiation. But whether the radiation, the chemo radiation part would be with gemcitabine or 5-FU or capecitabine, I think I would prefer capecitabine because gem plus radiation seems to have a little more toxicity.
So is there any medical onco? I got your point. Reena would also tell me it is local problem, so we must give radiotherapy and chemo, and I think I might agree with her in a group discussion. But is there any medical oncologist on this panel who says that it's a systemic disease? We have given chemo before, surgery has been adequate, whether the margin is positive or not, local recurrence rate after good surgery is less important in a systemic disease. We don't want to give radio, we want to give only chemo. Any medical oncologist on my panel who says that or no?
Yes, can I comment?
Yeah, Viraj, please.
So I would like to just finish 6 months of total chemotherapy, depending on how much was given in the balance in the neoadjuvant part.
What were given?
The evolution of trials over last 30 years, our retroperitoneal margin positivity rate has continuously increased.
Yeah.
The latest trial is 40%, but still we have also, that's the slide. So, and the 5-year survival has still increased. So
Yeah.
I think we have improved in surgery, and I do not think there is a role of radiation in this.
So if you say this, you know, Reena would kill me in Tata. Who is your radiation oncologist? Do they kill you when you say this?
So he's here with us.
Who is he? I want him to talk.
Viraj.
No, Viraj is the medical oncologist. Jagdish is my old friend. Who is your radiation oncologist? I want to see him or her.
Samir, are you there?
I'm here, sir.
He's hiding.
So Samir, bolo yaar, Reena is already staring at me. Samir.
Ma'am, for R1, I would definitely consider adjuvant radiation.
So tell Viraj next time that these kinds of cases, nothing doing, no radio, no only chemo, integrate radiotherapy also.
In the new
I would go further and tell my surgeon that it was an opportunity loss.
Yes,
I think
I
this,
would agree with you.
Why will you tell the surgeon?
I would beg to differ that. I would beg to differ that. I don't think there is any serious head-to-head comparison that retroperitoneal margin failure.
No, it is a vascular margin. It's not retroperitoneal.
No. When he means the same. He's right.
Yeah. But
maybe senior, so I will raise my case, but I will not comment more than that.
So Viraj, how many minutes do I have? Viraj, how many minutes do I have more?
No, we have 5 minutes.
Okay. So now just to quickly conclude, I want the audience to understand that at the turn of the century, the first SPECT trial reported a 19% R1 rate. Pathology came in a big way in 2005. The Leeds protocol came up in 2004. And then you see the R1 margins, despite more radical surgery, has now reached 60%. We even have SPECT 5 now, but it has reached 60%. Having said that, I know that the earlier radio was different and now we have better radio. But just looking at the SPECT trials, the 5-year survival has still increased. So also the median survival. Now we are not looking at our individual specialties. I'm trying to convey a message that though it's a bad cancer, we have improved and we hope to improve more. How do we hope to improve more? I think we must acknowledge that there is only one randomized trial. Indranil made a part reference to this. This is my friend from Korea, but there are challenges with this trial. There is no difference in real long-term survival, but yes, there are some differences where you have oncologic benefits of neoadjuvant chemoradiation. So I want my surgical colleagues to be not closed to the thoughts of chemoradiation in some cases and keeping the option open of chemotherapy in almost all cases of BRPC. So that's where I would say that radiotherapy is getting a resurgence, and rightly so. But yet,
just add a point, Shailesh, about the ease of surgery or the difficulty of surgery.
I'm yet to come to that because we are yet to publish a lot on that. But I'll just quickly finish. Then if we have time, I will comment because there were these issues raised by Dipanjan and you also. So we will address that. But here again, in favor of radiotherapy, retrospective study. But if you get a complete path response with radiotherapy, you have very impressive differences in your Kaplan-Meiers. And this I want every pancreas specialist to be aware of. Of course, retrospective, not a huge data, not level 1 evidence, but from a center which is doing good work, and that's the Johns Hopkins. Chris Wolfgang is a good surgeon, a good friend of mine, and Jin He is from China, but who works in Johns Hopkins. And this is a good multidisciplinary group which has shown good results. I don't have time to touch upon the fact that here we have also reached a stage where you will have things where you can actually improve the outcome of pancreas cancer, whether it is the PARP inhibitors or whether you want to deal with issues like immune checkpoint inhibition, which our medical oncologists would be able to use in a few cases, very few, but that's the progress in molecular biology that we have done. I'm going to round off in a minute or two by sharing with you, by not asking you questions, but showing you the next frontier beyond borderline resectable pancreas cancer. So this is a lady, maybe Reena will know, but she may not know, a breast cancer case operated in 2014. I'm not going to go into details. That's why I'm jumping slides. But last year she developed jaundice, pancreatic head mass, dilated pancreatic duct involving the vein, dilated bile duct, lymph nodes. Look at the CA19-9 level, and the bilirubin was high. We reconfirmed that this was not a recurrence of breast cancer. We confirmed that it was a second primary, and now this was the upper end of borderline resectable or locally advanced, not the early BRPC, the near locally advanced BRPC. And she received initially 4 cycles till March, but she actually received 8 cycles of chemotherapy. Reena will be a little bit angry with me, but I will show her why we did what we did. These are the pre-chemo scans. You see the celiac axis and a bad disease sitting at the flying bird sign. And you see that celiac origin is free. And you have a trifurcation involvement of common hepatic artery and splenic artery. Bad disease, metal stent to drain obstructed jaundice, withstood systemic chemotherapy excellently. Very good performance status, but vein also involved. So there was venous deformity and venous distortion, which you can very clearly see, but distally the SMA and the superior mesenteric vein was not involved. So on this background, we have done a PET scan, localized disease, no metastatic disease anywhere else in the body, essentially a patient with locally advanced pancreatic cancer. 8 cycles of chemo. You can see Dipanjan, no real change in size, but excellent performance status. Patient virtually asymptomatic, no jaundice, everything looking good to us as surgeons to attempt a massive surgery. But there were some things which were not great. For example, the CA19-9 did not decrease in this case. So conventionally, this case, 9 times out of 10, we would say it's an overkill and let us give radiotherapy. Now to answer Reena's concern, that if it is a simple borderline resectable pancreas cancer requiring only a vein resection, we have no problems with radiotherapy. I can make this statement. The minute I think of an arterial resection, I have huge concerns of radiotherapy, and I place it on record on the basis of a lot of experience abroad and my training, but also a little bit of experience in Tata. We are doing our prospective study a few years down the line. I'm sure we'll share with you the surgical outcomes of this difficult group. In this patient, we would have loved to give radio, but since we planned an arterial resection, we decided to stick to chemo, accept the fact that CA19-9 has not gone down, but decided to operate on her. This is not routine, and this is not heroism either, but we did a portal vein resection. An accessory artery was resected accessory, and you can see 2 anastomoses, left hepatic artery, right hepatic artery, and celiac axis. We did in this lady total pancreatectomy. She has come back to see me a second time, and very soon she will be starting her chemotherapy again in 2 weeks' time. This surgery was done less than a month ago. What am I trying to bring?
Dr. Shrikanta, what is the BRCA mutation status?
In this case, I do not know as of now, but we will look at this because she just came post-surgical follow-up. She will come up again, and I will certainly, thanks to this moderation and inputs from all of you, I will look at the BRCA mutation as well. Am I trying to say that this is the take-home message from this panel discussion? The answer is no. I'm only trying to say that just the way we have reached the stage of BRCA, just the way we have reached the stage of SBRT, just the way Reena is so confident that you will get better R0 with radiotherapy, I can also tell you that some patients of locally advanced pancreatic cancer with multidisciplinary care would also benefit from surgery. This is the message of the whole team. It's not one surgeon. This is our entire DMG. And see how scared I am sitting next to Reena. So you can see that in this picture. So I'm surrounded by good pathologists, good medical oncologists, and also good surgeons. I think I have to stop here. I wish you had given me an hour and a half, and we would have discussed more things in pancreas cancer.
And just one point, originally it was not discussed. This is the very reason we need a US guided biopsy and not FNAC, because you need tissue for various mutation study, which is coming up.
Which is true. And if you, whenever you can get a biopsy, I agree with you that immunohistochemistry is much better, easier, and more detailed. If you just can't get, then we have to work with an FNA, but otherwise an US biopsy is fine. It's about affordable. There are multiple factors which come in. Any last comments from my panelists? I'm done with. Shivender, Dhaval, Deepanjan, Indranil, Dr. Datta.
Your experience of operating on a radiated patients.
So in straightforward BRPC, not a big problem. Okay. Straightforward BRPC.
Okay. But multidisciplinary team is the best answer. If you have a good surgeon and good radiation oncologist and a good radiologist, you are only as good as that.
Yeah, like all of us, we are just now an MDT.
Dr. Deepanjan, good medical oncologist also.
That's a medical oncologist perspective. That somebody else will say.
Fine. Right. Okay. Shall I take your leave?
Great, sir. Thank you so much.
Thank you so much.
Thank you.
Excellent.
Thank you, everyone. Thank you.
Thank you, everyone. Thank you so much. Thank you. Bye-bye.
Viraj, next panel.
Yes, sir. In the want of time, we should move on.
Yeah. Invite the next panel.
Okay, so the next panel is on esophageal cancers, and we have Dr. Subramanieshwar Rao, sir, from Indo-American. He does not need an introduction, and these are the following panelists. Sir, the screen is yours. Rao, sir, are you there with us?
Yes, Viraj, thank you very much.
You can share your screen.
Yes. Can you give that to me? Yeah. Now, if you have to sum up where we are in oncology, I think it's the era of multimodality therapy, and then it's an era of molecular oncology. What we are going to touch upon now is the essence of multimodality treatment and what it has done to esophageal cancer treatment. That is the panel, and panel has been chosen by Jagdish Bhai and Viraj and others. And I was actually surprised that it's a very novel panel, not the novel coronavirus, but it's novel because there is no medical oncologist in a sponsored panel, and the absence of a medical oncologist must have been with a purpose. And
you have a Dr. Viraj. You can.
Yeah, I know. And Viraj has promised me that he will chip in if we actually need him. When you are discussing standards of care in surgery, 3 procedures are actually described world over. If you are comparing standards between systems, standards between countries and continents, CABG, hip replacement, and esophagectomy. So it actually sums up how important this procedure is. In countries where you can do this procedure with better cures and less mortality, it's an indicator that the country is actually has a higher position in medical fraternity. Similar issue, can I get this out? Yeah. Similarly, radiation itself is extremely important. Just as expert surgical skills are required for a successful esophageectomy, radiation field design for esophageal cancer surgery requires careful planning. The first sentence in Cancer by DVITA when they talk about radiation oncology, which means these two are extremely important and they can never be mutually exclusive. We're not going to discuss what gets discussed every day before the webinars and after the webinars have started. We won't discuss transthoracic versus transhiatal, two-field versus three-field, adjuvant versus neoadjuvant, CT versus CT-RT, neoadjuvant, and open versus MAS. We would only discuss how you can actually, the surgeon can make the radiation oncologist more comfortable, and much more how a radiation oncologist can actually make surgeon comfortable and safe. A 68-year-old gentleman, no comorbidities, smoker in the past, difficulty in swallowing food for 4 months on a semi-solid diet, recent weight loss, no other problems. PS1, upper GI endoscopy shows an obstructive eccentric lesion at 30 to 33 centimeters with a stricture. Endosonography, heteroechoic lesion at 30 to 33 centimeters breaking through muscularis propria and at one place through adventitia. No invasion of surrounding structures, so it becomes T3, no nodes. Biopsy shows squamous cell carcinoma. A PET CT was done, which shows a circumferential thickening in mid-esophagus with luminal compromise. Non-avid to esophageal lymph nodes. Cardiac workup was normal and pulmonary function tests were also normal. I would want to start with Harit Chaturvedi, probably the senior most panelist, because he would have seen that these patients, when we were trained, when he was trained and I was trained, and when Sumesh would have been trained, these patients would directly go for surgery. Would that happen now, or does he do anything different? Harit bhai, you are there? Sumesh can take that if Harit is not there.
Well, hello everyone.
Yeah, Sumesh.
I'm not at all tempted to take up this patient for surgery straight away. Not anymore.
Not anymore. And what makes you send this patient to pre-op chemo?
There are good reasons. We know that the results of trimodality therapy are far superior than a single modality surgery for such cases. And the trimodality therapy is as safe and as practicable as the single modality surgery.
But you could do the other modalities later on. We have not excluded modalities by choosing surgery upfront, is it not?
Yeah, the best evidence is for upfront neoadjuvant therapy. That's one. Second, if you these are potentially hazardous surgeries. The incidence of major postoperative morbidities are pretty high, and you may end up delaying any adjuvant therapy. The adjuvant therapy has never been shown to be as effective as the neoadjuvant protocols.
Wonderful.
So, Dr. Rao.
Yeah, Archit and Devendra want to add? Yeah.
Hi, sir. Good morning. Sorry, good evening. So, sir, apart from it being a T2 and above lesion, and also that me and Dr. Vinita share the same corridor, her room is right in front of me, I would dare not go for an upfront surgery in this case. And neoadjuvant treatment, as rightly said by Dr. Sumesh, sir, that it has definitely better evidence as compared to an adjuvant one.
Okay, Devendra, what you say a word?
Sir, T3 lesions, I'll put it as a locally advanced esophageal cancer, and for this type of lesion, risk of lymph node metastasis is as high as 70%. So yes, neoadjuvant therapy is the way ahead.
I do not want to cut a sorry figure as a surgeon when the pathologist reports that this is an R1 dissection. There's a chance that at least 30% of such upfront, if such patients posted for upfront surgery, would end up with a positive margin.
So, Dr. Rao, I'm Dr. Kothari.
You're worried about yourself as much as you are worried about the patient, Sumesh.
As a surgeon, you have to be.
Yes, yes. Okay. We'll move
Dr.
on.
Rao.
Yeah, yes, yes.
Dr.
Yes.
Kothari. So, I'm reading a couple of things here in your...
You are also there, I'm sorry. You are the senior most.
Yes. A couple of things I'm reading in your presentation is it's a circumferential disease.
Correct.
And a T3 disease which is breaking somewhere through the adventitia.
Correct.
So, that's where doing direct surgery, I'll not be able to make it R0 resection. And no adjuvant therapy in past has proven to be effective for esophageal cancer. So it's all, in the history that adjuvant therapy is going to help me for a R1 resection. I'm comfortable only in a pure non-circumferential, definitely T2, up to T2, definite N0 lesion, which is extensively investigated. There only I can do upfront surgery.
Which is a rare event in an Indian context, is it not?
Yeah,
true.
Okay, Archit, you want to chip in? What are the factors you try to evaluate to consider suitability for fitness for trimodality therapy?
So, sir, I would say, since you have said that the PS was 1, so I'm considering that this is a fit patient. Age is, I wouldn't consider age a barrier now that minimal invasive techniques are there. We are not here to discuss minimal invasive techniques. The nutritional status of the patient and so on and so forth. So these would be my factors to consider the suitability for trimodality therapy.
What would you be worried about, chemotherapy or radiation before surgery?
So I generally prefer chemoradiation above neoadjuvant chemotherapy before the surgery.
Devendra is there?
Yes, sir, I'm here.
Yeah, he was answering.
So same as said by Dr. Archit, but I would like to add one thing that I would like to evaluate the amount of weight loss, if at all there is. That's how I will be able to evaluate whether this patient is going to go in obstruction or not. That is also one important thing which we need to understand at this point of time, because this is a circumferential lesion, and if at all that patient will end up with obstruction during therapy, then it will substantially increases the morbidity related with neoadjuvant therapy.
Which means would you want to say that if the patient is getting obstructed, that would become a reason for you to choose surgery upfront?
No, sir. No, not at all. Not at all.
You would do something to circumvent the obstruction. That's what you would want.
Exactly. Yes, sir. Yes, sir. Yes, sir.
Wonderful.
See,
you are sending the patient for chemoradiation. What are the things that would worry you, Jagdish?
One important thing I would be worried about when I send the patient for chemoradiation is the patient or the relatives should not be able to kind of influence the radiation oncologist into believing that this is a patient who is fit for a single modality or double modality definitive chemoradiation.
You should send the patient and see that the radiation oncologist holds the patient very close. You talk about non-compliance of surgery, which is a very serious matter actually. That's something that I thought one of you would highlight, because in a teaching institute, in our own center, 40% is the dropout rate after chemoradiation. So that is probably the only complaint that I have, and that's what Sumesh also was trying to stress. Non-compliance to surgery, yes. So
we should all be talking on the same lines, the radiation oncologist, medical oncologist, surgeon.
Yeah, so the completion of treatment is something that is extremely important. So I think you must individualize the sequence of treatment according to the patient also. Yes. So we have been trained to do upfront surgery with a tissue that is native, virgin, and then the shift to radiation therapy, especially chemotherapy, was also worrying in terms of systemic toxicity. and problems associated with them. But once radiation was introduced, I for one picked it up much later than most others in the country. And these were the worries. So would you all be worried about the possible increase in pulmonary complications and anastomotic complications? Anyone can pick it up.
If I can take that question, as far as anastomotic complications are concerned, at our center we are not seeing a lot of difference when the patient is treatment naive or post neoadjuvant chemoradiated patient. So that is not a big concern. To go with pulmonary complications, we would like to evaluate that patient in terms of pulmonary function test prior to starting any therapy, and we make sure that all our patients undergo prehabilitation as soon as we start with neoadjuvant chemoradiation. So that is one important aspect. So about those two things.
Would you do a evaluation of the lungs specifically by an imaging system? Anyway, you would image, but would you have a look at it, not the lesion itself, but the lungs also?
Yes, sir. Absolutely, sir. So in our multimodal team, we also make sure that our intensivist also see the patient before starting any form of therapy. So even before starting neoadjuvant therapy, that patient is referred to our intensivist, who will also take care of her lungs, because many a times those patients in Indian setups have some associated pulmonary problems. So it is better that those problems are taken care well before they are subjected to surgery.
Very heartening to understand this, Devendra, Jagdish and all. Really congratulate you for this, because we don't do this. We can't afford to do it before it goes for radiation therapy.
So the routine,
so much, yes.
The routine practice is to have a set of consultations before radiation is started, and that includes meeting the nutritionist, that are dietitian, the pulmonologist, and the physiotherapist. They all see the patients. Patient has a PFT upfront before starting the radiation, because the lungs are as important for the radiation oncologist as they are for the surgeon.
Anastomotic complications, you are worried so much?
Absolutely. I would like to add here that I personally am seeing a little more of non-leak anastomotic strictures than I used to see when I was doing upfront surgeries.
So not leaks, but strictures.
In the anastomotic strictures, because my technique has remained the same. The leak rate has remained the same. But I'm seeing a little more of anastomotic strictures even without leaks after adopting chemoradiation. That's my only concern. I have no intraoperative concerns with chemoradiation. In fact, neoadjuvant chemotherapy using paclitaxel causes as much surrounding fibrosis around the tumor as possibly a chemoradiation does.
Yes.
I would say, sir, that anastomotic complications can further be reduced before starting any kind of neoadjuvant treatment if there's a good harmony between the surgeon and the radiation oncologist. For example, a simple maneuver that a radiation oncologist, especially at our center, like sparing the fundus of the stomach, and things like that. And if the fields are wide, then how do we tackle such a scenario? And if these situations are confronted between a surgeon and the radiation oncologist, just like a simple maneuver like sparing the fundus can actually help in reducing the anastomotic rates at a greater level.
Perfect. I think
Can I add a point here?
Yeah, Vinita. Please go
Sir,
ahead.
I'm a radiation oncologist, and when you talk about taking care of the pulmonary complications which can occur post-surgery and rehabilitation, I think all radiation oncologists should take up this responsibility. We also do it at our center, that while patients are on radiation therapy for 5 weeks, every time we meet them in our weekly reviews, we remind them for brisk walking, spirometry, etc. And also, constantly counsel them for maintaining their nutrition, including high protein diet. And as Dr. Archit mentioned, initially when we started with pre-op CTRT, 2 of our patients did have anastomotic complications, and those were 2 sequential patients. And this is when Dr. Harit caught me and he asked me, what are you doing? There's something wrong with your radiation. I have not changed my technique. And that is when we learned that if we spare the fundus of the stomach while planning radiation therapy, it definitely reduces the anastomotic complications. And after that, we did not see it. I think these are
How do you manage dysphagia, Vinita?
Sir, we never put peg tube or any stent, etc., because that makes life much more difficult later on. So if patients have dysphagia, they generally get Ryle's tube insertion.
Ryle's tube, yeah.
Yes, sir, Ryle's tube insertion.
Correct. See,
Nasogastrectomy.
for the surgeons in the panel, how comfortable would you be if the patient has been stented?
So, Dr. Rao, if I want to make a point here, stent or even PEG tube is not a problem. We almost never put the Ryle's tube. We do not want our patient to have a 24 hours having a nasogastric tube, which is bothering him, and not, I mean, no problem ever with either of these two. So about 10% of our patient will require either of these two. So we have 3 patients who were stented prior to neoadjuvant chemoradiotherapy, and about 5 patients have undergone a PEG prior to surgery. I mean, prior to neoadjuvant chemoradiation.
So would it not make your surgery much more difficult?
No,
Stent
not
especially.
really.
PEG has its own problems. See, PEG is not something that you do it, and if it is done from the greater curvature, and if there is an injury to the epiploic pedicle, which are all reported, I would personally prefer, and we continue to do in-tube intubation only. Although it's uncomfortable, it's probably a little more easier for you to operate.
I would like to say one thing.
Any other opinion? Yes.
Sir, so now, as sir said, a lot of our patients are undergoing PEG insertions, and fortunately our medical gastroenterologists know the amount of surgery we do, and they usually try and go from the laser curvature aspect towards the abdominal wall. So injuring pedicle, epiploic pedicle is very rare, and as far as PEG coming into the future conduit comes, we have made a protocol of taking out the PEG at least 7 days prior to surgery, and I'll be glad to say that most of our PEG sites at the time of surgery are so well healed that many times we are not able to appreciate where was the puncture of the PEG site.
Unless there is a tract that is running towards the stomach, yes. We have also seen something like that, but I was always concerned, although it has not happened to us, because we don't do PEG too often. Any other difference of opinion?
Sir, I have not come across any situation wherein we could not pass a FRECA or a Ryle's tube. Yes.
Correct.
And that is our preferred modality. I have never used a stent or never ever used a PEG as a fact. We have done post-esophagectomy in 3 patients in whom we had inserted stent for perforation during an endoscopy. And trust me, it was a very difficult resection, probably because of a mediastinitis that has been formed.
I would have wanted to ask Jagdish Bhai and Devendra, how easy it is to do a PEG when patient has absolute dysphagia. How many of them would you be successful in passing the endoscope and then doing it?
So, sir, if
would it be
Devendra, go ahead.
Universal solution for the problem?
Yes, sir. So if there is absolute obstruction and they are not able to pass the endoscope, then instead of preferring Ryle's tube, we would rather put a proper feeding jejunostomy, which will be used even in post-operative setting as well. So our criteria is, our idea is very clear that we are not putting NJ tube. Either we will go for PEG or we will go for open feeding jejunostomy, which will be later on carried out even after post-operative phase.
Dr. Rao, I would like to add here, see, our patient profile is little different, and the way, gastroenterologists are able to pass the guide wire and putting, they will dilate it and are able to put the PEG very, very comfortably.
No, but what I've always believed is anybody who can get a PEG would not have enough dysphagia for any intubation. Is it not?
No, actually, once they dilate, then they are able to put the scope inside and subsequently PEG. Before dilatation, it may be dysphagia of substance that they may not be able to take adequate quantity.
It's very interesting. Actually, in the introduction, Jagdish Kothari said multiple solutions to one problem. So these seem to be multiple solutions to one problem. It's very interesting.
So use of
from here, yeah. So
use of a pediatric endoscope is often done.
Yeah, so much by. Please
A
go ahead.
pediatric endoscope is often used by the endoscopist.
For the PEG, is it? That's interesting. Once again, because PEG is a procedure which is not difficult but not too easy also. Anyway,
Yeah, but
esophageal stents, a big analysis says esophageal stents do not actually improve too much of nutrition.
In most of our neoadjuvant patients,
I found I have not done a stenting for cancer at any point in time, but I have been working with Asian Institute of Gastro-Enterology for corrosive strictures. To do a esophageectomy in a corrosive is one of the most difficult things, and this stent actually fistulated into the trachea, so we had to remove it. Such a difficult thing. So I always thought stents make the thoracoscopy part of it much more difficult. Anyway, but Gujarat group has
Sir, this is covered stent, and we always put a clip also, so it's not never uncovered stent, and always clip is required, otherwise it may migrate also. So these are the two things which we are very careful about.
That's a good message. Yes.
I guess most of my radiation colleagues would agree that what we have seen in our clinical experience, that most of the patients who come with
Vinita, you're not audible.
dysphagia.
Samir is speaking.
Samir, okay.
Samir, you are not audible.
Just a minute. Am I audible now?
No.
Am I audible?
No.
Hello.
No, Bharati.
Yeah.
Yes, sir.
Is there?
Sir, so what?
Yes.
Yeah, Samir.
So can you hear me now?
Yes.
What I believe my radiation colleague would agree that most of our patients, they usually come in absolute dysphagia, and after 2 or 3 weeks of radiation, in fact, we have seen a lot of time we are seeing weight gain. In fact, their diet improves. So hardly we don't require a PEG, NG tube or a stent. We prefer a stent only if there is a fistula or something. Otherwise, most of the patients they don't need these things. This is what, of course, nutritional counseling is very important. A proper diet is very important. This is what we also ensure that our patients should take.
That is the best way to do it.
Adequate protein-rich diet. But I guess in our 300 plus patients, very few have required all these things. This is what we have seen.
Yes. Actually, on radiation, 70 to 80% patients will respond to radiation for dysphagia.
Most of the time, we are dealing with squamous cell, and they respond fantastically with radiation.
Yes. And even 50% of the patients will be relieved from dysphagia in 2 weeks, and 80% of the patients will relieve from dysphagia around at a month or so.
So at AIMS, you don't do anything? No NG tube, no stent?
No, we prefer RISE tube.
Okay, NG tube, okay. Anyway, Bharti, can you answer this? Steps to reduce post-CT morbidity, because your aim is to make the surgery much more comfortable.
Sir, can I join in? There is a question in the audience.
Yeah, please.
Instead of PEG, can we do feeding jejunostomy? And the second question is PEG can cause the margin problem. So
correct. That has been answered already. Feeding jejunostomy is an option, and you can do that minimal access also. Devendra, you are such a good minimal access surgeon. It can be done minimal access also. How do we reduce the chemotherapy radiation morbidity so that the surgery becomes more safe? Bharti or Vinita?
Yes, sir.
Yeah.
Sir, first thing is the patient selection is the utmost important.
Okay.
And then the technique is, yes, sir. And then the dose of the radiotherapy which we are choosing, if we are giving in pre-op as post-CTRT morbidity. So if we are giving in pre-op setting, then the 41.4 gray is enough. If we are giving in radical setting, so the dose should be modified according to the intent of the treatment. And then the patient-related factors should be taken care. And then the technique that low dose volume should be reduced in the lung. And as madam also highlighted earlier, that we encourage our patients to do physiotherapy like incentive spirometer, which is a very, I can say, very feasible option to do to reduce the lung morbidities.
So the machine and the man or the woman, both are women radiation oncologists here. Both are
Yes,
important.
sir.
That's what you mean?
Yes, sir.
Yeah.
So can I emphasize one more point here?
Yes, please, Sunita.
Dr. Rao, ever since we've started doing pre-op CTRT, my surgical colleagues have taught me to think like a surgeon as to what are the challenges that they are going to face while they are operating on these patients. So my message to my radiation oncology colleagues is that when you are doing contouring, you have to understand that surgeons might face a problem with aorta, the margins towards aorta or left atrium or bronchus or carina. So we have to always make sure, although we have to reduce the complications also, but we have to make sure that these parts are well covered. These are adequately covered in your pre-op CTRT. Only then radiation will be effective.
Wonderful.
There is also
It must be a very popular radiation oncologist, Vinita.
Sir, one last question.
With the surgeons, yes.
Is there any role of TPN in pre-op setting? There is a question from audience.
Is there a role of?
TPN.
TPN.
For nutrition.
Yeah, most of the patients can be intubated one way or the other. So TPN is very, very rarely done. The AIMS group tells you that they don't need anything actually. Most of the patients open up with radiation itself. So that is much more, very, very heartening.
Correct.
Yeah. Okay, we'll go forward.
So taking that question, I would like to know your experience also. Like I personally don't feel that there is much of a difficulty in doing a surgery post chemoradiation. I don't know if it is because
it's not post chemoradiation, post stenting we are talking about.
Okay,
post chemoradiation, yes.
Post chemoradiation.
It's something that is projected as a problem. So, can radiation oncologists do anything more to actually decrease the chances of a difference between upfront surgery and post radiation surgery? See, the difference, you are not making out the difference because radiation oncologists have improved so much.
Improved so much, yes.
And you're too young to understand what we have gone through.
What you have gone through. I thought so. I thought so. I got that.
Yeah,
I don't know whether it is a compliment to radiation oncology.
Actually, it is. The cross trial, which we are practically following for almost all patients now, because we see a lot of squamous cell carcinomas. Initially, when it was published in 2012, it took us some time to actually get comfortable with the idea of operating on patients post chemoradiation. The biggest finding was not that we'll get very lesional fibrosis and difficult dissection. The concerns were post radiation pneumonitis and fundal radiation.
True. As such, see, Arjit, the leak rate when we were trained was 60% in an upfront procedure in the neck, 50 to 60%. You can imagine a virgin stomach leaking so much, and then you do radiation therapy. What was going through our minds, and as such, there was so much of reluctance to offer surgery for these patients. So much of work was done by the seniors, and then the machine and the men and the women have improved so much. You are all very comfortable in operating much smaller lesions. After radiation becomes small, and you have become big surgeons because of small lesions. Anyway, we'll continue. How do you reduce anastomotic complications? It has been addressed already. This is what Vinita was talking about, I think. It's her slide, actually.
Yes, sir.
Yeah.
Yes.
Yeah. You want to talk about this? You sent this slide. Yeah.
Yes, sir. So we did give radiation to this patient who was being discussed in the first slide, in the initial slide. And I was quite comfortable with the radiation plan because you can see that the dose spillage is much reduced towards lungs. And we never do rapid arc or rotational IMRT for these patients to reduce the low dose lung doses. I think that is something very important which one should keep in mind. Could you show the next slide, sir?
Yeah.
We achieved almost what is recommended and desirable. Our bilateral lung mean dose was 14 gray V5, which is low dose was only 60%. Next slide, sir.
Yeah.
But by the time he completed his radiation 6 weeks later, when he was supposed to get operated, Dr. Archit told me that he was having persistent cough, and we got suspicious that it could be radiation pneumonitis. When we did a response assessment PET scan for him, it did show that he had pneumonitis towards the basal part of the lung posterior segment, which corresponded to the low ISO doses. So I think this is one of the fallout of concurrent chemoradiation, especially when it is given along with paclitaxel. Paclitaxel is a strong radiosensitizing agent and also by itself causes some amount of radiation pneumonitis. I think the most important thing is that if your patients have a radiation pneumonitis, we all must recognize it, accept it, and treat it well. And the treatment is usually done with inhalational steroids followed by, if required, oral steroids. And he did respond to that.
So Vinita wants to tell us that radiation pneumonitis is because of chemotherapy.
No, sir.
I have got questions regarding radiation oncology. What's the role of tomotherapy and proton therapy for esophageal cancers?
Tomotherapy is another form of linear accelerator, which provides rotational IMRT. So if I have a choice, I would, that's my personal call, that I will not treat a patient on tomotherapy, because the low dose lung bath, it increases with tomotherapy. While if I have proton therapy, I would always prefer to go for proton therapy in these patients, because it definitely reduces the lung and heart doses as compared to any photon plan.
Samir, do you want to comment?
Of course, I understand, but ma'am, I hope you will agree that
you're not audible, Samir. Samir, you're not audible.
Remove this.
You're still on, Samir?
Yeah. So I agree with madam, but with helical this is a concern, but with Tomo direct we have this option that we can give direct fields, but again this plan that becomes as good as a 3D conformal plan. But of course heart, as far as lung dose is concerned, yes, with helical plan it goes up and it is comparable with the VMAT plan, but with IMRT of course the low doses are definitely less. With VMAT and helical tomotherapy, I am not sure there is much difference in the low doses of lung.
So, Dr. Samir, we don't do VMAT for our esophagus patients.
Yes, ma'am. For IMRT, yes, I agree, ma'am,
Yes.
that it is better.
You want to
But for heart sparing, I would say, ma'am, that I guess we can spare it, but the lung is definitely a concern. We increases the low doses, but heart, like, we can spare.
Yes.
Yeah. How do we manage this? It's quite a problem now.
Sorry, sir.
Vinita, you want to talk about this also?
So, sir, generally these have to be, if the patients have mild cough, then the cough suppressants are good. But if it is not getting better, then they will require inhalational steroids. If it is still not improving or patient is having breathlessness, then we generally prescribe them oral steroids, which is in the dose of 1 milligram per kg body weight. And it is important to remember that one should not taper off steroids very quickly. So for this patient also we gave steroids and he responded quickly, and I think about 2 weeks later, Dr. Archit was able to operate him.
When would Archit not want to operate? Archit, you are there?
Sir, so I would be very skeptical to take up a patient for surgery if he has ascites, if his general condition is not very good, if there's a liver dysfunction, a cardiac dysfunction.
No. The patient who develops pneumonitis we are talking about.
So, sir, we have encountered 3 patients. So we have a data of around 140. We have encountered radiation pneumonitis in 3 patients who have been managed very well with steroids. And within 2 weeks, the cough completely resolves, dramatically resolves, I would say. And all that scary picture of infiltrates all along the paracardiac regions and the lung in that portal, and especially on the basal side, they resolve very well with steroid therapy. I think the key is to identify it as soon as possible, because you are losing on the time. That golden period time of 6 weeks is what the surgeon loses on, and you really don't want that to extend to 10 or 12 weeks.
So which means you have to be alert to this problem and then pick it up early and treat early. Okay.
Yes, sir.
Dr. Rao,
yeah,
I just
please.
want to, add this pneumonitis is a serious problem, and radiation as well as the surgeon needs to be extremely careful. We have a admission rate in fifth and sixth week after neoadjuvant chemoradiation in fifth and sixth weeks, about 20%. So we are very, very careful. This is the time where you could start seeing the patient is deteriorating in his condition. That is number one. And we lost one patient in his about 70s because of this radiation pneumonitis when he was ready for surgery. Even after 6 weeks, we of course did not touch him, thank God, but at the same time, unfortunately,
It could have been a post-op event also, yes.
yeah, so we lost this patient before surgery.
Bharti,
Yes, sir.
you were talking about hypofractionation in your institute.
Yes, sir. Actually, I wanted to highlight that issue that if the patient is not suitable for chemo and radiotherapy has to be given. So there are other options of except the conventional fractionation. So in AIMS before 2015, like before the updated cross came, some patients were treated with this fractionation, 25 rays and 5 fraction, followed by surgery. So the patients were like who have like poor PS2 or have significant dysphagia and weight loss. So the short course radiotherapy was given 25 rays and 5 fractions, followed by surgery within 10 days, 7 to 10 days. So this is one of the protocols which we were doing before 2015. So there was a data for around 20 years data of from 95 to 2015. And then there are also some UK protocols. One is from Leeds Cancer Center. So they are using 50 grays in 16 fraction or 50 grays in 20 fractions. So the patients who are not suitable for chemo RT, hypofractionation may be utilized, especially in this COVID time where we want to protract our treatment.
Yeah, absolutely COVID suitable, is it not? So you have been preparing for COVID for a long time. So,
last 5 minutes, so if we can.
Is this something that you have actually extrapolated from cancer rectum, Bharti?
Actually, no, sir. This is followed from 1995 to 2015. I think it is Dr. Mohanty's idea. I am not very sure about it. I don't think it is extrapolated from rectum.
I was in AIMS from 2008 to 2011, and my surgical oncology training was there. And fortunately, Dr. Mohanty was there. The whole idea behind this was that the waiting list at AIMS used to be for 4 months, 3 months. So they took that waiting list as soon as possible. This was a very good idea that because 25 fractions in 5 fractions, 25 gray, some amounts to around 40 gray, if I'm not wrong. So
it's a social adjustment for a scientific problem.
True.
But was it done primarily as a definitive radiation protocol?
No, it was a neoadjuvant protocol. And
Neoadjuvant.
you operate within 14 days of finishing the treatment, and you don't have to really wait for 6 weeks. So something like that.
Archit and Vinita, you want to talk about this dual agent versus single agent?
Sorry, in our experience, yeah. Sorry, Dr. Vinita, please go ahead. Sorry.
No, please go ahead. Please go ahead.
No, you women's first, ma'am.
Vinita, yes.
Sir, so the problem is that before cross trial came, we were generally treating our patients with single agent cisplatin alone. And many a times I raised this issue with Dr. Harit that let's add 5-FU in our pre-op setting. And his one typical answer was, patient ko is halat mein to rehne do ki hum operate kar dein. So we were all very scared, to give dual agent along with radiation. Everyone had their own concerns. But after cross trial, majority of us have shifted to dual agent with paclitaxel and carboplatin. But then there is still some subset of patients who are not fit for this dual chemotherapy. And I'm still okay to give them pre-op CTRT using cisplatin instead of carboplatin alone. And using cisplatin alone also avoids the risk of pneumonitis in these patients. So if I have a patient where the radiation field is pretty long, and I know that lung doses are going to be a little higher than how they are usually, then I prefer to give concurrent single agent cisplatin in pre-op setting.
And
These
your
are my thoughts.
medical oncologists don't object to it.
Sir, उनको ना थोड़ा पटाना पड़ता है. Very difficult.
Viraj is sitting there.
Yeah,
So
I know.
fortunately, he's not a part of the panel, so we can exclude it.
Sir, we'll need to conclude in next 3 to 5 minutes.
We'll take some questions then. We'll stop here. Doesn't matter. Yes. Anyway, the partial metabolic response, same patient. Surgery. What surgery? Timing of surgery? Starting with Jagdish bhai. Yeah. Somesh.
So standard protocol is we will evaluate at 5th week and generally 6 weeks. If the patient is otherwise fit, it is extremely important that my patient should be fit for a very major surgery. I am comfortable delaying by another 2 to 4 weeks. We are absolutely comfortable.
Somesh?
Yeah, so the thumb rule is that if there is a radiation for 5 weeks, then you wait for 5 weeks. At the end of that, you would maybe at the end of 4th week or 5th week, you would evaluate. You would use this period to build up the nutrition and pulmonary function of the patients, and generally you would operate in the 6th week or maybe the 7th week.
Ravindra, did you have an opportunity to do a minimal access surgery for a patient who did not get operated between 6 and 12 weeks, and you had to operate at 3 months, 6 months?
Yes, sir.
What happened?
Couple of patients where we have, as sir said, when there was radiation-induced pneumonitis, we have to postpone those patients for 4 to 6 weeks. After 6 weeks, so I have experience of operating those patients at the end of 3 months, 4 months.
Wow.
We have also done salvage surgery at the end of 2 years.
No, so salvage is a different situation altogether.
Yes. So I am comfortable doing thoracolap or robo at the end of let's say 4 months.
Anatomy was the same?
In infraesophageal compartment, yes, anatomy will be exact same. In supraesophageal compartment, there will be fibrosis. As time passes, fibrosis will be higher.
But fibrosis should be dependent on the field.
Location of the tumor.
Location of the tumor, exactly, sir. So in my experience, all those patients who have been operated delayed, I usually meet our upper thoracic esophagus.
Okay. So location bias it is. So ultimately, tumor undergoes desmoplasia, and it's all completely dependent on the field size, is it not?
Yes.
So vascularity is something that is lost. We'll stop here. Anyway, there are a few videos to show that this is something that is upfront. You can see vessels like this, and when you operate at 6 weeks, it is almost the same. On a good machine, if you have Bharti or Vinita as radiation oncologist, this is how it looks actually. Correct duration and not a very high dose. I think it is just as good as, and a smaller lesion. So we started loving our radiation oncologists more than ever. But what happens if you wait a little longer? This patient was operated at 6 months actually. Patient came back only when he developed dysphagia again. And that's how it can look. And you can actually see the radiation field here. Up to azygos, it's all fibrosed, unlike Devendra's patient. And then above azygos, it's all very, very virgin. So that's what happens. So I think it's indeed important, not just the dose, but the duration also is very, very important. We'll stop with this.
Thank you, Dr. Rao.
There is one question.
Jagdish bhai, Viraj, all the panelists, it has been a wonderful discussion.
Great.
So much we have learned.
Question, sir.
Simple things, but I think we have learned a lot from each other.
Viraj, before that, I want to ask one question to the panel. Dr. Rao, Ashish, we all know there's a very good data of the cross, but now there is a role of the neoadjuvant chemotherapy, especially in the gastric malignancy. So the question to all the panelists, what about the lower esophageal adenocarcinoma use of neoadjuvant chemotherapy, especially FLOT, and followed by surgery? So can anybody recommend?
So for CWAT1, the way Dr. Ashish is asking, we still continue to follow neoadjuvant chemoradiation for CIVAT1 in most of the cases. But if I'm concerned about the more lymph nodes area, or it's a poorly differentiated histology where I'm worried about possibility of a disseminated disease, I'll consider FLOT over this extrapolating data from CIVAT3 to 1.
More bulky disease, you consider neoadjuvant.
Long segment disease.
Same with us. Exactly same.
So neoadjuvant chemotherapy, sorry, yeah.
Go ahead, Archit. Go ahead.
So neoadjuvant chemotherapy actually turned out, the whole concept originated from JCO 9024 trial, wherein the Japanese are giving it as an adjuvant treatment, and in 9907 they actually made it as a neoadjuvant protocol as compared to the adjuvant chemotherapy protocol. And then the FLOT came for basically for the gastric cancers. But if we have to talk about the esophagus cancer, then probably a 9907 trial is the best, wherein neoadjuvant chemotherapy. And there are a lot of other trials like POET, in which POET, Swedish trial, and Australian phase 2 trial, wherein they have shown that there's not much of a difference. But then Vinita is just going to get angry, and tomorrow I'm going to have it from her. So I would rather say that neoadjuvant chemoradiation is definitely, Dr. Vinita, I'm again saying that neoadjuvant chemoradiation is.
So neoadjuvant CTRT gives you an additional advantage over neoadjuvant chemotherapy, and that is in terms of getting the R0 resection margins, is what I wanted
and
to
the complete pathological responses.
Yes,
correct,
yes.
Correct.
Your comment is
We will accept that and end this session. Wonderful session. Thank you very much for having us.
Thank you, sir.
over.
Thank you, sir. Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you, everyone.
We'll go to next panel.
Is Dr. Deepak there?
Hi, audible.
So we allow Dr. Deepak Chhabra moderating the panel, and so we invite him for this wonderful panel on the rectal cancer, and you invite your panelist, and it's all yours now.
Thank you so much, Dr. Kothari. And am I audible well?
Yes.
Yes.
All right. So let me quickly share my screen. All right. Is my screen visible?
Yeah.
Yes.
All right. Thank you so much. And I think, first of all, at the outset, let me just thank Dr. Viraj and Dr. Kothari for having us this virtual conference here this time. And I would quickly invite all my panels. Of course, Dr. Jagdish Kothari tops the list there. Dr. Ramakrishnan, Dr. Venkatesh, Dr. Veena Engineer, Dr. Basu, Dr. Goyal, Dr. KVVN Raju, and Dr. Sayan Paul. I saw in the participant list that most of were there. I'm not too sure if Venkatesh has joined in. Is Venkatesh there?
Hi, I'm here.
Hi, Venkatesh. So nice to see you again. All right. So thank you. At the outset, from what I see on my panel is Viraj has very confidently put 4 surgical oncologists, 3 radiation oncologists, and just 1 medical. I think it sums up all as to what is happening with the rectal cancer, and rightly so, he's kept it at the bottom of the panel because we are dealing with the bottom, isn't it? So thank you, Viraj. Once again, I was there last year with the second mid-year Gastro-Intestinal Conference there, and this time during these times we are with the virtual conference. I think times are changing, and we don't know what all changes we see. But then if I have to see these changes, this is the change that I would see in the rectal malignancy. That we way back in 1985, we started with the surgery, and then came a concept of that adjuvant chemoradiation therapy improves outcome versus surgery alone. We then had even consensus where adjuvant chemoradiation therapy became the standard of care in locally advanced rectal cancers. Then over a period of time in the next decade, we had the Dutch TME, which showed that neoadjuvant radiation treatment improves the local regional recurrence versus compared to surgery alone. We had the German rectal NSABP protocols coming in, where neoadjuvant chemoradiation therapy versus adjuvant became the standard of care, which is probably being followed till date. We also had the NSABP R04 capecitabine trial, which was shown as non-inferior to 5-FU with the advent of the capecitabines. Addition of oxaliplatin showed no benefit. Nowadays, we are also giving oxaliplatin in addition to the capecitabine as CAPOX, and slowly we are progressing towards the total neoadjuvant therapy approach. So I think change is only a matter of time. We are seeing with these virtual conferences. So my quick question to the surgical colleagues, I will start with the surgical colleagues and slowly move on to the other panelists as well. Dr. Kothari, the most important aspects that you would want to deal in a localized rectal cancer? We will restrict ourselves to localized. We will just dwell upon a little bit of metastatic disease, and I'll come to that in a little context, but quickly.
So to subset immediately my T stage of the disease and the location of the tumor. The sphincter, nowadays I'm more and more concerned about the external sphincter, because the whole goal, more and more patients for the sphincter preservation. It really doesn't matter now the digital distance from the anal verge. This is which is most important. And then of course the non-regional nodes, as you said. So regional nodes. This is what is most important for me, to have a clear-cut imaging available by the detailed MRI, because it has a lot of implications of my ultimate planning of surgery and delivering of the surgeries, which I can allude on to as we move on.
Right. So a distance from the anal verge, as Dr. Kothari rightly pointed out, is the preservation of the sphincter, and especially is more concerned in today's era about the external sphincter, because we know we can compromise the internal sphincter at some point of time by doing intersphincteric dissections. And of course, the threatened CRM. I think this is the biggest challenge, and where the entire concept of the neoadjuvant therapies have started coming in with understanding of more and more of this pathology by way of MRI evaluation. Now, Dr. Venki, if somebody just has to send you a WhatsApp of this particular image, telling you that, look, my father has been diagnosed with a malignancy and the biopsy is positive for cancer, and this is the only image that I have. What is your quick comment on this, Dr. Venkatesh?
No comment, because I would ask him, to see. It's difficult depending on it depends on the quality of the MRI one who's reported it.
Right.
So to make a decision based on that would be very challenging. So ideally, you would want a full report or the images to look at.
Right.
Second, ideally we should get it. You can only give broad terms, saying, okay, the first question people are going to mostly ask is, sir, this is what has happened. What should we do?
Correct. So I'm asking you, what should you do? Okay, this is the only thing. And just a quick, we don't want an absolute appropriate academic thing there, but on the quick look of this particular scan, what do you think is the most appropriate diagnosis for this? And what do you think you may think in terms of?
I have no idea, Dr. Deepak, really.
Okay,
you've shown me an image, so I can't make a call with what is shown. I need to, it's a lowish mid rectal tumor, I would have thought. And I need a clinical examination. I need a proper staging, which the radiologist has to do, whom you work with. And ideally, this should go on to an NDT so that we can.
All right. So now, exactly as what Dr. Venkatesh was trying to point out, that he needs more imaging. And I think that is the correct answer that I was expecting, that what you need is you need a definite MR imaging. And of course, backed by a thorough clinical examination and a digital rectal examination, as Dr. Kothari had pointed out, that we have to look at the distance. And when we check the distance, we are talking about the distance from the anal verge, dividing, as what Dr. Venkatesh tried to point out, that this is looking like to be a middle third. We are looking at the T staging, we are looking at the anal complex, we are looking at the end staging, a rough category on the MRI, we're looking at the circumferential margins, and maybe a quick comment on the extramural vascular invasion. All right, so let's come to this distance. Dr. Anand, lower, middle, upper 1/3. I'm a little confused because when you see this, somebody says it's less than 5. The Europeans say something else. The Japanese say something else. The Americans say something else. What's your cutoff? What would you label this low, middle, and upper third as? Is Dr. Ramakrishnan there? Okay, Dr. Raju?
Yeah, we take into account where is the level of the peritoneal reflection, and then the distal limit is where is the proximal limit of the sphincters. That is more important than the anal verge, because that would define and then we divide into 3 segments, the upper, middle, and lower, because that will be therapeutic implications in terms of our decision making.
So you said peritoneal reflection. Dr. Kothari?
Yeah, so peritoneal reflection is number 1, and number 2, the sphincter. These are 2 important anatomical landmark which I am seeing. Okay. Besides, various ways we put this 5, 10, and 15. Every report that you read, endoscopists would say something which is 6 centimeter, and the MR would say either it is 8 centimeter or 4 centimeters, and digital rectal says something else. So it is imaging.
Confusion for me always has been never a problem with the low rectal cancers. I think the confusion has always been those upper middle, those upper rectal cancers, and where are the rectosigmoid cancers. I think there is the confusion which I am generally confused about, where the patient comes for an opinion from some other center saying that it's a mid rectal. When you evaluate, you feel it's an upper rectal, and when somebody comes with an upper rectal and you feel it's a rectosigmoid, I think generally we don't have a problem with the lower rectal tumors. We generally have the problem with mid and this thing. This is exactly what I was trying to show the initial image. Where my radiologist always gives me a particular line, this particular line which tells me that this particular goes from the pubic symphysis to the sacral promontory, and anything below that is the rectum. Is that the way, Dr. Venkatesh? Is it how it's practiced at your institution? Yes and no? Or no?
It's variable. To be very honest, that's the challenge we have.
What is the variation?
Depending on which radiologist looks at it. So I think distance from the anal edge is important. And the question, as you rightly said, the challenge whether it's rectosigmoid, upper rectal, who needs to go for chemo, that's where our confusion comes. I agree with you.
Right. So I think if you have to see in our centers, what initially used to happen is that anything which is above this particular line was termed as rectosigmoid. Whatever is below this line is termed as rectal cancers, whether you label it as upper, middle, or lower. But if you actually see, this is what is decided, that if you go by a straight line that you would otherwise go in a rigid sigmoidoscopy, I think if you look at this comfortably, 34 millimeters, 70 millimeters, another 20 millimeters, and then you are at the highest level of tumors at 60 millimeters. So 3 plus 7, 10 plus 2, 12, and plus about 6, that means almost about 18 centimeters. I really don't know, because if you draw a line from here to here, a tumor which is at 18 centimeters, would it really get into being called as a rectal cancer is always my confusion. And that is why there has been this beautiful article in the Annals in 2019. As Dr. Raju was trying to point out, one of the points here is anterior peritoneal reflection. So what is the definition of rectum? They asked a big panel of surgeons across various centers. Somebody described as a third valve of Houston at endoscopy, somebody described as the sigmoid mesocolon and rectum reflection, somebody described as anterior peritoneal, somebody described as less than 20, less than 16, less than 15, less than 12, sacral promontory. So I think these are multiple, and finally we come down to a conclusion as to what is the rectum. So ultimately they gave a beautiful analysis of what is the rectum, and that rectum is anything which is below the sigmoid takeoff. So this is the rectum, and you have drawn a line where by MRI you can characteristically demonstrate the superior rectal artery, the sacrum, the rectum, everything. You demonstrate the peritoneal reflection, and finally you land into the start of the U-shaped mesentery, and this start of the U-shaped mesentery is actually all of this below this is the rectum, and all of this above is a rectum. So if you have a tumor here, like what we had in our situation, if you compare this, and if I have to actually give you a comparison of all what it was happened in my patient, this is equally comparable. So I would label this tumor as a rectosigmoid rather than primarily a rectal malignancy. And believe me, I actually took this patient for an upfront surgery. The tumor was way high above the urinary bladder as well as the peritoneal reflection, which was otherwise labeled for a definitive CT-RT at some other institution. Anyways, coming back to this particular thing there, we did discuss about that circumferential resection margin. Do we have Dr. Venkatesh now joining us?
Yeah, I'm here.
Dr. Anand, sorry. Anand, are you there?
I am Ramakrishnan, not Anand.
Hello. Yes, Anand, I can see you. Ramakrishnan, I can see you, but I don't think we are able to hear you well.
Am I audible now?
Yes.
Yeah.
Right. Give me your inputs about how important is the CRM to you as a surgeon.
It is next to EMVI, it is probably the single most important factor that is going to determine the need for neoadjuvant treatment and what sort of neoadjuvant treatment the patient is going to require.
Correct.
And also the type of surgery that I'm going to plan after completion of neoadjuvant treatment, whether I'm going to stick to a TME.
Do you always have your radiologist defining the EMVIs and the tumoral deposits on the mesorectal fascia? EMVI
Yes.
Always? Yes.
Yes,
I think
always.
that's what the protocol is, that every person who's dealing with rectal malignancy, be it the medical oncologist, surgical oncologist, we must have the radiation radiologist guy to demonstrate to us what is the EMVI. And I think we need to sit more and more with the radiology colleagues. I believe that there were times where our understanding of MRIs were much more inferior than the CT scans. But I think for the rectums, we are able to read MRIs better than the CT scans. So let me quickly come to the case discussion. We have a male who is 48 years with no comorbidities, chronic smoker, 5 to 6 cigarettes per day for the last 20 years. He quit about 3 years ago. He had 2 sons. The younger one expired in November 2016 to a relapse of T-cell ALL. He wishes for having another child. He's just about 48. January 2017 comes with a bleeding PR for 5-month duration. He's been treated outside as hemorrhoids as usual, a little bit of treatment delay. Good performance status, good weight, anal sphincter total normal on digital rectal examination, posterior rectal wall growth starting at about 4 centimeters from anal word. He had a colonoscopy, CT scan of the chest, abdomen, and pelvis. And now, of course, this is the colonoscopy report. We, for the sake of keeping the discussion limited to the rectal malignancy, I would get these polyps out of this particular image. It may have implications later on. But as for a discussion, we will just keep this right now that he's got a rectal growth. He's got multiple polyps in the MDI image, which is limited to the rectal proximal to the tumor. He's got some polyps, which is there in the transverse colon, 1 polyp, and cecal shows at least about 2 polyps. But the rest of the colon doesn't show too many polyps, but yes, limited segments do show polyps here. The biopsy report is a moderately differentiated carcinoma showing muscle invasion here. Colonic polyps are showing mild atypia. These are typical adenomatous polyps. Next best evaluation, Dr. Raju.
We need to get a good MRI of the pelvis.
All right.
Because that will give us the evaluation regarding the T stage,
correct,
the CRM, and the other things, the EMVI and other things.
Right. So you have these representative images in front of you. You have the distance from the verge over here, which is roughly about corresponding to I would say 3.8 or something. You have one lymph node which is shown in the right internal iliac area. You've got some perirectal nodes over here. The disease seems to be a little bulky, and you have a 6.00 mm invasion just at the right levator. So this is the image. My radiologist has this habit of putting this line over here, but then we go in for these distance measurement, and this is the final reporting that the lesion shows extension through the muscularis propria around the right lateral wall at 6 o'clock and 9 o'clock position for a 6 millimeters involving the right levator NI. Final impression, multiple perirectal nodes, enlarged lymph node at the right internal iliac region. Any other imaging needed, Dr. Kothari? PET scan or any other imaging that you feel is necessary?
So I need to evaluate the thorax and upper abdomen, certainly.
Correct. So he already had a CT scan, as I said, colonoscopy and CT scan of the chest, abdomen, and pelvis. The CT scan was clear, so he's negative for anything else suspicious on the scans.
So in terms of imaging, PET CT, no, I don't think if I'm comfortable with the imaging done, and no other suspicion on anything, if CA is abnormally high and if I want to look at it. Otherwise, no, I'm very comfortable with
Dr. Venkatesh?
Yeah, normally I'm happy with that.
You're happy with that. Okay. Yeah. So let's quickly go to these NCCN guidelines. Very categorically for all our postgraduates and the youngsters who are in the group, PET CT scan is not an indication unless and until you find that there are some unequivocal findings which are on the contrast enhanced CT scan, in which situation you would want to evaluate with the PET CT scan. Of course. Now, what's the next line of treatment? Let me quickly come to Sumit, Dr. Goel. As a medical oncologist,
Yes, sir.
Let me ask you, when you have this particular patient being referred to you by a surgeon, say for example, you are the only surgeon there, you don't have a radiation center in your institute, and you are the medical oncologist who's been involved into the meeting. So what is your take on this? What should this patient do? Should this patient go for an upfront surgery? Would you want to go for a neoadjuvant chemotherapy only? Would you want to refer this patient for a CTRT?
See, my thoughts when I see this patient is he's got a bulky disease, and the CRM is probably involved, as you said.
Right. Okay.
So definitely he's willing for another child. That is important for me. So right. I would definitely like to ask him to go for this thing. But I will discuss with my surgeons.
You would want to go for what? Sorry, I didn't get that.
I want to discuss with my surgeons. What will their plan be? Will they?
Dr. Jagdish Kothari says I can operate this guy.
Oh, but if in bulky disease, threatened this thing, I would like to be little aggressive. Probably.
Okay. All right. So I will tell you that now you have Dr. Anand Ramakrishnan as your surgeon. Discuss with Dr. Anand and then come back to me with the question.
Okay. So so my thing will be at what time point he would like to go for surgery.
Okay, Dr. Anand, what is your take on this? Dr. Sumit is asking you a question.
Dr. Sumit, of course, this patient has an operable cancer, but okay. I would probably rediscuss this image with the radiologist because this doesn't look to me to be a bulky tumor. This
okay.
T3D, as reported in the MRI scan, T3D N1 probably. There is a report of involvement of the mesorectal fascia at the level of the levators, which again I will take with a pinch of salt because images are not fully shown here. But and let us assume that the mesorectal fascia is involved at the level of the levators, in which case I would prefer to have a neoadjuvant treatment for this patient. Neoadjuvant radiation, because neoadjuvant chemotherapy alone has not been proven to be of use in cancers at the moment. So I would prefer a long course neoadjuvant treatment for this patient.
Okay, Dr. Anand, since you're already there in the question, and suppose if you have discussed with your radiologist with a questionable situation of the involvement of the CRM, would you want to do an endorectal ultrasound to evaluate this? Have you ever attempted that? Have you ever sent any of your patients for endorectal ultrasounds? How would you evaluate further?
I have sent patients for endorectal ultrasound, but I will not send this patient for an endorectal ultrasound.
Okay.
I will use endorectal ultrasound only if I am planning for a local excision. This patient is not a candidate for a local excision.
Point well taken for all those youngsters. Dr. Anand has made a very valid point that endorectal ultrasound is not an indication when you're already seeing a T3 level tumor, except for T1, T2. When you're planning for a local resection, you don't need an endorectal ultrasound. So coming to this, Dr. Anand has also made a very important point that he would want to send this patient for a CTRT. Now, let me quickly come to our the NCCN guidelines now. And this is always, when you have choices, you are always spoiled for choices. Somebody makes you spoiled for choices. And then you have a situation when you have to select between the choices. So now I'm being given a situation where I am being told that you have either the option of a chemoradiation, which is a long course. I either have an option of chemotherapy for going for 12 to 15 weeks, FOLFOX preferred, CAPOX preferred. Now I really don't understand. A preference is always to one rather than both of them. So I really don't know why do they write FOLFOX preferred or CAPOX preferred. The third thing is a short course RT followed by 12 to 16 weeks. Dr. Engineer, now this patient has been sent by Dr. Ramakrishnan to you because he's discussed with the medical oncologist and he feels that it needs to go for a neoadjuvant chemoradiation kind of protocol. What is your take? What would you want to give to this patient? Would you send this patient back to the medical oncologist saying that chemotherapy only, or would you want to give radiation?
So now with this recent Rapido trial coming in, now it says that short course RT with 6 cycles of chemotherapy is superior where the superior where the disease-free survival is concerned. So definitely this is coming up as a better modality than a long course chemoradiation.
So I will come back to you. There have been this NCCN very quick note written there that evaluation for short course RT should be in a multidisciplinary setting with a discussion of the need for downstaging and possibility of long-term toxicity. Short course RT is not recommended for low-lying tumors less than 5 centimeters from anal word. So we are dealing with this, which is about 3.8 or 4 centimeters from anal word. Dr. Basu, your quick comment on this.
So my choice would be chemoradiation treatment.
Correct. Okay.
Because we need to await for the long-term results of the Rapido trial. And if the patient got a good response to the treatment, then if the patient is willing for the more conservative approaches, then we can consider at that stage. So I want to evaluate the response based upon the chemoradiation response.
Yes, I will come back to you on this. I will come back to you on this. Dr. Sain,
one more point I would like to say is that at this juncture at TMH also, we would prefer long course chemoradiation. Particularly as a radiation oncologist, I'm more interested if this lateral pelvic node is looking ugly, it is more than 7 millimeter in size. So then this has very much chances of to be positive. And as a radiation oncologist, I tweak my doses, and I kind of escalate the dose to this node. And most of the times, we have been doing as a protocol now, and then most of the time it's like 95% it's getting sterilized by my higher doses. So there's no need of lateral lymph node dissection, which is or even if they do lateral lymph node dissection, it's coming negative. So it's one of my areas of interest.
So 7 millimeters is your cutoff, correct? As per the
Japanese 7
millimeters. What if it is 6 millimeters?
Yeah, and post radiation if it's more than 5 millimeters. So both.
So what if it is pre-radiation 6 millimeters?
But then you have to go not only by the size is always on the SAD. You have to look at the heterogeneity and also the hilum. So all three features have to fit in. So if there's only 2 out of 3, then it is suspicious.
I take that point, very, very valid. So, what about this? Is Dr. Basu there? Dr. Basu, Rinanjan, is he there?
So,
he is there.
Yeah, am I audible?
Yes, yes, you are.
Yeah.
Yes. Okay, your comment on taking it forward from what Dr. Engineer mentioned. So long course preoperative chemoradiation versus consolidation for clinically fixed T3 rectal cancers.
So mostly, yeah, we are also doing long course. Yeah, I am trained from there only from TMH, but I'd want to add a different aspect, because now with the COVID scenario, actually there's a task force from European Union, and they've given guideline where their long course, these T3 and lateral node would have otherwise recommended from long course CRT. But now they have also started giving an option of doing short course, keeping the current scenario. And this scenario is going to be long as well. So it is a call which maybe we could answer by doing it. There will not be any perfect scenario, I would say.
Right.
Though we are comfortable doing long course as of now also, but the scenario has really changed from what it used to be.
Yeah, so even if whatever the Europeans may say, if I have to look at these figures of overall survival and disease-free survival, I think we are just making a.
There's no difference, yeah. In the Polish too, there's no difference.
If you see this curve, there is absolutely no difference. So I really don't know whether we should actually really talk about these pandemic times. We'll keep that thing out as for the moment. We will just stick to the routine this thing. But yes, superiority of pre-op short course has not been demonstrated. That is for sure. And as Dr. Reena Engineer did mention, that we are also looking at publications from the Rapido and maybe the Stellar trials, which will come in and will give on more information. And I may quickly touch upon that. A quick comment, Dr. Sayan Paul, Stockholm trial.
Yeah, actually, for the last scenario, I will not go for a short course thing, because there are 3 issues. One is it is low lying, only 4 centimeter. So I don't know whether the surgeon will agree or not. There is a chance of ultra low resection also, ultra low LAR, if it is possible. Second thing is there is an internal iliac node which is threatening the CRM. So we need the margin. So in that case, I think the concurrent chemoradiotherapy will be ideal for that patient.
Right. So quickly getting on to the Stockholm trial, this generally after neoadjuvant therapy, patients with complete tumor regression or pathological graded response have significantly better survival. Of course, this has been given by these trial as a big highlight, and 5x5 gray with delayed surgeries induces more tumor regression and pathological complete response rate compared to the 25x2 grays is what Dr. Engineer was also trying to point out. And taking forward that, this with delayed surgery means that there is a delay to the surgery, and what do you do during this delay? And that is what the Rapido trial is trying to answer, that what do you do during this delay? Instead of having just a delayed surgery, you add chemotherapy for 5 months to these experimental arm and getting into the surgery. And what this has actually tried to show, and I'll quickly summarize this, that this data has been presented in the international ASCO meeting, which is just concluded on the 2nd of June, and it was performed as a virtual platform because of these pandemic times. So if you look at these short course therapy followed by chemotherapy, which is either 6-Kpox or 9-FOLFOX4, followed by TME versus the standard arm of long course. You see the safety analysis, you had about 901 patients equally divided. You see the surgery analysis, you have 92% going for surgery in the short course arm and you have 88% going in the long course arm. I don't have data of why certain people were skipped out. If you see pathology analysis was available for 423 out of 426 patients and 398 out of 400 patients on the standard arm over here. What you see is a big rate comparison, a significantly big difference in the pathological complete response rate following a short course therapy. If you have to see the disease related treatment failure is definitely lesser compared to the standard, not reaching significance. Distant metastasis is lesser. Loco-regional failure is slightly more in the short course therapy, and that is also what Dr. Engineer was trying to hint at. But if you see the grade 3 toxicity, as what Dr. Sain Paul tried to point out, you have a 4.3% toxicity of neurological toxicity, which is comparable to just 0.2% in the long course, 8.5% of vascular toxicity compared to 4.1%, and 17.6% diarrhea compared to 9.3%. So I think though they have given a final conclusion that combination of short course radiotherapy followed by neoadjuvant for patients with locally advanced rectal cancer resulted in more patients with complete response and less tumor recurrence with comparative toxic tolerability. With this data, Dr. Kothari, would you still think that we should advocate the Rapido trial into our armamentarium?
So, you know, it is interesting to look at this data, and certainly I think we have used consolidation chemotherapy for our patients, not exactly like a short course, but even in long course, when we have decided to wait. Now we wait more than 8 weeks in many patients, up to 12 weeks, and we do use this consolidation therapy. So for non-bulky disease, I think I am now tempted to consider short course treatment, and then of course giving consolidation chemotherapy for sure. So considering Rapido in some situations.
Dr.
Yes.
Venkatesh, your quick comments on this?
Sir, if I may add, sir?
Yes, please.
Yeah, sir, we are giving short course radiation chemotherapy with long delay. And during that long delay, we are using FOLFOX as a standard regime. We use it for 2 to 3 months. So we are giving 4 to 6 cycles before taking off a surgery. And if the study you showed, sir, the neurotoxicity and the diarrhea, if you compare, if you add both the pre and the post, it comes out to be equal. And the diarrhea part, in our experience, though it is very few patients, it's about 50 patients, the diarrhea is usually there in the first 2 cycles. After that, it is very well tolerated. And so far, our experience has been good. But adding to the short course followed by the addition of chemotherapy, definitely it has added to the value. We can see it has reduced the distant metastasis free. That advantage is definitely there. So we cannot overlook that also.
Okay,
so,
Dr. Engineer, do we have some data at TMH as to what is the advantage of addition of chemotherapy, something similar on similar lines of the Rapido? That as Dr. Goel mentioned, that they've not been giving chemotherapy for 5 months, just about 2 months, maybe that the 8-week delay is also taken care of. So something in the interim before getting into surgery. Have you all been giving anything even after a long course treatment?
So no, after a long course treatment, we have been giving consolidation chemo only to the poor responders. So we have not done it in the systematic manner that way. And we also compared short course RT with 2 cycles of chemotherapy as a part of IEA international trial compared with the long course, and we did not find any difference between the 2 arms. No.
And what was the chemotherapy arm that was used? You said
it was only because there were 10, like many African countries were also participating, and they did not have oxaliplatin. So we used only 2 cycles of capecitabine because it was supposed to be a resource sparing treatment.
Correct.
So
Okay.
that's why, but there was no difference. But I think this difference has six cycles of chemotherapy has made a difference in distance metastatic rate.
Yes.
So Deepak, can I make a comment on this?
Please.
Yeah, in the RAPIDO trial has shown that the PCR rates have improved.
Correct.
But if you look at the survival data, they haven't changed.
That's correct.
Yes, exactly. The survival data will not change because we have metastatectomy to offer. So disease-free survival is a very good endpoint, and it has shown. So chemotherapy has affected. So overall survival, we don't expect a change.
So I have one question, Reena madam. I have one question.
Yeah.
That is that how do you decide about chemotherapy? There are few cases where it is quite obvious that this patient will require chemotherapy. Normally in rectum, post-op pathology dictates the need of chemotherapy. And here, then which patients we exclude for this?
So I will come back to this
In
question of your
Rapido trial, only locally advanced CRM positive or threatened patients were taken.
Okay,
So all these patients were anyway required. And the
Dr. Paul,
majority of them were N2 disease.
We will come to addressing the options of the adjuvant treatment as well. So there have been quite a bit of studies which have evaluated the role of total neoadjuvant therapies, and including chemotherapies as well as chemoradiations to that particular center. I will not go into details. Dr. Goel, quickly, the rationale of TNT, that is total neoadjuvant chemotherapy. That is, we are now trying to exclude radiation. Now, there have been a number of issues which have been happening. What is your view? There have been views that,
Definitely, my views are, sir, definitely TNT, apart from, we know controlling the local, it is controlling the micrometastatic disease systemically. It also helps in downstaging and improving the sphincter sparing surgery, almost to the tune of 2 times as compared to the chemoradiation arm in all the studies. And the people who were likely to benefit are people who were threatened after resection also, where the possibility of positivity is likely to be high, but who have high nodal positivity, like the bulky nodal disease is there.
So Dr. Ramakrishnan, let me just interrupt you. Dr. Anand Ramakrishnan, your quick comment. He did mention about sphincter sparing surgery after downstaging. Give me a quick comment on that. How many cases do you feel that the chemotherapy actually downstages to an extent that you have been able to preserve the sphincter? Do you still go by the original digital rectal examination to verify intra-op frozen sections? How do you decide that?
So to date, there is no evidence that giving chemotherapy pre-operatively actually improves the sphincter preservation rate. And in fact, there is a meta-analysis done by a radiation oncologist, Bucco, who has actually said that it is not the radiation that is adding to the sphincter preservation. It is more the skill of the surgeon and the advancements in sphincter preserving techniques that have added to sphincter preservation rates.
I think Dr. Ramakrishnan has made a very, very valid point. I think we must remember that every institute is not the same, and every institute doesn't have a skilled surgeon like Dr. Ramakrishnan. I think the surgical skill is very, very important. Please continue.
Yeah, so definitely chemoradiation does help a little bit in sphincter preserving surgery, not by shrinking the tumor from the distance from the anal verge, but shrinking it circumferentially. So today we are at a point where the distance from the anal verge is not so relevant in making a decision on sphincter preserving surgery. So it's not how low a tumor goes that decides on sphincter preserving surgery, rather it's how deep a tumor goes. So as long as you're able to achieve a negative circumferential margin, you can do a sphincter preserving surgery in most of the patients.
Right.
And
so
if I may just add a point on total neoadjuvant treatment, I think the terminology itself is a misnomer, because most of the studies that have reported on using preoperative chemotherapy have not used the complete quota of chemotherapy cycles. They are what you would call a partial neoadjuvant therapy, because all of them have stopped with 3 to 4 cycles of chemotherapy.
Yes, so
very rarely have anybody used a complete quota of chemotherapy.
So we have something which is coming up. Anybody knowing this? What is this? NAR divided by 9.61.
NAR is the neoadjuvant rectal score, which is something that is used to calculate the prognosis of rectal cancers based on the response to treatment.
Correct. So based on the response, so these are the neoadjuvant rectal scores, and there is too much of mathematics involved into this. I will not go into details, but then there are a lot of things which are coming as far as the domain of the medical oncologist is concerned, and where Dr. Ramakrishnan was talking about the concept and the misnomer. And this is where the TNT trial possibly may answer his questions, where you are giving FOLFOX into 8 cycles, followed by radiation along with capecitabine and surgery. There is also veliparib and pembrolizumab. I'm not sure of where we are going and whether all my surgeons would agree with all of this. But then, of course, there is a big scope for all these trials. Let's not dwell into this. There are trials which are selectively excluding out radiation therapy. So I think Reena, Trinanjan, and Sayan Paul are also trying to be kept out, including the surgeons. And this is exactly what Dr. Ramakrishnan was trying to point out, that none of the trials have been based with the fact that you have given a complete course of treatment. And I think this is what the prospect schema is based on, where you have randomized patients to a standard arm who are receiving the regular chemoradiation with 5-FU, whichever base, then going for surgery, and then going for adjuvant chemo as per the primary MD, versus giving them FOLFOX6. And after a FOLFOX6 course, that means you complete the chemotherapy and you check for responses. And if you have a response which is more than 20%, you take these patients for surgery and go as per the adjuvant chemos as per protocols. Or if you don't have a response more than 20%, you're definitely less than 20%, you go ahead and complete even the radiation, get into surgery. Now, I think it is a big thing that is going to happen. I'm not sure of what the results are as of
but
now.
I can add into it.
Please, Dr.
The case selection is only for mid and upper rectal cancers. I think majority mid, and they are not CRM threatened or involved.
Absolutely.
So the message has to go across that, yeah.
I was just coming to that one has to, they are also trying to keep the surgeons out, whereas because the problems generally are for the lower rectums, and the mid and upper rectums are basically more of surgical domains, and they are trying to push the surgeons all to the end towards the wall, that yes, if now you don't have an option, now this is a surgery, whereas at some point of time surgery was considered as the backbone for all the solid cancers in the body. All right. So I am also a little confused that when we are talking about all these trials and neoadjuvant based on the fact that there is micrometastatic disease, there is local recurrence, there is distal recurrence, what is the pattern of disease recurrence? Dr. Kothari, what do you generally see as recurrent disease? Is it more of local recurrence that is it more of distant recurrence that you see?
So about 5% is local recurrence. About 5% is the metastatic disease in the lung. Right. And other recurrences would occur anywhere in the abdomen. So it could be lymph node or liver metastatic disease or in the peritoneum.
Dr. Venkatesh, is that the same with your center or your experience? I think Dr. Venkatesh.
Right. Can I add into it? The pattern of recurrence actually depends on the location of the tumor and all the pre-op features like EMVI and nodal positivity and 2 nodes and all.
Right.
So typically, if it's a T4B tumor, it is this thing that the local recurrences would be high to the tune of 8 to 12%. It can go.
Do you have any data to support that, Dr.
Yes,
Engineer?
Yes, definitely. Even in the Rapido, the pattern of recurrences are coming the same. And if there's a EMVI positive and it's a more of a mid and upper rectal tumor, and the node positivity, the N2 nodal status pre-RT or pre-neoadjuvant therapy decides the outcome. And so the distant metastatic rate goes from 30 to 35% in these cases. So it's always, it is correlated, and also the pathology, the differentiation, it matters. Where the pattern of
lot of factors, not a single factor. So I think surgical skills, the pathological scorings, the pathological complete responsiveness, the biological aggressiveness of the tumor, the threatened CRMs, the EMVI, I think a lot of factors. So we can't pinpoint any particular thing there. Dr.
So
Raju,
can I add?
Yes, please.
I think we may need to conclude in next 5 minutes. Dr.
Absolutely. I just have about 4 slides remaining. Yeah, Dr. Raju, do you have the similar kind of experience at your center as what Dr. Engineer has described?
I think I have nothing to add beyond what.
Okay, so if I have to look at some of the reported series, if you have to see the clinical patterns of recurrence disease, this is a patient. This is a series where you have 378 patients, and you have 17% of them relapse, but you have more metastatic disease than local recurrence. This is another 16-year study recently published in 2019 from the Canadian group. 188 patients, 53%, that is 28% relapse, but more local than metastatic. Now, I'm a little confused. At one place, there is more metastatic disease. At the other place, there is more local disease. Should I consider it is the caliber of surgeon in the end of it, which decides as to what is the overall outcome of a recurrent disease? And there is another article which says that you have, at a median follow-up of 2.06 years, 68 patients developed relapse, which is local, regional, distant both, and 69 patients died. Dr. Anand Ramakrishnan, your quick comments on this. What do you think is the factor? Do you feel that surgical skill at the back end of it is the most important?
It is partly important, but I don't think that is the reason for the differences that you're seeing in these papers. What we must remember is the kind of tumors that we see here in India is probably not the kind of tumors that they see in the Western world. We see more of the advanced, ugly-looking tumors, and they see more of the intermediate or the early tumors. In our own experience, we have quite a higher incidence of local recurrence than what is reported in most of the Western countries. And this is probably due to the fact that we often treat bulky tumors. Being a referral center, we treat bulky tumors. So I think this is going to be the experience probably by most of my other colleagues from India, that we do see a higher incidence of local recurrence than what is actually reported in the literature.
Right.
So there's no point in trying to hide that fact that we do see a lot of local recurrences.
Okay.
But at the same time, we also see a lot of distant metastasis as well, which is the reason why neoadjuvant chemotherapy is being pushed more and more.
Okay.
So Dr. Ramakrishna, are you trying to say that we are seeing local recurrence to the tune of 20-30%? Is that what you are trying to say?
Not 20-30%. See, most of the Western series report 5%, 6%. We are seeing close to 8 to 10%.
Okay.
So quickly going forward, the patient was counseled for sperm banking, genetic analysis. He received the typical of the neoadjuvant long course with capecitabine, grade 2 toxicity, reviewed after 6 weeks, nodularity at 4.5 centimeters from the anal word, sphincter tone good. Dr. Venkatesh, if you're there, quick one-line answer. What out of the 4? MRI pelvis only, MRI abdomen pelvis with CT chest again, MRI with PET CT, or CT scan abdomen pelvis contrast with lab staging? I think maybe his audio is not there, or we have lost him. Dr. Raju, your quick response to this?
Yeah, the clinical examination plus the MRI pelvis, that will be sufficient because it is less than 6 weeks. So I think that should be okay.
So I think this is one article from the Tata Memorial Group where they have given a beautiful discussion about how to restage, and the histology is very important. So on the basis of histology, with the poorly differentiated ones, they definitely talk about getting CT into the armamentarium. So now you have the post CT RT images. You see an absolute regressed kind of a lesion there. The previously mask noted in the rectum as resolved completely, no pelvic adenopathy now. Findings, lower edge of the rectum is 5.1 centimeter from the anal verge, and findings are still concerning of a neoplasm. 4.5 centimeters, good sphincter tone. I will skip this in the interest of time. We've already discussed that no endorectal ultrasound. What surgery? Dr. Raju, since you're on my screen, quickly, out of the first four options.
Now, regarding the polyps, should I
yeah, so now we take that polyps also into consideration, but yeah.
If the polyps are taken into consideration and we assume that it is due to one of the Lynch syndrome, then I would prefer to go for a total proctocolectomy with a diversion.
All right, Dr. Kothari.
So if I just ignore the polyp things at this stage, then ultra low ISR, minimally invasive way.
All right, so I'll just give you a quick update. This patient was not ready. He was counseled for the proctocolectomy, as Dr. Raju said. So both of y'all are correct from your point of view. Taking polyps into consideration, we need to go for a total proctocolectomy for this guy. IPAA versus permanent ileostomy is a choice and the skill dependent thing. Ultra low AR was the option for him because he did not agree for all of that. Timing, I think we have already dwelled on this less than 6 weeks, 6 to 8 weeks. Dr. Kothari had already mentioned that about 8 to 12 weeks. And we have a good, non-systematic, but a good literature review where available data suggests that at least 6 weeks, but by 12 weeks appears to be appropriate unless and until we have further studies that are available. Acceptable distant margin, Dr. Ramakrishnan, your quick view on this?
A very low rectal cancer, 5 millimeters negative distal margin with a frozen section coming negative is good enough for me.
5 millimeter, 0.5 mm?
5 millimeters.
5 millimeters. All right, Dr. Kothari?
Yeah. 5 millimeter and negative frozen section.
Right? Yes. So this is one of the editorial from one of our Indian journal, Sher-e-Kashmir Institute, where he's written a beautiful review and about the distal margin, about reviewing the entire data. And his final conclusion was oncologically safe DRM should be 1 centimeter for T1, T2, and 2 centimeters for T3, T4. DRM of less than 1 centimeter does not seem to be adverse effect, but I think slowly we are coming down to, as what Dr. Ramakrishnan and what Dr. Jagdish Kothari have said, that even 5 millimeters negative margin, we have already made the field sterile, I think is easily acceptable. So the patient underwent a robotic assisted ultra-low intersphincteric resection, follow anal anastomosis. He did a diversion ileostomy, and we could use these retractors to kind of have this anastomosis. The final histopathology was TRG0, complete response, distal margin free, but then there is no tumor, no residual carcinoma. Now, Dr. Kothari, your quick views on this. No residual carcinoma. Suppose you had a situation where you have done whatever to prove. How would you prove? Which patient would you want to not operate? Which patient you would want to observe? What would you do to tell this patient that, look, I'm not going to operate?
So based on complete clinical response, you are talking about that scenario, right?
Right.
I need to discuss this, and we are talking about patients where you have to do permanent colostomy. Other than that, I don't give option of wait and watch.
Mm-hmm.
So if the option is only AP resection, then yes, and carefully counsel him, and very regular surveillance program, which will include everything, digital rectal examination to MRI to EUS, whatever is required for at least first 2 years. That's what I would say.
Dr. Ramakrishnan, what's your strategy? If you find that a complete clinical response, what's your strategy generally?
Yeah, now we are on a program where we offer intentional watch and wait option to the patient.
Okay.
And in those situations, we usually identify such patients who are likely to have a complete clinical response, and we add a radiation boost of around 6 to 9 gray over and above the standard dose of 50 gray. And we put them on 6 cycles of chemotherapy as well. We have had a publication in this aspect in 2013, and our individual pooled individual patient data has also been included in 2 of the largest meta-analysis on complete clinical response and watch and wait policy.
Right. So you are trying to tell me that non-operative management, but you the patient 6 cycles of chemotherapy.
Yes, that's correct.
All right. So do you have a situation where you've kept the patient only on a non-operative management and without chemotherapy? How is your data correlating with that? Have you tried to randomize that not giving anything after a complete clinical response versus this thing?
Our initial publication of nearly 23 patients, none of them received chemotherapy. It was just chemoradiation, complete response, and no surgery.
Right.
But of late, we've been adding consolidation chemotherapy once the patient achieves a complete clinical response.
Why did you think of shifting? Yes, please. Let me just quickly have this answer. Why did you think of continuing the chemotherapy? Did you find something in the non-operative management that you needed to add the chemotherapy recently?
No, it was not based because there's hardly any evidence except now that the OKRA trial has come up with the consolidation and the induction chemotherapy. But what we believe is that patients will be missing out on systemic treatment if we avoid chemotherapy. So that whether it actually helps in reducing the distant metastasis, we don't know.
Right. So
far
most of the trials, evidence.
most of the trials that have reported on non-operative management have not given chemotherapy, and the distant metastasis rates in those patients is just around 7 to 8%, which indicates that these patients who have a complete clinical response have a biologically favorable tumor, which leads to a very low incidence of distant metastasis.
So you do believe that despite having this clinical response, there is a role for completion chemotherapy?
At the moment, that is my view.
At the moment, yes, but we don't have strong evidence to support. Yes, Dr. Engineer, you were trying to say something.
Yeah, I fully support what Dr. Ramakrishnan said. So at Tata, we have around 65 patients now on the watch and wait policy, and our distant metastasis rate is around 10% only. So we don't see any value in adding chemotherapy, because chemotherapy, even if you say Capox, is not full, it is not completely safe, and why to subject patients who may not require. So our philosophy is right now till Dr. Habergamma, they are randomizing patients between consolidation chemo versus not. So till the data comes up, we are not going to change, but our policy is no chemotherapy till now.
So I'm actually, because if you see the adjuvant data trial, we have the 4 biggest randomized trials, or whatever we have till date, the EOR-CTC and the Italian, the Proctor script and the Chronicle. All of them do not show anything which is adding to the responses in the adjuvant setting. Of course, we are talking about a patient who has been operated, where all the tumor or the residual tumor disease has been removed, and we don't have adjuvant. But as you rightly said, that in patients who have not been operated, but we presume that they have a complete clinical response and they have a complete pathological response, is there really a role of this adjuvant therapy? I think it is only a trial based, and what you said, that maybe we will have light about a year or 2 down the line for all this. This was my last slide. And just to inform you that this patient was there in Dubai early last year in September. And this patient also had a second child, and he's very, very happy that he always wanted one. We could have a sphincter preservation for him. At the same point of time, we could give him the advance of the newer techniques and the robotic magnification for achieving a good nerve sparing surgery, because of which he did have his sexual functions intact, and he was very happy to have a second child. And with that, I would just want to thank all my panelists here, and thank you, Viraj and Dr. Kothari, for giving me such an esteemed panel who have been right to the point. I think full marks to everybody, and congratulations for a very well conducted virtual meet this time, Viraj.
Thank you, Deepak. Thank you so much. And thanks
you.
all the panelists.
Nice meeting you. Bye-bye.
Thanks. Nice.
Thank you. Thank you.
Thank you.
Sir, can you conclude, sir? Jagdeep, sir?
Yeah, so I think Viraj put in the show, which was exhaustive, but I think at the same time quite informative. Excellent panels, excellent moderation. So 5 panels and constant back-to-back discussion on so many real life situations. I think
500
plus. Oh, that's excellent. So it's all kudos to Dr. Viraj. Wonderful. And with that, I think we thank all the participants, not just the faculties, for staying by till so late. And I hope that it has added value to their clinical